है। सो जिनका भी केस प्रेजेंटेशन है, आई होप उनको केस का अलॉट हो गया था और उन्होंने प्रेजेंटेशन तैयार कर लिया है। थायराइड पैनल में विल बी आस्किंग फॉर वॉलंटियर्स, बिकॉज पैनल का मतलब है कि टू वे टॉक हो, है ना। इट इज़ ऑलवेज गुड टू हैव अ टू वे टॉक, इट्स नॉट बिटवीन कि आई एम आस्किंग क्वेश्चन के निकल रहे हैं तो हमारा पर्पज सॉल्व हो जाता है। ठीक है, तो इट इज़ ऑलवेज गुड कि जब भी क्वेश्चन ख़त्म हो स्पीकर का टॉक, अगर टाइम है प्लीज आस्क क्वेश्चंस, और इन द टी ब्रेक प्लीज आस्क क्वेश्चन, हैव अ डिस्कशन अमंग योर सेल्फ। डोंट हैव अ डिस्कशन व्हेन द क्लास इज गोइंग ऑन, नो। बट जब क्लास ओवर हो जाए, जब जब सेशन खत्म हो जाए, तब प्लीज हैव अ डिस्कशन विद द स्पीकर। जो भी डाउट्स हैं प्लीज क्लियर योर डाउट्स, ठीक है। तो वो बहुत ज़रूरी है, जब तक टू वे डिस्कशन नहीं होगा, बिकॉज सारे मोस्टली एग्जाम गोइंग हो आप लोग, तो इट इज़ ऑलवेज गुड टू ग्रास्प। ठीक है, तो हमारा सेशन स्टार्ट होगा। We'll have sessions on multinodular goiter, hyperthyroidism, thyroid cancer, safe thyroidectomy. We'll have 15 minutes break for question and answer session, and I hope कि आप लोग क्वेश्चन आंसर पूछें, नहीं पूछेंगे तो मैं सवाल पूछूंगा सब लोगों से, ठीक है। एंड उसके अलावा उसके बाद ब्रेस्ट का रहेगा, ब्रेस्ट कैंसर पे रहेगा, लोकली एडवांस ब्रेस्ट पे रहेगा, ब्रेस्ट बिनाइन ब्रेस्ट डिजीज पे है। एंड देन वी हैव पैनल्स, यस, नेक डिसेक्शन पे है, एंड केस प्रेजेंटेशन एंड पैनल डिस्कशन। लास्टली हमारे पास कीमोपोर्ट की वर्कशॉप रहेगी 3 to 5 पे। तो विल बी हैविंग मैनिक्विन्स एंड कीमोपोर्ट्स, सो टू हैव अ हैंड्स ऑन एक्सपीरियंस कि एग्जैक्टली कैसे कीमोपोर्ट डाला जाता है और कैसे किया जाता है। सो ओके,
Good morning. So our first lecture for the day is approach to a case of multinodular goiter, and the speaker is Dr. Kulranjan sir. It's a privilege to introduce him. He is a dedicated clinician and an academician specializing in the intricate field of endocrine surgery. Currently, he is a professor in endocrine surgery, KGMC Lucknow. We welcome you, sir.
डॉक्टर रजत अभी इसी हुई नहीं है, तुमने प्रोफेसर पहले ही बना दिया यार, थैंक यू। तो ये गीतिका के लिए ज़रूरी नहीं कि आपका कुत्ता ही वफादार निकले, कभी कभी आपका वफादार भी कुत्ता निकल सकता है, ठीक है। नहीं मैम, ये पॉजिटिव सेंस में बोल रहा हूँ। व्हाट डॉक्टर गीतिका एक्सपेक्ट्स कि पहले मेडिटेशन करा के सबको सुला दिया जाए, फिर हेवी नाश्ता करा के एक बोरिंग सा टॉपिक, अप्रोच टू मल्टी नोडुलर गोइटर, एंड शी एक्सपेक्ट्स मी कि सबको जगा के रखूँ। Anyway, that's an important exam topic, and जो टॉपिक दिया गया था इट्स अप्रोच टू मल्टी नोडुलर गोइटर। थोड़ा सा इसमें चेंजेस भी रहते टू गोइटर और नोड्यूल और व्हाट्सोएवर, तो इट बीन अ लॉट ईजियर। मेरी प्रॉब्लम ये रहेगी कि इसके बाद पूजा मैम मेलिग्नेंसी डिस्कस कर लेंगे, कुशाग्र हाइपरथायरॉयडिज्म डिस्कस कर लेगा, तो मैं यहाँ पे बस कोविड वाला प्लेट बजाने के लिए आ गया हूँ। सपना तो मैं बहुत देखा था कि एट द एंड ऑफ दिस सेशन मैं यहाँ का हीरो बन के जाऊँगा, बट गोइंग बाय व्हाट इज हैपनिंग, माय विश विल नेवर बी फुलफिल्ड। So what's normally said, give a man a fish, you feed him for a day, teach a man how to fish, you feed him for a lifetime. This was true. However, with the current lot of residency और जैसे भी MCH में लोग आ रहे हैं, give a man a fish, he will eat for a day. Teach him how to fish and he'll sit in a boat and drink beer all day. So I'm probably going to fail, but as Kushag said, over these next 5 days, even if 15 to 20% of is taken back of what is taught over here, our job would be done. But this is the latest concept. Don't teach him to fish, teach him fish farming. This is more in terms of industrial development, but even in our normal जो modern medical curriculum है या teaching है, this is how things are approached in today's times. So what's a goiter? It's a clinically recognizable enlargement of the thyroid gland characterized by excessive growth and structural with or without functional transformation in one or several areas within the normal thyroid tissue. And radiologically, this should be distinct from the surrounding thyroid parenchyma. So that's the definition of a goiter. So what would be a multinodular goiter? It would be an enlarged thyroid gland containing multiple distinct nodules or lumps. The incidence or prevalence is variable in the sense that if you have to look for the prevalence of a multinodular goiter in an endemic region which is endemic for iodine deficiency, it can be as high as 25%. But if we are looking for multinodular goiter in the western population or in an iodine sufficient area, the incidence should be in single digits, probably less than 10%. If you have to perform or look for multinodular goiter in autopsy series, it can be as high as 50 to 60%. So, or even if you are likely to perform ultrasound in a general population, it will be in at least 30 to 40%. You will pick up multiple nodules. They may not be clinically palpable though. So, the incidence is high, but how many of them are clinically relevant? That is different. So, how does a multinodular goiter develop? You need a thyroid bed which is predisposed to some kind of external influence. So, it is a thyroid gland which is apparently normal, but it has some kind of abnormality which predisposes it to certain signals where nodules would start forming. So, it is an inherent polyclonal cells are there that would have different sensitivities to all these factors, which would be TSH, which could be iodine deficiency, which could be any external factor like nutritional deficiencies, which could be a goitrogen, and many more, which could be harmful ionizing radiations. And what would happen is usually a neoplasia or a malignant would start as a monoconal proliferation. But these benign goiters or multinodular goiters, usually in them there is a polyclonal proliferation, and each clone of cells would have differing sensitivity to the signals or the proactive signals. So, once the nodular proliferation occurs, some of them would outgrow the vascular supply, and in those nodules there would be hemorrhage and necrosis. Some would become inactive, the others would continue to grow, and then you have a stage of multinodular goiter. And ultimately what happens, some of these nodules can become autonomous. The TSH would cease to have control over them, and that is where you would see a case of a toxic multinodular goiter. So, just like any neoplasia, even a benign multinodular goiter, it is not one step but multiple steps, each happening one after another. So, what should be the clinical approach? Whenever we are approaching a case of thyroid nodule, we are trying to differentiate whether in the functional status, whether it is euthyroid, hypothyroid or a toxic, whether it is solitary or whether it is multinodular goiter or it is diffuse enlargement, and of course malignancy versus benign. Needless to say, all of you have to face exams. It's the same case of thyroid that is put for an MBBS candidate, for an MS candidate, and also for an MCH candidate. And believe you me, the questions start from the same level. What we look for is just your approach, and definitely at the level of MS, your approach should be more logical or more intellectual compared to that of an MBBS, and that is what we will try to get you to. So, most nodules are asymptomatic, and there is no clear-cut relationship to size and symptoms. So, what are the important parameters that we normally give importance to is the age, gender and geographical location. The incidence of malignancy is likely to be much higher in an pediatric goiter or those in elderly. Goiters are more common in women, but a male harboring a goiter is more likely to have it as a malignant one, and similarly the geographical location. So, our belt is endemic to goiters, and if you look for any specific areas which you can talk of in our country, the coastal regions, especially in Kerala, there they can be more predisposed to harmful ionizing radiations. The sands over there apparently has a higher content of thorium, and apparently the population is exposed to more radiation. Again, What you need to keep in mind is, it is the 8th edition which came out a few years ago. The WHO classification of goiter has changed. You need to update yourself on that. And also the ATA guidelines for thyroid nodule or DTC, that has been, our new edition has come out last year. So at the level of MS, you need to keep these 3 changes in mind. Even in the 8th edition of AJCC, the cutoff was increased from 45 to 55. I am not going to go into the details of WHO modifications, or I will not go into details of the changes in the ATA guidelines. I am sure Pooja ma'am would cover them partly. But what you need to remember is the recent change in voice is definitely pointed toward malignancy. If you have any lymphadenopathy and the lymph nodes are larger than a centimeter, or they have other features of malignancy, you are very likely dealing with a malignant goiter or a nodule. And of course, the rate of growth characteristics of thyroid swelling may be pointed towards malignancy, but even a PTC can be very slow growing, or even a benign goiter can grow very rapidly and grow despite suppression, though suppression is not normally given these days. It is definitely a poor clinical indicator. The consistency misleads, we need to keep that in mind. Goitrogens, once again, this is often a good question during, or a commonly asked questions during vivas. But why I tried to get this slide across is, though it is asked in theory, but practically it is not very important, because if you have to look at the list, it is one huge list where anything that we eat actually has some component of a goitrogen, right from, if you see, apples, peanuts and whatnot. Most of the vegetable products would have flavonoids, if not thiocyanates, and so they are potential goitrogens. But what you need to remember is, we don't take them in a quantity that they would serve as a goitrogen in a normal thyroid follicle. And also what you need to remember, cooking or any preservation of these foods actually destroys most of the goitrogens that are normally present. So for example, if you have to look at the Brassica family also, if you have to cook that cabbage, almost 90% of all the goitrogens in cabbage or all these vegetables are actually destroyed during the process of cooking. But what is again once important, not only dietary habits, but it is also industrial pollutants like perchlorates, which you will see in your bangle industry, sulfides in your mining industry, and all these deficiencies like severe iron deficiency. We all know that thyroid peroxidase is an heme containing enzyme. So if you have severe iron deficiency, that is also likely to serve as a goitrogens. So are selenium deficiency and also vitamin A deficiency. Family history, once again, you need to take that for completion, and a lot many syndromes are associated with goiter. Examination, I will definitely not go into the details. At the end of our history and examination, we have to form a clinical impression, and in the case of multinodular goiter, it could either be euthyroid, hypothyroid or toxic. What you need to remember, even a toxic a multinodular or seemingly multinodular goiter or a toxic STM could actually be a Graves' disease, or you also know that there could be a nodular Graves' disease. So what are the investigations? We normally ask for serum TSH. We are not wrong in asking T3, T4, TSH or free T4, T3, but you have to justify that in your exam. And if you look at the diagnostic algorithm, there is the presence of thyroid nodule, history and physical examination. Serum TSH is the first thing that you would do. If TSH is suppressed, the next part of the algorithm would take you to some kind of thyroid antibodies. To rule out Graves, you need to perform a thyroid stimulating antibodies. Thyroiditis can be ruled out by a serum anti-TPO. In case it is hypothyroid or normally euthyroid, you would subject them to some kind of imaging, and ultrasound is the most commonly performed imaging examination, and it is mandatory in a case of thyroid, and then based on the findings we will approach them further. So if you look at this algorithm, in today's times the role of thyroid scan is not as important as before. Serum thyroid receptor antibodies or stimulating antibodies, these are better diagnostic tool for making a diagnosis of Graves' disease. In case you don't have access to this, a thyroid scan is there, and you definitely don't have a role of thyroid scan for workup of a nodule or a multinode or a goiter, unless it is toxic and you want to rule out whether it's a unilateral disease or not. So if it is a toxic solitary thyroid nodule, definitely there is a role of a thyroid scan, so that for you to decide that it may, an hemithyroidectomy may suffice. So this history and examination, serum TSH, ultrasonography and cytology. In today's times, there is no role of upfront measurement of serum thyroglobulin, and there is no evidence to support the routine use of serum calcitonin in the evaluation of a thyroid nodule. But what you need to remember is, for medullary thyroid carcinomas, almost 55% of them are missed in the initial evaluation, or it is a post-operative diagnosis. So whether routine use of serum calcitonin is justified or not, in Europe and elsewhere they do use it, but the guidelines don't say that it has to be universal. So normally you perform imaging, it's an ultrasound, so you have lot many categorization system, your ACR or American College of Radiologists, RATA, Korean, French, or a Tata also has their own guidelines, and normally what you look for them is composition, echogenicity, shape, margin and echogenic foci. Once you use ultrasound routinely, you definitely memorize it. If not, you have online calculators in your mobile phones, you can just put these and then you will find the categorization. Based on the categorization, you would subject them to an FNAC or not. So if it is definitely benign, let's say if it is a spongiform nodule, you don't need to actually subject them to an FNAC also. But if it is highly suspicious or moderately suspicious, highly suspicious even for smaller nodules, you have to perform an FNAC even if it is about a centimeter large, but mildly suspicious, you do have a threshold which can guide it, FNAC also. Again, is there any rows of other things? Elastography is something where you look at the kind of the elastic properties of the thyroid nodule. It will definitely give us more information than a conventional ultrasound, or even if you look at these, this is the Korean TIRADS, American TIRADS, ADA, the French, and that is a TMC. So in our department also we wanted to study which of this actually performs better. So in a particular thyroid nodule, all these categories were put to use, and what we also found, addition of this, the Tata guidelines, which also have all these things apart from vascularity and the elastography, they performed better. So there is definitely some role of elastography, but it is not a standard of care, or it's not mandated by all the universal guidelines. You also need to know that of late there is something which is known as a contrast enhanced ultrasound. So you inject an contrast agent, which forms micro bubbles within the thyroid, and then you image the thyroid. So you can then again see the enhancement pattern of the thyroid nodule depending upon whether it is scattered, centripetal or centrifugal, whether it is hyper enhancing, hypo enhancing, present, or the ring enhancement is there or not, and then the composition. So this would again help you categorize, better categorize whether a nodule could potentially be malignant or not. So though it's costly, one dose of this dye costs almost 5,000. If you can use it on 3 patients. We have found clinical use of this, and in times to come this may again become more useful. What you need to remember is the FNAC is reported by the Bethesda system, and that would be categorized into non-diagnostic, benign, atypia, of undetermined significance, follicular neoplasm, suspicious for malignancy and malignant. They would have a range of estimated malignancy which could range from up to, in a malignant one, if you have a malignant diagnosis of on FNAC, you are almost 100% sure that you are dealing with a malignant case. But what you need to remember here is, there is a higher chances of malignancy in one where the FNAC is non-diagnostic. So most of the non-diagnostic FNAC, you should not subject them to upfront surgery. You should always try and repeat an FNAC or make use of what is given in your elastography or contrast enhanced ultrasound. So once again, here what we have done is, you have performed an ultrasound, then you have performed an FNAC based on the the size criteria, and then you have various reports which could be non-diagnostic, benign, AUS, follicular neoplasm, suspicious or malignant. Malignant, you need to operate in this ATP of undetermined significance of follicular neoplasm. There is a scope of molecular diagnostics which is picking up these days. So that I'll deal just a little later. Again, when we talk about the Bethesda classification, most of the time you would see that there is an estimated risk of malignancy. But in real scenarios or real world scenarios, it varies. So almost 20% of all the non-diagnostic or unsatisfactory FNACs actually turn out to be malignancies. So when you have a benign FNA diagnosis of benign goiter or a benign nodule, you can be a little calm, but the moment you have unsatisfactory or non-diagnostic, always repeat it or look for other things. I'll just rush through the other things. So adenoma versus carcinoma, all of us know it's difficult to pick that up, but what is important that there are some radiological features which we need to keep in mind. So if you have a pattern of multiple nodules within a nodule, so if this was one nodule, you see multiple nodules within the nodule on ultrasound, this could be more even if you have an FNAC features diagnosis suggestive of nodule, a follicular adenoma, here you need to suspect malignancy. And the other one is the formation of trabeculae within the nodule along with interrupted halo. So these are evidence, even though your FNAC may not be may give a report of follicular adenoma or benign lesion, it could actually be dealing with the follicular carcinoma. So thyroid scan, we have already told, no routine use. So routine use is unnecessary. To differentiate between a benign and malignant, definitely unnecessarily. In today's times, it has very limited role. CT scan, in case you're dealing with large goiters, suspicious of malignancy, yes. Retrosternal goiter, yes. MRI, we as surgeons normally don't prefer it, but in cases of recurrent thyroglossal cyst or any discharging sinus, their MRI definitely has a role. Otherwise, routine management of thyroid nodule, answer is no. Molecular diagnostics, just a slide or two. Initially, you had these tests, rule in or rule out. Whether you want to rule in malignancy or rule out malignancy, you had variable tests. These were the older generation. As the diagnostic yield of all these molecular diagnostics improved, modern day molecular tests actually are both sensitive and specific. So actually it both rules in and rules out this. So in our Indian scenario, still we don't use these routinely, but in times to come this will definitely help, and it is definitely of help in that select group of patients where you have ATP of undetermined significance or follicular neoplasm. And whenever you are talking about all these things, you need to remember that this is the prevalence of disease that matters. So if a thyroid nodule has a prevalence of, let's say 25% and 40%, their results would vary. So once you have a clinical impression, euthyroid or hypothyroid, if it is toxic, rule out toxic, nodular Graves' disease, then whether you intervene or surveillance, conventional surgery, remote access thydectomy, endoscopic or robotic. Of late, there is some role of ablative techniques even in multinodular goiter. So I would have used this. I would just like to end it by, the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. And during our MCH and MS, most of us do have some degree of illusion. Just get over it. And what is important, just remember this Dunning-Kruger effect. During our residency and or during our training, we are always somewhere at the part of this mount, stupid. The moment you start your consultancy, it is a valley of despair where actually you see where you actually stand all your surgical complications or your diagnostic mistakes, and then slowly you start growing. So in this part, don't be too happy, don't go into despair in this part of the learning curve. There is definitely a growth beyond that. And definitely I have finished. छोटा सा आपको उड़ा दिया गया है. And after this we'll have Kushag, Pooja ma'am and Sonkar sir. They'll finish off the baki dhamaka. Thank you.
Thank you so much, sir, for such an enlightening talk. I invite Surendra sir to kindly felicitate Dr. Kulranjan sir. Our next talk, Differentiated Thyroid Cancer from Diagnosis to Follow-up, by Dr. Pooja Ramakant ma'am. She is a professor currently working in Department of Endocrine Surgery, KGMU, Lucknow. We welcome you, ma'am.
ठीक, थैंक यू। स्लाइड्स इस पर है? ठीक। तो डॉक्टर कुलरंजन ने एक अच्छा समा बांध दिया है, अप्रोच टू अ ग्वाइटर। अब अगर वो डीटीसी निकलता है तो हम क्या करें? एंड इट्स अ नाइस जर्नी टू सी अ पेशेंट। फॉर रेजिडेंसी यू थिंक कि हमें बस कटिंग मिल जाए, सर्जरी मिल जाए, बट व्हेन यू सी द होल जर्नी, द स्पेक्ट्रम पेशेंट को फॉलो अप सब चीज़ें, देन ओनली यू लर्न होलिस्टिक मैनेजमेंट। तो दिस हैज़ टू बी अ क्वेश्चन आंसर सेशन। ठीक है, आई विल बी क्वेश्चनिंग यू एंड यू हैव टू आंसर, सो इट इज़ अ प्रोएक्टिव सेशन नाउ। डीटीसी में क्या क्या आता है? हाँ, पैपिलरी एंड फॉलिकुलर, वेरी गुड। ठीक है, हर्टल सेल भी आ जाता है। ठीक है, नया क्लासिफिकेशन भी आया है डब्ल्यूएचओ का। तो डायग्नोसिस के क्या क्या मोड्स होते हैं? अभी पिछला लेक्चर ही रिवाइज होगा। हाउ डू यू मेक अ डायग्नोसिस? थायराइड फंक्शन टेस्ट से आप हाइपरथायराइडिज्म, हाइपो या यूथ फंक्शनैलिटी बता सकते हैं। ठीक है, देखो अब यूएसजी, सीटी, एमआरआई, सबसे पहली चीज़ क्या है जब पेशेंट आपके पास आता है? हाँ, क्लिनिकल एग्जामिनेशन इज़ मोस्ट इम्पॉर्टेंट। ठीक है, तो सबसे पहला स्टेप आपका क्लिनिकल एग्जामिनेशन होना है। लाइफ लॉन्ग ये बात याद रखनी है, क्लिनिकल एग्जामिनेशन को कभी भी हम लेस वैल्यू नहीं देंगे थिंकिंग कि पेशेंट अल्ट्रासाउंड लेके आता है, ये हमने जांच कराई है, आप जांच देख लीजिए। ठीक है, मैनी आ टाइम्स इमेजिंग्स पैथोलॉजीज गो रॉन्ग। अभी भी हम देखते हैं कितनी बार ऐसा होता है कि एफएनए बिनाइन होगा, अल्ट्रासाउंड पे टायराइड्स बिनाइन लिखा होगा, स्कोरिंग 2-3 होगा, बट जब हम क्लिनिकली फील करेंगे ग्लैंड हार्ड होगा, मोबिलिटी कम होगी, वी विल हैव डाउट, सस्पिशन कि मैलिग्नेंट है। कई बार हमें इंट्राऑपरेटिव लिम्फ नोड्स भी दिख गए जो कि इमेजिंग पे नहीं थे। ठीक है, तो क्लिनिकल सेंस सर्जन का सबसे स्ट्रांग होना चाहिए। शुड ऑलवेज, कहते हैं ना, ट्रस्ट योर ओन क्लिनिकल एक्यूमेन। इफ़ यू आर थिंकिंग कि सस्पिशियस है तो यू हैव टू गो बैक, सी एफएनए ठीक से हुआ नहीं हुआ, इमेजिंग री इंटरप्रेट, रीड योर इमेजिंग योर सेल्फ। डोंट ट्रस्ट द रेडियोलॉजिस्ट ब्लाइंडली। ठीक है, हर सीटी, अल्ट्रासाउंड, सारी इमेजेस आपको रीड करना आना चाहिए, इवन द एक्सरेज। यू शुड पिक अप थिंग्स विच दे हैव मिस्ड। ठीक है, देन ओनली यू बिकम अ गुड सर्जन। सो क्लिनिकल एक्यूमेन इज़ वेरी इंपॉर्टेंट। देन पैथोलॉजी में कौन सा क्लासिफिकेशन यूज़ करते हैं एफएनए में? बेथेस्डा क्लासिफिकेशन। ठीक है, सो दिस हेल्प्स यू इन डिफाइनिंग कि वो बिनाइन है, इनडिटर्मिनेट है, मैलिग्नेंट है, क्या है, हाउ टू डिसाइड। अल्ट्रासाउंड में आपका स्कोरिंग सिस्टम कौन सा डॉक्टर कुलरंजन ने बताया? टायराइड्स। कौन कौन से टायराइड्स बताए? नहीं, कौन कौन से क्लासिफिकेशन, किस किस कंट्री के उन्होंने नाम लिए थे? टाटा का लिया था, कोरियन। एटीए क्लासिफिकेशन तो मैलिग्नेंसी के उससे है। यूरोप, फ्रेंड्स, सब ने अपने अपने टायराइड स्कोरिंग बना रखा है, क्योंकि हर कंट्री के हो सकता हो कि कुछ फैक्टर्स ऐसे हों जो उनके यहाँ ज़्यादा पर्टिनेंट हो। जैसे इंडिया इज़ अ मिक्स कंट्री, नॉर्थ में क्या है? आयोडीन डेफिशिएंसी है। साउथ में क्या है? क्यों? आयोनाइजेशन तो पैन इंडिया है। ठीक है, साउथ में क्या है कि दे ईट लॉट ऑफ सॉल्ट, रसम है, हर चीज़ में उनका सॉल्ट इनटेक ज़्यादा है, जो कि हम बहुत सी चीज़ें नहीं लेते हैं। ठीक है, तो सॉल्ट एक्सेस, आप एक्सेस सॉल्ट ले रहे हैं तो क्या हुआ? एक्सेस आयोडीन, एक्सेस आयोडीन से पैपिली थायराइड कैंसर हो रहा है। आयोडीन डेफिशिएंसी से यहाँ पे हम जब रॉक सॉल्ट ले रहे हैं नॉर्थ साइड में तो क्या हो रहा है? फॉलिकुलर थायराइड कैंसर। तो कैंसर्स दोनों उसमें हो रहे हैं। ठीक है, तो इसलिए आपका अल्ट्रासाउंड ये सब इम्पॉर्टेंट है। फिर जेनेटिक्स का रोल क्या है? हाँ, मेन सिंड्रोम के आपके उसमें है, तो अगर कोई जेनेटिक इंड्यूस कैंसर है तो फ़ायदा है कि आपको पता है कि आप में रेट म्यूटेशन पॉजिटिव है, तो आप उस पेशेंट के बच्चों में भी स्क्रीन कर सकते हैं। अगर वो पॉजिटिव निकलते हैं तो आप प्रोफाइलेक्टिक थायरेक्टमी सर्जरी परफॉर्म कर सकते हैं बिफोर इवन द कैंसर डेवलप्स, यू कैन टेक द ग्लैंड आउट। ठीक है, तो दैट इज़ वेरी इंपॉर्टेंट रोल ऑफ जेनेटिक्स, बट बिकॉज ऑफ कॉस्ट कंट्रेंट समटाइम्स हम नहीं कर पाते। सो क्लिनिकल फैक्टर्स क्या क्या इंपॉर्टेंट है? बोथ एक्सट्रीम्स ऑफ एज, चाहे वो बच्चा हो चाहे वो एल्डरली हो, यू हैव टू सस्पेक्ट मैलिग्नेंसी। बच्चों में बहुत फ्रीक्वेंटली थायराइड कैंसर्स हो जाते हैं डिटेक्ट। तो यू हैव टू बी केयरफुल विद द एज. फिर एनी रैपिड ग्रोथ, या तो लॉन्ग स्टैंडिंग गॉइटर है उसमें रैपिड ग्रोथ हो गया, या शॉर्ट ड्यूरेशन विद रैपिड ग्रोथ, दैट इज़ वेरी इंपॉर्टेंट. हार्ड कंसिस्टेंसी है, वॉइस चेंज है, कोई भी कंप्रेसिव सिम्टम्स आपको बहुत मिल रहे हैं, ठीक है. वॉइस चेंज बिनाइन में हो सकता है, कैसे? हाँ, लार्ज गॉइटर वो नर्व को कंप्रेस कर रहा है तो हो सकता है वॉइस चेंज. कोई टीचर है वो वोकल नॉड्यूल है उसके अंदर, अनरिलेटेड टू थायराइड प्रॉब्लम, उसका वॉइस चेंज हो गया है, ठीक है. किसी को कोल्ड है, कफ है, वॉइस चेंज हो जाता है. तो देयर मेनी अदर रीजंस आल्सो, बट कॉमन थिंग्स आर कॉमन फर्स्ट, ठीक है. तो अगर कंप्रेसिव सिम्टम्स है, फैमिली हिस्ट्री है, रेडिएशन एक्सपोजर है, ये सब चीज़ें मैलिग्नेंसी की तरफ सफाइज करती हैं. हार्ड कंसिस्टेंसी है, रेस्ट्रिक्टेड मोबिलिटी है, ठीक है. दैट इज़ वेरी इंपॉर्टेंट कि इट इज़ फिक्स टू अंडरलाइंग स्ट्रक्चर्स. फिक्सिटी मोस्टली इसमें होता है, बहुत रेयरली थायराइडाइटिस में आपको मिलेगा कि फाइब्रोसिस है और रेस्ट्रिक्शन है थोड़ा सा. लिम्फ नोड्स एनलार्ज्ड है और सॉलिड सिस्टिक नोड्यूल्स है, कंसिस्टेंसी है. बी वेरी केयरफुल फॉर लुकिंग फॉर मैलिग्नेंसीज. आई विल शो यू सम इमेजेस. इसमें क्या फीचर है मैलिग्नेंसी का? हाँ, सॉलिड सिस्टिक, वेरी गुड. तो ये सिस्टिक कंपोनेंट है, यू सी हेयर सॉलिड पैटर्न, ठीक है. दैट इज़ वेरी क्लासिकल हेयर. यहाँ देखो सेप्टेटेड सिस्ट है, सेप्टेशन साथ में है, ये सॉलिड ग्रोथ है. जब भी सॉलिड ग्रोथ इन द सिस्टिक नोड्यूल है, दैट इज़ वेरी हाई चांस मैलिग्नेंसी का. इसका अगर ब्लाइंड एफएनए होगा, दैट में टर्न आउट टू बी बिनाइन. तो डोंट गेट कैरिड अवे कि वो बिनाइन नोड्यूल है, ठीक है. बिकॉज इसमें क्या होना है, आइडियली यू हैव टू एस्पिरेट द होल फ्लूइड एंड देन डू एफएनए फ्रॉम दिस सॉलिड एलिमेंट. बट बहुत बार ये मिस हो जाता है, इट डजंट हैपन दैट वे, ठीक है. यहाँ पे ये क्या है, कैल्सिफिकेशन नहीं. कैन समबडी से कि ये क्या है? ये लंग है, ये ट्रेकिया है. हाँ, वेरी गुड. सो क्लैविकल है, ये क्लैविकल इन्फिल्ट्रेट हो गई है. इसका मतलब क्या हुआ? एक्स्ट्रा मतलब थायराइड कैंसर विथ क्लैविकुलर मेटास्टेसिस, ठीक है. तो अगर आपको ऐसे मेटास्टेसिस कहीं पे दिख रहे हैं तो इट मीन्स कि वो डीटीसी है विथ मेटास्टेसिस. और मोस्टली क्लैविकल्स आपके जो हैं या बोन इन्वॉल्वमेंट है, मोस्टली फॉलिकुलर में ज़्यादा होता है बिकॉज दे हैव हेमाटोजिनस, ब्लड से स्प्रेड होते हैं. पैपिलरीज में लिम्फ नोड स्प्रेड ज़्यादा है तो लिम्फेटिक लिम्फ नोड इन्वॉल्वमेंट ज़्यादा होगा. तो बी केयरफुल इन इंटरप्रेटिंग द इमेजेस. अब सर्जिकल ट्रीटमेंट जो है, अगर छोटा है नोड्यूल, T1 T2 है, यू कैन गेट अवे विथ हेमीथायरेक्टमी. अगर मल्टीपल नोड्यूल्स बोथ साइड्स हैं या लार्ज है, T3 T4 है, यू कैन डू टोटल थायरेक्टमी. अगर आपको जैसे क्लैविकल स्टर्नम कोई इन्वॉल्वमेंट है, यू हैव टू डू स्टर्नोटमी या रिट्रोस्टर्नल है, तो बी प्रिपेयर्ड फॉर दैट. फिर अगर कोई मेटास्टेसिस है, लाइक आई सेड क्लैविकुलर है, समटाइम्स वी एक्साइज द मेटास्टेसिस आल्सो, तो वो मेटास्टैटेक्टमी बोलते हैं. अगर वो अप्रोचेबल है और ओलिगोमेटास्टेसिस है, इट इज़ गुड टू एक्साइज. फिर सर्जिकल, उसमें एक स्पेक्ट्रम में इवन नो सर्जरी आल्सो इज़ वन ऑफ द चॉइस. नो सर्जरी में क्या है, पैपिलरी माइक्रोकार्सिनोमा विच आर लेस देन 1 सेंटीमीटर्स. उसमें इधर यू कैन ऑब्जर्व या सम पीपल आर स्टार्टेड डूइंग एब्लेशंस. अब माइक्रोवेव एब्लेशन है, वो देखो सो रही है सुबह सुबह. गुड मॉर्निंग, उठ गए? ठीक है. लिम्फ नोड्स का क्या है, व्हाट इज CCLND? तुम ही बताओ. CCLND क्या है, MRND क्या है, उसको बोलने दो. हाँ, MRND सुना है नाम? मॉडिफाइड रेडिकल, वेरी गुड. और CCLND क्या है? सर नहीं बता रही वो अभी सो के उठी ना, तो वो टोटली वो है कि डिसोरिएंटेड है. CCLND क्या है? सेंट्रल कंपार्टमेंट लिम्फ नोड डिसेक्शन, ठीक है. तो सेंट्रल कंपार्टमेंट यू कैन डू प्रोफाइलेक्टिक इन T3 T4, बट T1 T2 में इट हैज़ टू बी थेराप्यूटिक. बट MRNDs इज़ नॉट प्रोफाइलेक्टिक. अगर लिम्फ नोड्स आपके इन्वॉल्व हैं तो फिर यू कैन गेट अवे विद द नेक डिसेक्शन लेवल 2 to 5. ठीक है. अब सर्टेन सिनेरियोज. अभी स्टोरी क्या है, 25 ईयर्स मेल, स्वेलिंग इन फ्रंट ऑफ नेक फॉर 3 months, ग्रेजुअल प्रोग्रेशन, कोई कंप्रेसिव सिम्टम्स नहीं है, यूथायरॉयड. क्लिनिकली क्या है, इट इज़ अ 3 centimeter हार्ड सॉलिटरी थायरॉयड नोड्यूल लेफ्ट साइड में. सो अब इसमें क्या पॉइंटर्स हैं टुवर्ड्स मैलिग्नेंसी, हार्ड है और मेल जेंडर है और एज ग्रुप भी 25 ईयर्स है, थोड़ा सा यंगिश ग्रुप में है. ठीक है. तो आपको सारे फीचर्स ऑफ मैलिग्नेंसी एक पेशेंट में नहीं मिलेंगे. सो यू हैव टू बी केयरफुल इन पिकिंग अप है इसमें कैंसर है या नहीं है. अल्ट्रासाउंड में जैसे हाइपोइपोइक नोड्यूल है 3 सेंटीमीटर्स का, नो एनलार्ज लिम्फ नोड्स. तो इसमें क्या फीचर है, हाइपो. ठीक है, सॉलिड नोड्यूल्स, दे आर मोर चांसेस ऑफ मैलिग्नेंसी. सीटी स्कैन में यू कैन सी राइट साइड में नोड्यूल है. एफएनए में क्या फीचर्स हैं, ऑर्फन एनीआई न्यूक्लियाई, कैरेक्टरिस्टिक ऑफ पैपरी थायरॉयड कैंसर. तो इसका ट्रीटमेंट क्या होगा, हेमीथायरेक्टमी, यू कैन गेट अवे विद इट. 3 सेंटीमीटर्स है, इंट्राकैप्सुलर है, आपने देख लिया, बाहर नहीं कहीं कुछ है. एफएनए पीटीसी है, यू कैन गेट अवे, यू कैन डिस्कस विद द पेशेंट. ठीक है. कई बार पेशेंट ऐसा कहता है कि हमारा कैंसर है, आपने आधा ग्लैंड छोड़ दिया, कोई और जाके उसे रिकाउंसिल कर रहा है, तो यू कैन डिस्कस विद पेशेंट प्रॉस एंड कॉन्स. इफ पेशेंट इज विलिंग एंड एक्सेप्टिंग हेमीथायरेक्टमी, यू कैन गेट अवे विद हेमी. ठीक है. और ये अनदर सिनेरियो है, दिस इज लार्ज मल्टीनोडुलर गोइटर. इसमें क्या आपको एबनॉर्मल दिख रहा है, क्लिनिकल डायग्नोसिस. हिरसोटिज्म तो छोड़ दो, मतलब दैट इज वो है, बट दैट इज फिजियोलॉजिकल फॉर हर. बट कुछ एबनॉर्मल दिख रहा है. हाँ, आई में क्या दिख रहा है, स्क्विंट, वेरी गुड. ठीक है. तो शी डेवलप डिप्लोपिया, और वो भी आप देखो यूनिलैटरल है. ठीक है. आपको दूसरा हिंट, आपको वहाँ एरो भी दिख रहा है, शी हैज गॉट स्कैल्प मेटास्टेसिस ऑल्सो. तो ये अब ग्वाइटर क्या होगा फिर, ये फॉलिकुलर कार्सिनोमास. ठीक है, मोस्ट कॉमनली. अब देखो सेम चीज़ इसके भी नोड्यूल में, सीटी में यू सी सिस्टिक एलिमेंट हेयर, सॉलिड ग्रोथ हैपनिंग, इरेगुलर हेयर. यहाँ पे भी देखो कॉलीफ्लावर की तरह, गोभी की तरह ये सॉलिड ग्रोथ इरेगुलर सी ग्रो कर रही है. दैट इज कैरेक्टरिस्टिक ऑफ कैंसर्स. और यही लॉन्ग स्टैंडिंग नेक्रोसिस होके फाइनली एनाप्लास्टिक थायरॉयड कैंसर में कन्वर्ट हो जाएगा अगर इसको 5 साल और रखे रहेंगे तो. ठीक है. अब इसके मेटास्टेसिस का इमेजिंग हुआ है, यू कैन सी हेयर स्कैल्प में मेटास्टेसिस है जो कि प्रोट्यूबरेंट है, जहाँ हमें फील हो रहा है, आउटग्रो कर रही है. मल्टीपल और साइड्स भी है, नॉट सिंगल. वो लंग भी स्टडेड है विद मेटास्टेसिस. ये देखो रिब में भी मेटास्टेसिस है. तो शी हैज मल्टीपल साइड्स मेटास्टेसिस. थायरॉयड कैंसर इज वन ऑफ द गुड कैंसर्स जिसमें कि इवन इज सो मच ऑफ लिम्फ नोड्स और सब कुछ इन्वॉल्वमेंट है, स्टिल वी कैन ऑपरेट फॉलोड बाय एडजुवेंट थेरेपी. तो आप एफएनए दोनों साइड से कराएंगे. दिस इज अनदर सिनेरियो. दिस लेडी ऑल्सो हैज स्कैल्प मेटास्टेसिस विद अ गोइटर और इसके लिम्फ नोड्स भी एनलार्ज्ड हैं. ठीक है. अल्ट्रासाउंड आपने कराया है, मल्टीपल लिम्फ नोड, सेम चीज़ आप इमेजिंग उसका भी कराते हैं, लीशंस के भी कहाँ पे हैं. एफएनए अगेन फ्रॉम थायरॉयड इज फॉलिकुलर कार्सिनोमा, पैथोलॉजिस्ट हैज रिपोर्टेड स्कैल्प सेलिंग से पॉजिटिव फॉर मेटास्टेसिस. अब इसमें इंपॉर्टेंट चीज़ क्या है कि आप देखते हैं कैप्सूल के बाहर भी ये थायरॉयड सेल्स आपको दिख रहे हैं, ये कैप्सूल है. तो थायरॉयड फॉलिकुलर न्यूप्लाज्म में अगर पूरा बाहर जा रहा है कैप्सूल के, ग्रीन कैप्सूल है इसके बाहर जा रहा है, तो येस इन्वॉल्वमेंट है कैप्सुलर इन्वेजन, ये भी बाहर जा रहा है. स्किप मेटास्टेसिस है, इसके बाहर है एम्बोलाई की तरह, तो ये भी है. बट अगर जस्ट कैप्सूल को परमिएट करा है बट थ्रू एंड थ्रू नहीं करा है, तो देन दैट इज नॉट इन्वॉल्व कॉल्ड एज कैप्सुलर इन्वेजन. तो कैप्सुलर इन्वेजन, वैस्कुलर इन्वेजन, कोई भी इन्वेजन जो है दैट इज फीचर ऑफ वाइडली इन्वेसिव फॉलिकुलर कार्सिनोमास. फॉलिकुलर कार्सिनोमास भी मिनिमली इन्वेसिव, मॉडरेट और वाइडली इन्वेसिव हो सकते हैं. तो दैट चेंजेस योर एडजुवेंट ट्रीटमेंट प्लानिंग. इमेजिंग पे मोस्ट कॉमनली अल्ट्रासाउंड आप कराते हैं, बेसिक है. सीटी इन लार्ज गोइटर्स, कोई इन्फिल्ट्रेशन दिख रहा है आपको, मोबिलिटी कम है, रिट्रोस्टर्नल एक्सटेंशन है, सो इन सेलेक्टेड सब ग्रुप सीटी कराएंगे. एमआरआई उससे भी सेलेक्टेड सब ग्रुप में, कोई जैसे डॉक्टर ने बताया कि कोई फिस्टुला है, कुछ इश्यूज़ हैं, बहुत रेयर हम एमआरआई कराते हैं. और जैसे ये पेशेंट का आप देखो, यहाँ पे क्या है, लिम्फ नोड्स और थायरॉयड नोड्यूल्स दोनों आपस में मिक्स हो गए हैं. तो अगर फैरिंग्स इन्वॉल्वमेंट है, कुछ है, पेशेंट को डिस्पेजिया है, तो उसमें आप केसेस में एंडोब्रोकियल या एंडोस्कोपी अपर जीआई करा के चेक करते हैं कि इसोफेगस के अंदर या ट्रेकिया के अंदर ग्रोथ तो नहीं है, टू चेक दैट पार्ट। सर्जरी में उस पेशेंट में बिकॉज लिम्फ नोड्स भी इन्वॉल्व थे, तो टोटल थायरडेक्टमी विद सेंट्रल कंपार्टमेंट लिम्फ नोड डिसेक्शन विद मॉडिफाइड रेडिकल नेक डिसेक्शन प्लस मेटास्टेसिस। अगर क्लैविकल का या न्यूरोसर्जन अगर ब्रेन वाला निकालना चाहते हैं तो दे कैन गेट अवे विद इट, बट मल्टीपल हैं तो देयर इज नो पॉइंट, फिर रेडियो आयोडीन टेक्स केयर ऑफ इट। अब एडजुवेंट में क्या है कि रेडियो आयोडीन थेरेपी मॉडरेट रिस्क और हाई रिस्क में सबको देना है। जो लो रिस्क डीटीसीज आएंगे उसमें यू कैन अवॉइड, तो रिस्क स्ट्रैटिफिकेशन आप फॉलो अप में प्लान करते हैं, इसलिए फॉलो अप इज़ इम्पॉर्टेंट। आपको पहले प्री ऑप में पता नहीं होता कि ये कौन सा रिस्क स्ट्रैटिफिकेशन में पेशेंट फिट होगा। और टीएसएच सप्रेशन क्यों करते हैं हम पेशेंट को थायरॉक्सिन उसको ज़्यादा देते हैं जिससे टीएसएच सप्रेस्ड है, लाइक लेस देन 0.1 रहे रेकरेंस के लिए, क्योंकि टीएसएच इज़ वन ऑफ द ग्रोथ फैक्टर्स फॉर थायराइड कैंसर्स। ठीक है, तो वन ऑफ द फैक्टर्स। तो फॉलोअप में क्या है कि आप 4 to 6 वीक बाद टीएसएच करा के चेक कर लेंगे कि सप्रेस्ड है नहीं है। वो भी लो रिस्क में सप्रेशन, मॉडरेट हाई रिस्क में सप्रेशन डिफरेंट होगा। लो रिस्क में आप कम सप्रेशन करेंगे और कैल्शियम चेक करेंगे टोटल थायरेक्टमी के बाद, क्योंकि हाइपोकैल्सीमिया तो नहीं है पेशेंट को, या कैल्शियम टेपर करना है। बायोमार्कर क्या है, ब्लड मार्कर, हाँ टीजी। तो थायरोग्लोबुलिन चेक कराएंगे, थायरोग्लोबुलिन फॉल्सली एलिवेटेड तो नहीं है, वो चेक करने के लिए आप टीजी एंटीबॉडीज़ कराते हैं, किसी और रीज़न से तो नहीं एलिवेटेड है। और सिंगल वैल्यू ऑफ टीजी इज़ नॉट इम्पॉर्टेंट, उसका पैटर्न कैसा है, क्या वो डबलिंग टाइम हो रहा है टीजी का, कैसा ग्रोथ है, दैट इज़ मोर इम्पॉर्टेंट कि अंदर मेटास्टेसिस हो रहा है या नहीं। ठीक है, तो अब क्या है, ये डेटा फ्रेमवर्क है, डेटा का एक्रोनिम है। तो डायग्नोसिस ऑफ थायराइड कैंसर किया, असेसमेंट ऑफ रिस्क बेनिफिट किया, फिर ट्रीटमेंट प्लान किया, आप सर्जरी कर रहे हैं या एक्टिव सर्विलेंस, फिर असेसमेंट ऑफ रिस्पॉन्स। ट्रीटमेंट के बाद भी रेकरेंस तो नहीं हो रहा, जो एक्टिव सर्विलेंस में आपने रखा है पेशेंट को उसमें भी यू डू एनुअली अल्ट्रासाउंड टू सी नोड्यूल ग्रो तो नहीं कर रहा है, क्या है। और फॉर इनिशियल थेरेपी में डायग्नोसिस और सर्जरी हुआ, एजेसीसी क्लासिफिकेशन किया, हिस्टोपैथ देखी, क्लिनिकल इन्फॉर्मेशन एंटर करा, एटीए का रिस्क ऑफ रेकरेंस क्या है, लो रिस्क, इंटरमीडिएट या हाई रिस्क इसमें फॉल करता है। 6 to 12 वीक्स आपने असेसमेंट किया, टीजी एंटीबॉडीज़, ट्रीटमेंट डिसीजन लिया, अगर हाई रिस्क है या मॉडरेट रिस्क है तो आपने रेडियो आयोडीन प्लान किया है। फिर 6 to 12 मंथली आप टीजी एंटीबॉडी, क्लिनिकल एग्जामिनेशन, लिम्फ नोड्स तो नहीं आ रहे हैं, पेशेंट को कोई कंप्लेंट्स तो नहीं है, पेशेंट ने थायरॉक्सिन छोड़ तो नहीं दिया, वो सब चीज़ें चेक किया। तो फॉलो अप इज़ लाइफ लॉन्ग। ठीक है, थायराइड कैंसर्स है वेरी गुड प्रोग्नोस्टिक कैंसर्स, पेशेंट्स लिव अलॉन्ग, 90% पेशेंट्स लिव फॉर मोर देन 10 years। तो लाइफ लंबी होगी तो क्या होगा, रेकरेंसेस आ सकते हैं, तो यू हैव टू कीप लुकिंग फॉर दैट। तो फॉलो अप डजंट एंड आफ्टर 5 years 10 years, इट गोज थ्रू आउट लाइफ। अनलाइक ब्रेस्ट कैंसर जहाँ पे कि मोर्टेलिटी रेट ज़्यादा है, तो उसमें मोर्टेलिटी और रेकरेंस दोनों देखते हैं। थायराइड कैंसर्स में हम मोर्टेलिटी की ज़्यादा बात नहीं करते। अनलाइक कि सबसे ख़राब कौन सा है कैंसर है थायराइड का, एनाप्लास्टिक, जिसमें कि डेथ ज़्यादा होती हैं, तो उसमें हम रेकरेंस उतना नहीं देखते। बट ये स्लो ग्रोइंग इंडोलेंट होते हैं डीटीसीज, तो वी लुक फॉर रेकरेंसेस। सो विद दिस आई एंड, एनी क्वेश्चंस, क्लैरिफिकेशंस, आप लोग कुछ पूछना है? जितना बताया उतना क्लियर है। मॉडरेट में और हाई रिस्क में मोस्टली लोग बोलते हैं, बट मॉडरेट में क्या है, इंस्टीट्यूशनल पॉलिसी भी मैटर करती है। कुछ इंस्टीट्यूशंस देंगे, कुछ नहीं देंगे। ऐसा हो सकता है हम केजीएमयू में दे दें, एम्स वाले नहीं दे रहे, तो वो इंस्टीट्यूशनल पॉलिसी पे उन्होंने छोड़ दिया है कि आप अपना डिसीजंस ले लो। सेम चीज़ गोज़ फॉर हेमीथायरेक्टमी ऑल्सो। कुछ लोग अभी भी हेमी में बिलीव नहीं करते, दे डोंट डू इट, सो दे हैव लेट, बट क्लास गाइडलाइंस आर जस्ट टू गाइड अस, दे डोंट डिक्टेट कि आपको यही करना है, क्योंकि हर कंट्री का, हर प्लेस का पेशेंट्स डिफरेंट होते हैं। अगर प्रोफाइल गांव वाला आ रहा है, फॉलोअप में नहीं रहेगा, तो वी हैव टू मेक अ कॉल कि वो टोटल थायरेक्टमी के बाद अगर कोई 25 years का है, वो लाइफ लॉन्ग थायरोक्सिन नहीं खाएगा, तो हम उसका हेमी करते हैं, दैट इज़ बेटर फॉर हिम। तो उस तरह से यू मेक दोज डिसीजंस। तो मॉडरेट में इंस्टीट्यूशनल पॉलिसी है, लो रिस्क में तो दे से की ज़रूरत नहीं है देने की, डोंट वेस्ट आयोडीन, हाई रिस्क में तो देना ही है। जैसे ये मेटास्टेसिस के 2 सिनेरियोज आई शोड, इनमें तो देना ही है। बट मॉडरेट में बहुत से लोग लो स्मॉल अमाउंट ऑफ रेडियो आयोडीन देते हैं, फुल डोज भी नहीं देते हैं, तो वो भी डिफरेंस हो जाता है कि हम कितना अमाउंट ऑफ रेडियो आयोडीन दे रहे हैं। ठीक, थैंक यू।
Thank you so much, ma'am. It was a wonderful talk. Now I call Avneesh sir for felicitating, ma'am. Our next lecture of the day, hypothyroidism from control to cure. Our speaker, Dr. Kushagra Gaurav sir. Sir is associate professor here at our department of KGMU General Surgery. Thank you. We welcome you, sir.
Thank you. So फिर से गुड मॉर्निंग. गुड मॉर्निंग. हाँ जी, हाइपरथायराइडिज्म प्रेजेंट हो रहा है ना, तो थोड़ा सा हाइपो से हाइपर के फेज में चले जाएं. ठीक है, आई वांट यू गाइस टू हैव ऑल योर थायराइड हार्मोन बूस्टेड अप. सो हाइपरथायराइडिज्म क्या होता है? So hyperthyroidism, we all know this. Please no need to write anything. सब कुछ बुक्स में दिया हुआ है, सब कुछ मैंने बुक से ही बनाया. ठीक है, प्लीज जस्ट फॉर 15 minutes, एटलीस्ट फॉर 10 minutes, focus here. ठीक है, everything is given in books and focus here. Hyperthyroidism is a disorder in which excess thyroid hormone is synthesized and secreted from the thyroid gland. Okay, this is very important in definition. That is, it is synthesized and secreted from the thyroid gland. There can be condition where thyroid, the circulation can have excess thyroid hormones that may not be synthesized by the thyroid gland. Those conditions are labeled as thyrotoxicosis without hyperthyroidism. So what are those conditions? Then in those conditions there could be extrathyroidal sources like excess thyroid hormone ingestion, there could be struma ovari, there could be functional thyroid, metastatic thyroid cancer, or release of preformed hormones like in radiation induced thyroiditis. So most common type, we have three types of causes of hyperthyroidism. Most common is grave disease all across the world. That constitutes about 70 to 80%. That happens mostly in iodine sufficient world, Western world, industrialized world. Two other common causes are toxic nodular goiter. It includes two entities, that is toxic multinodular goiter and solitary toxic adenoma. These are common causes in elderly individuals in geographic areas of endemic iodine deficiency. This happens in iodine sufficient world, more common, 70 to 80%. This happens in iodine deficient world, less common. So overall, it is about, we have Western data, we don't have an Indian data or a subnational data. It is more common in women in 1.23% to in US population. It is higher in elderly women, I'll just tell. So I'll not focus much on clinical features of hyperthyroidism. We all know hyperthyroidism क्यों होता है? BMR बढ़ जाने की वजह से. तो सारे जितने बॉडी के सिस्टम है, CNS है, CVS है, कार्डियक है, all systems, all muscular systems, सब की BMR बढ़ जाएगी. सबका मिनट टू मिनट टाइट्रेशन इज, जो हर चीज का रेट है, that is governed by T3 and T4 हार्मोन. ओके, कि एक सेकंड में या एक मिनट में हार्ट कितनी बार बीट करेगा, एक मिनट में कितनी बार ब्रेन से पल्सेस जाएंगे, कितनी बार न्यूरोनल reflexes जाएंगे, सब चीजें. Every rate is governed by thyroid hormone. So that rate is increased. So every system is excited. यानी CNS का rate बढ़ जाएगा, CVS का rate बढ़ जाएगा, तो tachycardias, arrhythmias, irritation, anxiety, heat intolerance, सब कुछ होता है. ये सब हम लोग MBBS में पढ़ चुके हैं, तो I'll not focus much on this. In Graves' disease, we have, apart from the system, we have a neck swelling also. We have prominent eyes या फिर exophthalmos जिसको हम लोग बोलते हैं, that is also common, and amenorrhea या oligomenoria. We'll focus one by one on these. Graves' disease is an autoimmune disease, हम सबको पता है. It is causes multifactorial. Main cause is due to autoantibodies that bind to TSH receptor, that are similar in structure to TSH receptor, and they bind to TSH receptor, and they continually stimulate the thyroid gland to secrete T3 and T4. So earlier in era, they were called as long-acting thyroid stimulator, LATS antibody. Okay, we have genetic predisposition. There are certain trigger factors for Graves' disease. What are those trigger factors? Trigger factors are psychological stress, smoking, female sex and recent childbirth. These are trigger factors. यानी young ladies में अगर ये कुछ भी हो रहा है, these could be trigger factors for Graves' disease. Some infections like Yersinia, vitamin D and selenium deficiency. Since it is an autoimmune disease, so it is often associated with other autoimmune disease like rheumatoid arthritis, SLE, type 1 diabetes mellitus, Addison disease and much more. Clinically, there is clinical features of hyperthyroidism. We know that there could be a thyroid swelling, there could not be a thyroid swelling in Graves' disease. But certain extrathyroidal features are very important. What are those? Ophthalmopathy. This is extremely important in Graves' disease. It happens to be about in 25% of Graves' disease, and it occurs due to that antibodies also bind to the TSH receptor which are present in the intraorbital tissues and result in hypertrophy of orbital muscles and fibrofatty tissue, resulting in the ophthalmos. Second most common symptom extrathyroidal is dermopathy, the pretubal myxedema, the thickening of skin and fibrofatty tissue deposition, and lastly the rest is acropathy, that is the clubbing of fingers and toes. Thyroid in Graves' gland is typically diffuse butterfly shaped, classically diffuse butterfly shaped. It is soft and rubbery. Goiter, whereas in multinodular goiter it is multinodular. Graves' disease में goiter small होगा, वहाँ large होगा. Graves में there is short history, rapid history, young patient. Whereas in toxic nodular goiter there is a long history of preceding goiter की goiter लंबे कई decades से goiter है, that converts into a toxic multinodular goiter. So patient are usually elderly and the process is developmental is slow. Diagnosis is usually clinical. Serum TSH क्या होगा Graves में? Serum TSH would be low, yes, and T3 T4 would be high. Like in any hyperthyroidism, वो हमको मिलेगा. There are some associations like ATA and ACE. They recommend use of radioiodine scan, and unless a diagnosis of Graves' disease established clinically. Some geographic regions like Europe, Japan, Korea, they also recommend the assessment of TSH receptor or antibodies concentration. So this is how radioiodine scan पे Graves' disease, this looks like this, diffuse butterfly shaped uptake, hot uptake. This is how it looks on multinodular goiter. Certain areas are hot, certain areas are cold, certain areas are warm, certain areas are mixed. And this is how a toxic single nodule looks like, only a single functioning nodule, that is AFTN or toxically solitary adenoma. US guideline also considers the management of TSH receptor antibodies as an alternative way to Graves' disease diagnosis when radioiodine uptake cannot be done or it is not available or contraindicated. So treatment of every hyperthyroidism is like that only. For Graves' disease, we have to restore the normal thyroid function, we have to avoid recurrence of hyperthyroidism, and we have to prevent the development of hypothyroidism. In Graves' disease, we have to also stop the progression or we have to stop the development of Graves' ophthalmopathy also. So there are three therapies of management of hyperthyroidism. First of all, it is antithyroid drugs. Secondly, radioactive iodine therapy, and third is surgery definitely. Geographical differences occur in usage of these and preference of these therapy for treatment. So which therapy is best, that is a matter of debate, but all the guidelines and all the regions, they say that there should be patient-centered approach, there should be patient-tailored approach, which therapy is best. तो कौन सा therapy किस patient के लिए क्या suit करेगा? We have to visualize the patient features and patient-tailored. We have to consider the patient values, and that can be kept under consideration. Antithyroid drugs that are usually given as for mild disease, small goiters, and when we have a negative or low TSH receptor antibody. Also as a bridging gap for surgery, when we are planning for surgery to make the patient use antithyroid drugs. Contraindication when patient is having high sensitivity or adverse reaction to these drugs. Radioactive iodine when patient is high surgical risk or previously operated neck, or there is a contraindication of radioiodine therapy. And the contraindication of radioactive therapy is whenever patient is pregnant, patient is lactating, or patient is planning very soon a pregnancy. So that is a contraindication, and if there is a coexisting thyroid cancer or a suspicion of cancer, then surgery is recommended. So there happens to be a lot of indication for surgery in Graves' disease. if the goiter is very large, there is symptomatic compression, there is intolerance to anti-thyroid drugs, and thyroid malignancy suspected, large non-functioning nodules are there. So, or if the patient is planning pregnancy, or any of the contraindication to previous two multimodalities, any other contraindication to anti-thyroid drugs, or any other contraindication to the radioactive iodine therapy. Contraindications are if the patient is not fit for surgery, that is one contraindication only. That is how difference in opinion occurs. This is in North America, where they prefer mostly radioactive iodine therapy. All across the world, they prefer anti-thyroid drugs and radiation therapy. This small green one is surgery. So very less people in world, they prefer surgery. Surgery is the usually last modality, but definitely modality of treatment. So surgical treatment of Graves' disease, patient should be made euthyroid definitely by the use of anti-thyroid drugs. Beta blockers can be used along with that. There is a concept of rapid preparation. Rapid preparation क्या होता है? Rapid preparation is beyond the usual anti-thyroid drug preparation when we want to do this surgery. So we use certain drugs like supersaturated solution of potassium iodide or Lugol's iodine. Those decrease the thyroid vascularity and they reduce the thyroid hormone release. That is known as Wolff-Chaikoff effect. Very good. That is known as Wolff-Chaikoff effect. That is called as thyroid constipation. मोटा मोटा thyroid को constipation हो जाता है. जितना thyroid का hormone stored है, that is not released. We stun the thyroid with high doses of iodine. हमने high doses of iodine दे दी, Lugol's iodine देके या super saturated potassium iodide देके, जिससे thyroid stun हो गया. Thyroid stunning का मतलब है कुछ दिन तक, at least 5 to 7 days तक, even to 10 days, थायराइड की वैस्कुलरिटी कम हो जाएगी, थायराइड में आयोडीन बनना कम हो जाएगा. थायराइड को ये लगेगा बॉडी में सर्कुलेशन बहुत सारा आयोडीन है, तो मुझे रिलीज भी नहीं करना है. तो दैट इज अवर विंडो पीरियड जिसमें हम लोग बहुत अच्छे से सर्जरी कर सकते हैं, बिकॉज वैस्कुलरिटी कम हो जाती है एंड जो सर्जरी के बाद समटाइम थायराइड स्टॉर्म एक कॉम्प्लिकेशन होता है वो भी नहीं होता है. तो दिस इज यूजुअली डन इन केस ऑफ ग्रेव्स डिजीज ओनली, बाकी किसी में नहीं. सर्जरी वाइज टोटल थायराइडेक्टमी इज द ओनली ऑप्शन. एडवांटेजेस एंड डिसएडवांटेजेस हमको सबकी पता है. Coming to the second modality, that is toxic nodular goiter. It also has a multimodal idiopathogenesis. First of all is somatic activating mutation of TS receptors. Second is chronic TS stimulation. That the toxic nodular goiter happens to be in case of iodine deficiency area. So there is chronic TS stimulation. There is phases of euthyroidism, hypothyroidism. So chronic TS stimulation, so that is also important. Chronic TS stimulation with prolonged iodine deficiency. And lastly, but most important, is polyclonal expansion. In toxic multinodular goiter, there is polyclonal expansion of functional follicular cells. In toxic adenoma, there is monoclonal expansion. So this is the graph I was talking about. Euthyroid, there are phases of euthyroidism, then hypothyroidism, euthyroidism, hypothyroidism. Then there is continued phase of subclinical hypothyroidism that inactively turns into hyperthyroidism and toxic nodular goiter. So there is a long history of subtoxic goiter or a non-toxic goiter, multinodular goiter beforehand that converts into a toxic goiter. Clinical features are same. Hyperthyroidism होगा ही होगा. There would be history of non-toxic goiter for long. Patient क्योंकि long history होगी 3 to 4 decades की, obviously patient elderly होगा. Cardiacs यहाँ पर जो पुराने से पढ़ा जाता है, इस दास पढ़ाती है कि टॉक्सिक मल्टीगोइटर में कार्डिक मैनिफेस्टेशन ज्यादा होते हैं. ग्रेव्स डिजीज में सीएनएस मैनिफेस्टेशन ज्यादा. पेशेंट यंग होता है, इरिटेबल होता है, फंक्शनली वेल होता है. यहाँ पर क्योंकि कार्डिक सिस्टम ऑलरेडी कॉम्प्रोमाइज्ड है तो कार्डिक मैनिफेस्टेशन ज्यादा होते हैं. Hyperthyroidism is usually less severe than that of Graves' disease. Onset is gradual and often preceded by a long period of subclinical hyperthyroidism या non-toxic goiter. इसमें dermopathy and ophthalmopathy नहीं होगी. That is characteristic feature of Graves' disease only because of that antibody feature. And usually large goiters होते हैं तो there is mass effect. Diagnosis is more or less clinical. TSH यहाँ पर क्या होगा? क्या होगा TSH? Obviously कम होगा, हाइपरथायराइड है ना, तो TSH कम होगा, T3 T4 ज्यादा होंगे. रेडियो अपटेक अगर हम करते हैं, it is not necessary for diagnosis, करते हैं तो पैची अपटेक. There would be areas of hyperfunction and less function. Goal of treatment, radioiodine ablation या thyroidectomy. रेडियोआयोडीन थेरेपी जब हम देते हैं जबकि हाई रिस्क फॉर सर्जरी होता है या रेकरेंट गॉइटर होता है. कॉन्ट्राइंडिकेशन जैसे कि कॉन्ट्राइंडिकेशन थेरेपी के थे वो यहाँ पर होंगे. It contains many non-function nodule also. So therapy का result varies. अगर हम रेडियोआयोडीन थेरेपी देते हैं, अगर non-function nodule में वो concentrate नहीं करेगी, एंड वहां का रिजल्ट नहीं आएगा, नोड्यूल एज इट इज रहेगा ही रहेगा, एंड सस्पिशन ऑफ कैंसर है तो उसके लिए हमें सर्जरी करनी पड़ेगी. So surgical management is usually the definitive management. Total thyroidectomy is always preferable. Subtotal thyroidectomy आज की तारीख में it is obsolete, but if done that results into 50 to 78% of recurrence. ठीक है, तो हमेशा ध्यान रखना आज की तारीख में there is no indication of subtotal thyroidectomy. The only option for hyperthyroidism, for thyroid cancer, for multinodular goiter is total thyroidectomy only. SSKI is not given because it may worsen the hyperthyroidism. That is known as jod based off phenomena. वो Wolff-Chaikoff effect हो रहा था, वहां पर iodine constipation, thyroid constipation जिसको हम बोल रहे थे, यहाँ पर क्योंकि ऑलरेडी ऑटोमेटिक सोमैटिक म्यूटेशन की वजह से ऑटोमेटिक फंक्शनिंग नोड्यूल्स हैं, तो हमने अगर आयोडीन दिया तो वो ज्यादा आयोडीन मिलता है, वो ज्यादा T3 T4 बनाने लगेंगे, तो इट वर्सन्स द हाइपरथायराइडिज्म. सो हम लोग टॉक्सिक मल्टीनोडुलर गटर में कभी भी हम लोग वोल्फ-चाइकोफ इफेक्ट एक्सेप्ट नहीं करते हैं. Lastly, it is solitary toxic nodule, that is one single nodule that is autonomous functioning, also known as AFTN. This is one single nodule that takes up greater radioiodine in the surrounding tissue. The etiopathogenesis is monoclonal expansion and mutation in TSH receptor gene. Patient is usually young and there is single nodule, and signs and symptoms obviously TSH कम होगा, T3 T4 ज़्यादा होगा. This is how it looks on radioactive iodine scan. जब भी सॉलिटरी नोड्यूल होता है एंड टीएसएच लो होता है, हमारा एल्गोरिथम क्या कहता है, सबसे पहले रेडियोआयोडीन स्कैन करना है. तो रेडियोआयोडीन स्कैन हम इसीलिए करते हैं, देखने के लिए क्या वो एएफटीएन तो नहीं है. अगर कोल्ड नोड्यूल है तब हम उससे एफएनएसी करते हैं. किसी में भी ग्रेव्स में, टॉक्सिक मल्टीनोडुलर गॉइटर में या एएफटीएन में हम लोग एफएनएसी नहीं कर रहे हैं. मैंने किसी में भी एफएनएसी नहीं बताया, किसी भी हाइपर फंक्शनिंग नोड्यूल में हम एफएनएसी नहीं कर रहे हैं. तो अगर वो हाइपर फंक्शनिंग नोड्यूल होगा तो ऑब्वियसली we'll do the radioiodine therapy surgery or the newer modality जैसे सर ने बताया, ethanol injection या radio ablation अभी accepted नहीं है, but they are coming into the series. So they require the higher doses of radioiodine therapy surgically. Usually क्योंकि एक पोर्शन हाइपर वर्किंग है तो यूजुअली हेमीथायरॉयडेक्टमी या लोबेक्टमी सफिशिएंट. ऑब्वियसली ऑपोजिट लोब सप्रेस्ड होता है तो हेमीथायरॉयडेक्टमी सफिशिएंट. सम ऑथर आल्सो एडवोकेट बिकॉज दूसरा लोब ऑलरेडी सप्रेस्ड है, दे एडवोकेट टोटल थायरॉयडेक्टमी आल्सो, बट यूनिवर्सली एक्सेप्टेड थेरेपी इज सर्जरी में यूजुअली हेमीथायरॉयडेक्टमी. अब वेरी क्विकली अबाउट, क्योंकि हमने सर्जरी करा, हमको सर्जरी पढ़ना है, तो सर्जरी की हाइपरथायरॉयडिज्म कॉम्प्लिकेशन क्या हो सकती हैं. जनरल कॉम्प्लिकेशन लाइक एनी कॉम्प्लिकेशन ऑफ एनी डिजीज, पोस्ट फीवर, एटलेक्सिस, यूरिनरी टेंशन वगैरह वगैरह. बट अर्ली कॉम्प्लिकेशन जो हो सकती है थायराइड के पर्टेनिंग टॉक्सिक गॉइटर में, दैट कुड बी ब्लीडिंग, हेमेटोमा, नर्व इंजरी और हाइपोपैराथायरॉयडिज्म. लेट में हाइपोथायरॉयडिज्म या हाइपोपैराथायरॉयडिज्म. हाउ टू प्रिवेंट देम? टू प्रिवेंट, फॉर प्रिवेंशन वी शुड हैव अ गुड एक्सपोजर, गुड लाइट, गुड हेमोस्टेसिस. पैराथायराइड को आइडेंटिफाई करना है बाय द कलर, साइज, लोकेशन. मेटिकुलस कैप्सुलर डिसेक्शन इज द की. कॉम्प्लिकेशन बढ़ती कब है? जब एक्सटेंस ऑफ डिजीज बड़ी होगी, मल्टीनोडुलर बड़ा होगा, रीऑपरेटिव गॉइटर होगा, ज्यादा हाइपरथायरॉयडिज्म होगा, ज्यादा डिसेक्शन होगा, अगर थायराइड कैंसर होगा, या टॉक्सिक या रेट्रोस्टेरनल एक्सटेंशन, कुछ भी चीज, जितना बड़ा सर्जरी का नेक सर्जरी का एक्सटेंट होगा उतना ज्यादा कॉम्प्लिकेशन का एक्सटेंट बढ़ेगा. तो वो हमें स्टेबलाइज करना, माइंड में लेके चलना है कि ये चीज हो सकती है. तो बिगर द ऑपरेशन बिगर द कॉम्प्लिकेशन. सो टेक होम मैसेजेस, हाइपरथायरॉयडिज्म तब होता है जब एक्सेस थायराइड हार्मोन सिंथेसाइज होता है एंड ग्लैंड से सिक्रीट होता है. ये मुझे ध्यान रखना, दैट इज डेफिनेशन ऑफ हाइपरथायरॉयडिज्म. थायराइडोटॉक्सिकोसिस किसी भी समय T3 T4 बढ़ रहा है, या तो बाहर से ले लिया या रेडिएशन टू थायराइडाइटिस या जो मैंने रीजंस बताए, ठीक है. बट हाइपरथायरॉयडिज्म इज व्हेन इट इज सिक्रीटेड बाय द थायराइड ग्लैंड. तो ग्रेव्स इज मोस्ट कॉमन टाइप. 3 therapies, anti-thyroid drugs, radioiodine therapy and surgery. Each therapy has its set of indication and contraindication. That's all.
Thank you, Dr. Kushak, for the very much comprehensive
Thank
rapid
you. बच्चे
revision
हाइपो
of
में चले गए,
hyperthyroidism.
सारा T3 T4 मैंने ही खा लिया है ना.
नहीं. It's all pleasure to have you on this stage. I would request Dr. Ajay Kumar Pal to come upon the dais to kindly felicitate Dr. Kushak Gaurav.
मैं ब्रेक में सवाल पूछूंगा, मैं बता रहा हूँ, अपने टॉपिक से तो जरूर पूछूंगा, कुलरन सर के पे और पूजा मैडम से पूछूंगा, मतलब उनके टॉपिक से पूछूंगा. तो जो बच्चे सोए मैंने देख लिया कौन कौन सोया.
Actually, teachers can teach best when they find the audience alert. And if the audience is sleeping, then you don't feel like teaching. I make either of you stand here and you see the audience with drowsy faces and hanging necks, then you won't feel like speaking. We have a coffee break after this lecture. नहीं सर आप नहीं, आप मैस्टेक्टमी वाले सेशन में आएंगे. नहीं सर आप कहीं नहीं जाएंगे, अभी पे बैठिए, आप कंटिन्यूटी में बोलेंगे. तो अब नेक्स्ट इन लाइन वी आर नाउ मूविंग टू द ब्रेस्ट सेशंस. एंड ब्रेस्ट सेशंस में वी हैव बिनाइन ब्रेस्ट डिजीजेस एंड वी हैव मैलिग्नेंट ब्रेस्ट डिजीजेस. तो ज़्यादा कॉमन क्या होता है? ज़्यादा कॉमन क्या होता है? ओपीडी कितने लोग देखते हैं? हाउ मेनी ऑफ यू आर सिटिंग इन द क्लिनिक्स? मोस्ट ऑफ यू नहीं. तो बिनाइन ब्रेस्ट डिजीज ज़्यादा कॉमन होता है कि मैलिग्नेंट ज़्यादा कॉमन देख? बिनाइन ना. तो इसमें कौन सा रॉकेट क्वेश्चन था एक्चुअली? प्लीज स्टार्ट द प्रेजेंटेशन. So the next presenter is me, which is benign breast diseases, and this is not important for your exams. Nobody is going to ask you questions with the benign breast diseases, but what is most important is that they are so mismanaged by most of you who are sitting and looking at these patients. Now when we'll go through these slides, you will understand कि हम क्या करते हैं और actually क्या करना चाहिए. So this is the idea behind this topic. I'm sure all of you are well versed with the anatomy of breast. It's a terminal ductular lobular unit which has got asyni at the distal end, followed by ductules which drain into the main ducts. And if you compare it, it's like a tree. It's like this tree. The anatomy of breast is like the pattern of the tree, where you can compare these leaves to the alveoli, the stem to the ductules, and the main stem to the lactiferous duct. Correct? सही है ना? ऐसा ही होता है ना कि कुछ और होता है? पक्का? चलो. तो ब्रेस्ट इज अ एवर इवॉल्विंग एंड अ एवर चेंजिंग ऑर्गन. इन्वोल्यूशन होता है ना? उसके पहले प्रोलिफरेशन होता है, फिर इन्वोल्यूशन होता है, प्रोलिफरेशन होता है, इन्वोल्यूशन होता है. सो इट इज ऑलवेज चेंजिंग विद द मेंस्ट्रुअल साइकिल. And because of these changes, certain changes are happening in the breast which are called as fibrocystic disease of breast. Now the term has been changed, and what is it now called? ANDI, ANDI, aberration in involution and aberration in normal development and involution of breast. So there are developmental changes happening, and then there is involution happening. ऐसे ही होता है, पहले आपका proliferation होता है estrogen की वजह से, and then progesterone आता है, तो involution start हो जाता है. So this is how these changes happen. अब ये जो एंडी वाला टर्म है ना, दिस केम वे बैक इन 1987, but still in 2026 most of us are not writing Andy on the paper. We are writing fibrocystic disease, which had been changed long time ago. Correct? तो अब से हम अपना टर्मिनोलॉजी पहला चीज़ है जो चेंज करेंगे. एंड एंडी क्यों टर्म हुआ? बिकॉज दे सेड दैट नॉट एवरीथिंग इज abnormal. Something is normal, then something becomes abnormal, and when the changes become so abnormal, they become a disease which needs certain kind of treatment. तो उस फेज को अंडरस्टैंड करने के लिए फाइब्रोसिस्टिक डिजीज से चेंज करके नाम उन्होंने एंडी कर दिया था. सो यू हैव टू अंडरस्टैंड कि इट्स बेसिकली द चेंजेस, they are all the changes, but when they happen beyond a certain range, they come into the category of a disease. Otherwise they are not disease. Okay? Now we come to the common diseases that you encounter when you are sitting in your clinics. Most common benign problem that you encounter when you are sitting in the breast clinic. क्या देखते? नहीं यार, fibroadenoma का. Mastitis? Mastalgia. So mastalgia is the most common thing. हम सब देखते हैं ना? And most ill managed. Mastalgia में let's not come to the ये concerns क्या होते हैं patient के? पेशेंट कहता है, उसको डर लगता है मुझे कैंसर हो गया. Most of the patients are not coming to you because of pain. They are coming with the concern of having something abnormal, and that is one thing, if you address properly, most of the patients are taken care of. Please mind it. Most of us do not counsel them that there is nothing like cancer when you have a pain, and most of us don't do that. Okay? Now coming to the management, पहले तो हमें ये पता होना चाहिए कि कारण क्या होता है मेस्टेल्जिया का. देयर इज नो प्रूवन कॉज फॉर मेस्टेल्जिया. हाइपर ईस्ट्रोजेनीमिया, लेस प्रोजेस्ट्रॉन, sometimes even increased prolactin levels are proposed to be the causes, but they are just proposed. Engineers will agree. We are all using Primrosa, and we did a study at KG. We found that 90% of the patients are cured by Primrosa and India. So as per us, it works very well, but it is entirely your discretion and your clinical practice whether you want to give it or not. But most of the standard papers do not recommend it. Then other treatment options are tamoxifen. A 10 milligram dose of tamoxifen works wonderfully well for the younger patients who have very dense breast. Then other options which is coming now is ormelofexin or Sevista 30 milligrams alternate days or twice a week. Works wonderfully well, and also the recurrent pain which happens after the withdrawal of these drugs is lesser with Sevista when you compare it with any other management. Then other options are danazole, which comes with its own profile of side effects, so not really recommended routinely, but yes, you can use it once in a while and it also works wonderfully well. Then bromocriptine, lizuride, goserelin, these are all for the refractory cases which are not for which other drugs are not working. And sometimes you may even need to do a lignocaine injection when there is a focal point of tenderness, and rarely some patient may require mastectomy also. Okay, so we come to the next, which is fibroadenoma. Fibroadenoma में क्या करना है, होता क्या है fibroadenoma? We discussed about the asyni and we discussed about the ductules. So the mesenchymal deposition in the asyni is basically a fibroadenoma. It's nothing. तो सबसे पहली प्रॉब्लम ये है कि फाइब्रोएडेनोमास में मैलिग्नेंसी होगा ऐसा सोच के पेशेंट डरता रहता है. यू हैव टू एश्योर देम दैट इट इज़ नॉट गोइंग टू गेट मैलिग्नेंट. जितना चांस पूरे ब्रेस्ट में मैलिग्नेंसी होने का है उतना ही इस फाइब्रोएडेनोमा में होने का है. सो दैट इज़ वन रीअश्योरेंस दैट यू हैव टू डू. बट देन डू यू नीड टू एक्साइज ऑल फाइब्रोएडेनोमास, यस और नो? एक्साइज करना है? नहीं करना है ना? कब तक एक्साइज नहीं करना है? किस साइज तक हम छोड़ सकते हैं? 2 सेंटीमीटर्स. 2 सेंटीमीटर्स के नीचे हमको एक्सरसाइज करने की ज़रूरत नहीं, बिकॉज दे माइट जस्ट स्पॉन्टेनियसली रिग्रेस, बट बियॉन्ड 2 सेंटीमीटर्स दे विल नॉट रिग्रेस. तो इसलिए बियॉन्ड 2 सेंटीमीटर्स यू कैन स्टिल रिकमेंड अ सर्जरी, बट लेस देन 2 यू नीड नॉट. अब तो बहुत सारे लेस इन्वेजिव प्रोसीजर्स लाइक मैमोटोम एबलेशन, माइक्रोवेव एबलेशन, radio frequency ablation, all this is coming into view for the ablation of fibroadenomas. We are not using it at the moment, we are using a mammotome, but yes, you can use these newer techniques for the smaller fibroadenomas. For the larger fibroadenomas which are more than 5 centimeter, also called as giant fibroadenomas, they would require a surgery. Okay. Now come to the issue of multiple fibroadenomas. Now, yes, another question which comes is, do I need to FNA a fibroadenoma routinely? So, FNA is only done when the fibroadenomas are atypical. What is the meaning of atypical? When it has some features on ultrasound which suggest that there could be a problem. Now look at this picture. Fibroadenomas are usually quite oval. They are very well defined. They have a capsule around them. They are wider and they have macrolobulations. With macro, I mean these gross lobulations happening, okay? But if they are micro, like angles coming up, then it means that there is a problem with these fibroadenomas and they would need a FNA or a biopsy. So if you think that the lady is young, less than 35, fibroadenoma is quite typical, then you need not FNA it, you can straight away go for an excision. But if there is something abnormal, there are some cystic areas, there is increased color flow, there are microlobulations, then you need to biopsy them and then only proceed with surgery. Diagnosis for fibroadenomas are phylloides tumor, the benign phylloides 1. Medullary carcinoma, triple negative breast cancers closely mimic fibroadenomas. So please note that the lady who is more than 35 present with fibroadenoma should be biopsied. It should never ever be taken as a simple fibroadenoma. Okay. So the indications for surgery we just discussed. Anything which is atypical in fibroadenoma should be excised after getting out a biopsy. Now, multiple fibroadenomas is another issue. A girl comes to you with multiple fibroadenomas here and there, and then you don't know what to do. They do not require surgery unless they are large. If they are very big, of course they would require surgery. But the chances of having a recurrent fibroadenoma is very high in them. And if you excise something, then the blame will fall onto you कि सर आपने ये निकाला था और अब मुझे दोबारा हो गया. Although she does not know her pathology कि actually she is prone to develop multiple fibroadenomas. इसलिए please don't ever take the onus of removing multiple fibroadenomas or be prepared for getting the blame later on in your life. Okay. Now comes to phylloides. Phylloides looks very much similar to fibroadenoma except for its stromal mitosis and stromal cellularity. So that is something that we cannot really make out on doing a FNAC. We need a core biopsy for that. But how would you make it out on ultrasound? Can you make out on ultrasound that you are looking at a fibroadenoma or a phylloides? देख सकते हैं? Clinically देख सकते हैं, कभी कभी दिखता है. If you are looking at some cystic area, suppose आपने ultrasound किया fibroadenoma का and you are looking at a cystic area in the ultrasound, be sure that you are looking at a phylloides. Be it a benign phylloides, but it will be a phylloides. तो इसलिए कुछ भी अगर एटिपिकल हो रहा है फाइब्रोएडेनोमा में, लाइक सिस्टिक एरियाज मींस नेक्रोसिस हैपनिंग, इट इज नॉट कॉमन इन अ फाइब्रोएडेनोमा, सो प्रोबेबली यू आर लुकिंग एट अ फिलॉइडस. क्लियर? तो मेजॉरिटी तो बिनाइन ही होते, बट देयर आर 15% बॉर्डरलाइन एंड 10% मैलिग्नेंट. ओके, हाउ वुड यू डिस्टिंग्विश इट फ्रॉम अ फिलॉइडस या फाइब्रोएडेनोमा डेवलपिंग इनटू फिलॉइडस when the patient is older, that is more than 35-40, and the fibroadenoma suddenly increases in size, or a new lump appears which is very well defined and it is increasing in size rapidly. There will be prominent dilated veins, and suddenly because of the pressure on the overlying skin there will be ulcer formation also. There was a time when we actually started chemo for one patient because she had a huge lump which ulcerated, and we did not have the time to wait for the biopsy and we gave her the chemo, and then the biopsy came out to be phylloides. So don't do these mistakes. I made this mistake once, but because we were in college we got saved. Then we didn't give her any chemotherapy further and proceeded with surgery. But this is how the presentation can be so dramatic at times. So anyone getting ulcerating skin with a lump which is very well mobile, please think of phylloides also. So this is how the picture is. Yeah, you can look at this this looks like a pretty well defined lesion, but it has got cystic area here, and see the multiple cystic areas here, very pathognomic of having a phylloides if you look at a lesion like this. So as I said, FNAC cannot distinguish a phylloides from a fibroadenoma, and you need to do a biopsy for it. Okay. So this is all in your textbook. Stromal cellularity and mitosis is the component which distinguishes a benign phylloides from a malignant phylloides, and this is what the pathologist will look at. So treatment, wide local excision, take it out with a 1 centimeter margin. Radiation is not necessary except for the recurrent phylloides or for the malignant phylloides. For the benign ones, they do not give radiations. Now comes this breast cyst. How many of you see breast cyst? I find it very funny because some of the surgeons recommend excision for the breast cysts, and we just put in a needle and remove it, and the patient is happily dancing that the lump is gone, and we feel ourselves like God that day, although we haven't done anything great. So this is the breast cyst all about. What is breast cyst? It is basically the progesterone mediated involution which has led to the formation of a cyst. Now what happens is, this is of 3 types: simple, complex and complicated cyst. Now this is how the simple cyst will look like, pretty anechoic. But if you look at the complicated cyst, you would see some contents, and if you look at the complex cyst, you would see some solid areas. So these complicated cysts are the one with solid areas, and these solid areas have vascularity that they would require certain kind of biopsy. For the complicated cysts, they are generally the infected one. Those simple cysts which got infected, and you just need to aspirate it and start the treatment on antibiotics. Any simple cyst, all it requires is just put in a needle under ultrasound guidance, remove the contents, and it is gone. It won't recur also, but it sometimes it will just present like a painless mass which has increased in size. You put in, do an ultrasound, see a cyst, aspirate it, and it's gone. Not even all the cysts require aspiration. Just those cysts require aspiration which are painful, they were sudden onset, and they were a concern to the lady. So this is how the simple disease of breast are managed day in and day out. And I think with this we finish our talk. Thank you so much.
Thank you so much, ma'am. It was indeed a very informative talk. Now I request Professor Jitendra Kumar Kushwaha sir to please felicitate our speaker. Please a round loud of applause.
Thank you. Sir, to make you comfortable, can we have a 5 minute
So yeah, I request all the delegates to go for 5 minutes coffee break. We will resume back in exact 5 minutes.
So we have Dr. Gaurav Agarwal sir with us. He's a prominent breast surgeon in Lucknow. He's the professor and head of department in endocrine surgery at SGPGI. So please only 5 minutes, and we request you to join back fast. Thank you so much.
Honor for me to introduce our next speaker, Dr. Gaurav Agarwal. He's a professor and head currently working as the head of endocrine surgery department at SGPGI. We welcome you, sir.
So good morning. Uh, Firstly, I thank Department of Surgery, KGMU, and specifically Dr. Sonkar and Dr. Geetika for this invitation. I've been asked to talk about early breast cancer, and the topic given to me is actually a three-in-one topic. I have to talk about surgery of the breast cancer, oncoplastics, or some basics about it, and then how are the nodes managed in patients with early breast cancer. So let's see what all can I cover in the time allotted to me. Um, and we'll learn a few things about early breast cancer management here. And then I request or invite all of you to consider joining us for the next SEPGI breast course. And I promise you, you'll get a lot of other very interesting topics covered during this. That's on 3rd to 5th of April, 6 weeks from now. So, what's early breast cancer? I'm sure as residents in surgery or practicing surgeons, all of you manage early breast cancer patients. These are patients who are primarily operable breast cancers. And in terms of TNM stages, these are T1 to T2, which means less than 5 centimeter size, with either no palpable nodes, or if at all there are lymph nodes, those are mobile. So that means N0 to N1. And we also include T3 N0 in this group, which means large tumors but without any metastatic nodes. We also call this group as large operable group, but then part of early breast cancer. So that is the group of patients we will be talking about today in this talk. How is early breast cancer treated? Surgery is the mainstay, is the primary treatment for early breast cancer, but surgery alone is not sufficient in majority of patients. So it can be safely said that it is the mainstay of a multidisciplinary team treatment or multidisciplinary treatment, and not the sole treatment. Today, what we want to do while treating all cancers, including breast cancers, is that we want to do minimal essential treatment. Unlike, say, 4 decades ago or 5 decades ago, when the practice was to bombard the cancer with every possible method that you had in your armamentarium. So it's no longer maximal tolerated treatment, is the minimum essential treatment that we do. And when treating breast cancers, early breast cancers, we have to take care of the primary disease in the breast as well as the lymph nodes in the axilla, both. And breast conservation is desirable in majority. I'll discuss more in detail about the breast conservation. Mastectomy still is required for certain patients, either those who do not who have a contraindication for conservation, or for certain other reasons. And more we are moving towards operating patients after some bit of neoadjuvant systemic treatment, and we'll discuss more in detail about that too. So remember, keep in mind while discussing breast cancer treatment that the goal is to achieve cure when we are treating patients with early breast cancer. However, it is not just adding years to life, but life to years, which means quality of life, preservation of quality of life, or improvement of quality of life is also a goal. So oncological cure with preservation of quality of life is the goal of treatment when we are talking of early breast cancer patients, and this we want to do while avoiding any major morbidity. What are the prerequisites before we embark upon treatment of early breast cancer patients? We have to establish a foolproof, absolutely robust diagnosis, which is done by use of a triple test. The three components of triple test are clinical examination, imaging in form of mammography and ultrasonography, and a core biopsy. And core biopsy is, I would say, an essential component, diagnostic component of this triple test. No longer it is appropriate or acceptable to treat patients without a core biopsy. I might sound radical to some of you, but so be it. We have to have a histological diagnosis before we start treating a patient with breast cancer for various reasons, and that's besides the topic of my talk today. So, I'll be now on discussing the surgical treatment of breast primary, which will include a bit of discussion on breast conservation and some basics of oncoplastic surgery and mastectomy too, and then surgical staging or treatment of the axillary nodes either in form of a sentinel lymph node biopsy or axillary dissection. So, let us look at the management of breast primary first. Like every other cancer, the treatment is dictated by various factors. One central theme or central basis of treatment is the tumor stage. When we are dealing with the primary in the breast, if you are dealing with a small T1 or T2 cancer, there are number of patients who can be operated primarily. That means surgery is the first treatment, and then rest of the adjuvant treatment will follow. However, there are numerous circumstances today, as we will discuss more in detail, where we now, even with a small tumor, we treat them with neoadjuvant systemic treatment and then only operate. Conservation is the norm. If any one of you is asked in an exam what is the primary surgical treatment for early breast cancer, it has to be conservative breast surgery. However, there would be certain patients who would require mastectomy. So, exceptions to this rule are there. For patients who have a large T2 or N1 disease, so still early breast cancer, they can be offered neoadjuvant systemic treatment and then post NSCT surgery, and the same is true for large tumors, T3 tumors, where the norm currently is neoadjuvant systemic treatment followed by conservation or mastectomy, whatever is appropriate. So, conservation is the key for various reasons. Not only it preserves the breast, and so there is a psychological advantage to the patient, there is oncological benefit derived from conserving the breast today. There is better overall survival in patients who undergo conservation compared to those who undergo mastectomy. And so, this is a myth that needs to be busted. Conservation can be done as a primary surgery, or it can be after some sort of a neoadjuvant systemic treatment, and also we are using oncoplastic procedures to facilitate safe and effective conservation. And one of the immediate goals while doing breast conservation surgery is to achieve infiltration free margins. All the margins of the specimen that you resect have to be free of any tumor, either invasive or DCIS, and the current guidelines to that is that we need to achieve no tumor on the inked margins, which is we do not have to achieve a very wide margin, but ensure that the resected margins are free. Mastectomy is still required in some certain patients who are either ineligible for conservation or are unwilling for it. Why breast conservation? It is the standard of care for majority of early breast cancer patients. Who are these patients? Early stage, low risk, and those who have low risk for local recurrence, those who do not have any contraindication for radiation, and where we can do a safe wide local excision or a quadrantectomy without compromising on survival in terms of ipsilateral breast tumor recurrence or chest wall recurrence or overall survival. So, all of these goals are easily met in patients, majority of early breast cancer patients, by conservation. Breast conservation's treatment has two essential, or rather three essential components. One is surgery itself, second is high quality histology or pathology reporting, and third is management of the residual breast by adjuvant radiotherapy. So, all these three components have to be focused on. What established the role of breast conservation in management of early breast cancer? There have been number of trials, very high quality, large prospective trials, which have initially established no compromise on cure rates, overall survival rates in patients with early breast cancer by conserving the breast. And the old gold standard of modified radical mastectomy was not found to be superior to conservation. This is a list of some of those initial trials, and more recently we have had updated 20 years results of some of these seminal trials. One of them was NSAPP B06 trial. I'm sure majority of you have read about this trial, which was an American trial comparing outcomes of mastectomy and breast conservation with radiation or without radiation. And the 20 years updated results have established or reconfirmed the same facts, that by conserving the breast, you are not compromising on overall survival, disease or disease-free survival. The same was also brought out by updated results of Milan trial, the European trial. Again, this trial also established the very same facts, that you are not compromising on cure by conserving the breast. However, we have moved forward now. Earlier, say 10 years ago, we would only talk about equivalence of conservation versus mastectomy. Today, we are looking at superiority of conservation compared to mastectomy. Why? There are any number of observational studies, prospective trials, and meta-analysis which have established that patients who undergo breast conservation have better overall survival. They, in certain studies, there may be some observational bias, some bit of observation methodological flaws, but then this inference is now being drawn from multitude of these trials and meta-analysis. So indeed, all these observational studies and certain other studies have established no compromise or better survival with conservation compared to mastectomy. One factor which used to plague, or one fact which used to trouble majority of us, was patients who undergo conservation have higher local recurrence rates. Even that is now busted in certain high quality recent trials and studies. Because of the high quality of surgery and adjuvant radiation, it is no longer true that patients who undergo breast conservation have higher local recurrence rate, like it was brought about by this Canadian study. So in a sense, breast conservation today is not just equivalent to mastectomy for managing early breast cancer, it is superior to mastectomy. There continue to be a few contraindications, and these contraindications are shrinking by the day. Very few absolute contraindications of conservation in early breast cancer patients, and for us, the major contraindication is patient not willing for conservation. Sadly, despite being counseled about superiority of breast conservation compared to mastectomy, still a large proportion of patients do not accept conservation as the standard of treatment. However, multicentricity, multiple tumors located in different quadrants of the breast, or presence of diffuse microcalcifications, and indiscrete tumor which you cannot safely excise and achieve negative margins, these are certain absolute contraindication. Extensive DCIS is no longer an absolute contraindication, though has to be considered very safely. And then, as I said earlier, adjuvant radiation to the remnant of the breast is an essential component of breast conservation. So if a young patient has some contraindications to radiation, for example, some connective tissue disorder, scleroderma, etc., those again have to be taken into consideration as a contraindication. How is a conventional breast conservation surgery done for a small tumor? All that is required is what I call as no-see surgery, which means you would not like to see the tumor. You stay away from the margins, palpating the tumor while operating, stay away from it, ensure that you have taken out the tumor with an envelope, 360-degree envelope of normal breast parenchyma all around, and leave, vertically from superficial to deep, it is a full thickness excision from skin or subcutaneous tissue right down to the pectoral fascia. The specimen has to be oriented for the pathologist to examine, and you can see here at the core of the specimen is the tumor, and there is surrounding normal breast parenchyma. This is how you will be able to achieve a negative margin. Breast conservation treatment cannot be safely performed without assessment of margins. How is it done? You have to ensure that margins are negative, not infiltrated. If in case any of these margins are infiltrated, then you have to go back and re-excise that infiltrated margin. At times, there may be multiple attempts, even after multiple attempts, you will still find infiltrated margins. So in those rare cases, you may have to resort to doing a mastectomy or a segmental mastectomy. You can use intraoperative frozen section, though it's not essential. It is time consuming. It's not universally acceptable, but it does help reduce the possibility or rates of reoperation for margin re-excision. One of the goals or one of the important goals of breast conservation is preservation of body form or body contour or cosmesis. So if in case you have to compromise on cosmesis while doing breast conservation, you are not really doing justice to the patient. While compromising on oncological cure is certainly unacceptable, so is uh, not achieving acceptable cosmetic results. So this patient has undergone a breast conservation surgery, and you can see while undergoing adjuvant radiation therapy, there is no distortion of the body contour, the breast shape, contour or symmetry, and that is what you would like to achieve in majority of patients. However, it is not always possible to achieve good cosmetic outcomes while doing a radical wide local excision or breast conservation surgery, and in that scenario, oncoplastic procedures come to our rescue. What is oncoplastic breast surgery? It is a single operation which incorporates an oncologically sound procedure plus a plastic reconstructive procedure to ensure invasion free margins yet cosmetically acceptable outcomes, achieving acceptable breast symmetry, contour and good cosmesis, and while also achieving negative margins which result in low ipsilateral breast tumor recurrence rates. This we can achieve by using certain technical or certain surgical techniques that I will discuss. Why is oncoplastic breast surgery required? Here are some examples. By doing a simple wide local excision, you can cause post-lumpectomy deformity, pectoral adherence, inferior pole deformity like this, or volume loss, or various other distortions to the body shape or the breast shape. And this all can be prevented by oncoplastic breast surgery. The definition of oncoplastic breast surgery is combination of best oncology surgery and aesthetic outcomes. But the principle is that the oncological outcomes must never be compromised to achieve cosmetic outcomes. So the twin goals of oncological cure and cosmetic outcomes are to be achieved, but never at the cost of the first, which is oncological cure. Uh, Yeah. So I'll have to skip some bit of details in interest of time, but primarily oncoplastic breast surgery has been divided into two types: volume displacement and volume replacement, where volume replacement means that you are bringing in some tissue from neighborhood like the chest wall or the latissimus dorsi, or and these are also been classified into level 1 and level 2. Level 1 oncoplastic procedures are required where the anticipated breast volume loss is less than 20%, where you can safely restructure or reshape the breast and yet achieve good cosmetic results. Level 2 procedures are required when the anticipated volume loss is between 20 and 50%, where you may have to use a mammoplasty technique or reduction technique or some sort of advanced flaps. And these can also be mastered with some bit of training. For patients who require even larger volume excisions, even those can be taken care by doing what is commonly called today as extreme oncoplasty. And which exact procedure would be required depends on various factors: location of the tumor in the breast, its location, the relative size of the tumor to the breast in an individual patient, and certain other factors. The selection is based on size of the tumor and breast to tumor ratio, location, the breast density and habitus, and the patient's choice. There are certain procedures which are very straightforward, not so complex. To the contrary, there are others which are time consuming, more complex procedures with a possibility of some complications. So it depends on the patient's own choice, what the patient wants. We often use the dial clock method to document the location of tumor in the breast, and depending on the dial clock position, various procedures can be planned for individual patient. And this is just a collage of some of the procedures which can be performed. As I said, the commoner procedures are called volume displacement procedure, and these are relatively less complex procedure. One of the commonest one performed is what we call as round block, where we make a circumarular incision and excise the tumor and reshape the breast, whereas the other possibility is a volume displacement level 2 procedure, where this patient has undergone a mini LD flap for replacement of some part of the breast. As you can see, this patient had a relatively small breast, so excising this volume and not replacing it would have resulted in considerable deformity. So neoadjuvant systemic treatment is more and more being employed in patients, especially in certain biological subtypes. HER2 enriched, triple negative, we treat the patients with neoadjuvant systemic treatment and then undertake surgery. Even for luminal B cancers, for large proportion of patients, we are using neoadjuvant systemic treatment. Depending on the biological subtype, one of the factors that is important, or one of the important outcome yardstick today is achievement of pathological complete response to neoadjuvant systemic treatment. We know we can individualize or de-escalate surgery as well as other treatment if the patient has achieved pathological complete response. So this is indeed one important consideration today for treating early breast cancers, and then we can do a safe and effective breast conservation surgery, because following de-escalation or following downstaging of the cancer with neoadjuvant systemic treatment, what you require to remove surgically is a much smaller volume of disease compared to the primary disease that was there with before the neoadjuvant systemic treatment, and then these patients need to be followed up. Mastectomy is still contemporary in patients who are either who do not accept breast conservation, those who have involved surgical margins after the excision, those who have multicentric disease, diffuse DCIS, those who have recurrence after breast conservation, those who are predisposed to multiple tumors like BRCA1 and 2 mutated patients, or those who have connective tissue disorders, or those who have received radiation to the chest wall earlier. And what is required while doing mastectomy is you place a appropriate incision, raise good quality full thickness flaps, and do a complete mastectomy, and then achieve a tension free closure with a suction drainage. And this is the kind of flat chest that you would expect after the wound has healed well. Of course, you can reconstruct the breast using various methods. This patient underwent because the patient had a modest sized breast, so a reconstruction could be done by autologous means using a latissimus dorsi flap. Of course, you have options of conservative mastectomy, nipple sparing, skin sparing, appropriate conservative mastectomy, where if the skin is not involved, you don't have to excise the whole skin of the breast. If the nipple is not involved and the tumor is fairly away from the nipple, you can conserve the nipple too, and so reconstruction would be easier, better in such a scenario. Very quickly, how do we manage axilla in patients with early breast cancers? We either do sentinel lymph node biopsy, which is the appropriate or which is the preferred technique today, or else we can do axillary dissection. Again, it is the clinical stage of the disease which dictates what procedure would be performed. Patients with N0, uninvolved axillary nodes, would undergo sentinel lymph node biopsy. Patients who have N1 disease, they would undergo either a primary axillary dissection, or they can be downstaged by use of neoadjuvant systemic treatment, and then following that we can do post NSCT sentinel lymph node biopsy. So I'll have to skip some part of it. The reason why we do sentinel lymph node biopsy and not axillary dissection is to reduce the morbidity of axillary dissection, and this is performed using two dyes, a blue and a radiopharmaceutical or a fluorescent dye, and using that we can reduce the morbidity of axillary surgery or axillary dissection. So if there are any questions regarding the axillary surgery, I'll be happy to take those, and because I've overshot my time, I'll end my talk here.
Thank you so much, sir. It was indeed an insightful talk. I request Pankaj sir to kindly come and felicitate the esteemed guest.
Okay, so the question is about radiation following axillary dissection. We let us restrict to early breast cancer patients. Locally advanced will be discussed separately. In a patient with early breast cancer, today we would do axillary dissection only if there are metastatic nodes. So, if you have done sufficient or adequate axillary dissection, which is removing minimum of 10 nodes, and the nodes are the disease is within the nodes, there is no extra nodal spread, then there is no need for axillary radiation. Of course, the need for chest wall or breast radiation is separate, but nodal radiation is no longer required. Nodal radiation is required only if there is extra nodal spread of the disease.
Sir, if you're doing a surgical axillary dissection, should we still give axillary radiotherapy to that area?
Okay, so now you are using a term axillary radiotherapy, and I am using a different term, which is nodal radiation. Axillary radiation is no longer the standard. When we are talking about adjuvant radiotherapy following breast conservation or following mastectomy, the need for nodal radiation is determined by the stage of disease, and only if there are metastatic nodal radiation is required. That nodal radiation can be infraclavicular and supraclavicular foci and avoid the axilla unless there is extra nodal spread. So why axillary radiation is avoided? Because if you have done a full axillary dissection, on top of it you do axillary radiation, nodal radiation, the lymphedema rate is much higher, and you want to avoid that. And it does not bring down, in absence of extranodal disease, there is no definite benefit of adding axillary nodal radiation. Does that answer your question? Thank you.
Thank you.
I request Sonkar sir to please felicitate the esteemed guest.
So this year the NEET had questions about oncoplasty. They had described the location of tumor and they were asking which technique is better for this kind of tumor, like bat wings was there and round block was there. So all this that was there, sir, this year NEET. So I'm saying that this year NEET had questions about oncoplastic breast surgery. They had described the location of tumor and then they asked about the best surgical technique to remove this tumor by oncoplasty. Yes, sir. NEET PG. NEET super speciality, sorry. Yeah. So the residents who work and who continuously see oncoplasty could answer those questions, but not all of them.
Schwartz है और दूसरी कौन सेबेस्टन इट कंटेन एवरीथिंग तो वो सुपर स्पेशलिटी तो एक मिस नंबर इंडिया में ना हम लोग उसको सब स्पेशलिटी को सुपर स्पेशलिटी बोलते हैं वो पढ़ोगे तो सब और ये देखना भी है थैंक यू
Our next session is on locally advanced breast cancer multimodality strategy for surgeons, and the speaker is Dr. Ashish Chaudhary sir, Professor Surgery, GSVM Kanpur. We welcome you, sir.
जब पीछे कैसे जाना So good morning everybody. First I would like to thank Department of Surgery for inviting me on this talk, locally advanced breast cancer. I think sir has covered literally all things regarding the breast. ज़्यादा डिफरेंस नहीं है, बट डिफरेंस यही है कि कब क्या कैसे करना है. Early invasive means tumor that is localized to breast, and locally advanced breast carcinoma, that means tumor has advanced enough that goes beyond the breast, but not at the level of metastasis. That means this can include the large primary tumor more than 5 centimeter, that is T3, tumor involving chest wall, skin involvement, or other things like this T4, D4 and inflammatory carcinoma. So these three things, T3, T4 and inflammatory breast carcinoma, all these come into the locally advanced breast carcinoma. And obviously N2, N3, that means tumor has spread to local draining area, local this nodal basin up to the regional nodal basin. That means loco-regional spread beyond the breast and draining lymph nodes. But it has no clinically detected metastasis. So local regional extension, but without metastasis, it comes under locally advanced breast carcinoma. So stage wise, it's stage 3 disease, 3A, B and C. Okay. So what is the motive to divide all these TNM staging, all these in groups? Ductal carcinoma in situ, early invasive, locally advanced breast carcinoma and metastatic disease. Because breast is a systemic disease, so treatment according to the stage varies. And purpose is also to cure the tumor along with, yes, sir has already throws light on this. So some of the feature of or some presentation of locally advanced breast carcinoma, that means satellite nodule, ulceration, orange appearance, fixity to chest wall, skin fixity, teething, nipple retractions. All these features suggest that this could be, or this is locally advanced breast carcinoma. Regarding, I will not go into the detail, you can go through the books or textbooks are there, detail about the staging. So in this early invasive stage 3 comes in the locally advanced breast carcinoma. In some textbooks, as a substance, they have included this stage 2B also into the locally advanced breast carcinoma. But what is the difference? Difference between early invasive breast carcinoma and locally advanced breast carcinoma is the approach to the treatment. It's a multimodality treatment for locally advanced breast carcinoma. Purpose is to downstage the tumor for a better resectability and so that morbidity to the patient is decreased. सर ने बताया पहले अभी कि पहले कैंसर ट्रीटमेंट एकदम एग्जॉस्टिव bombardment, सब निकाल दो जितना निकल सकता है, but nowadays scenario has been changed. We have to give equally the quality of life to the patient. So in the workup, the routine basic से start करना है, basic history and detailed clinical examination to assess the exact this tumor. For that, first suspicion of the malignancy, then confirmation of malignancy, and then staging of the malignancy. All these things you have to do and that can be on based on the different methods on investigation. That's a for imaging technique, USG breast and axilla, mammography and MRI. And certain indications are there. Histopathology is must. Nowadays, core needle biopsy, as sir has already told you that it is mandatory. Just and after metastatic workup, go for genetic counseling for screening any hereditary disease. If you are suspicious of any hereditary disease, go for all these things. So during examination, what you have to go for detailed examination, then don't forget to examine regional lymph nodes, that is the axillary lymph nodes. This is very important. Never forget to examine. होता है कई बार जल्दी जल्दी आप ब्रेस्ट को देखा और बड़ा सा मास है, छोटा सा ही मास है, आप एक्सपेक्ट कर लेते हैं कि हाँ यहाँ कोई lymph node होगा नहीं, but always examine the axilla properly. Give time to this examination. Sometimes you may miss. And imaging, ultrasonography, less than 30 years, younger age, better, ultrasound is better in younger age, mammography is better in older age because of breast density. Breast is less dense in older age, and mammography give because we have to see the background. Pad confirms are black. And what are the role of MRI? In MRI, better for if there is implant, recurrence, or multicentric disease, or if you are evaluating for high risk patient. Then FNAC and core-needle biopsy. Core-needle biopsy, this is this is mandatory because it provides adequate tissue for histological grading and ISC testing, so that we can differentiate, we can know the molecular subtype of the this carcinoma breast, because on that basis you will decide which therapy is best for the patient and what is the prognosis about the patient. How to do, so detail, core needle biopsy, what important things you will look in the biopsy, just not just a confirmation of the disease, histological subtypes, histological grading, it's a what about grade 1, 2 or 3, and then subtypes depends on the this ERPR and HER2 status and Ki67 proliferation index. On the basis of these findings, you can classify the subtype of the tumor as luminal A, B, triple negative, HER2 enriched, or Claudin. In this, what is luminal A? Either or ERPR positive and HER2 negative, Ki67 low. It has this variety of carcinoma breast has best prognosis. So best prognosis. Luminal B, because of this high 67, it's a more aggressive than luminal A. And triple negative, it's a all three are negative and worse prognosis, and HER2 enriched tumor needs required a different scenario for treatment. So after deciding all these subtypes, you have to decide what neoadjuvant systemic therapy you have to give or what type of surgery you can give. Apart from them, some genomic tests are there that is helpful for prognosticating the disease. You can see for about prognosis, you can assess some recurrence score, and you can tell the patient आपका ये आया है और इसके हिसाब से इतना रिकरेंस के चांसेस है, इतनी प्रोग्नोसिस है, बिकॉज ट्रीटमेंट आपको उस पेशेंट को क्या देना है, पहले न्यूरोजन कीमोथेरेपी देनी है, डाउन स्टेज करना है ट्यूमर को, पीसीएस करना है कि मैस्टेक्टमी करनी है, आगे उसकी क्या प्लानिंग है, पूरी एक प्लानिंग आपको पेशेंट से डिस्कस करनी है. वी हैव टू डिस्कस ईच एंड एवरीथिंग. ऐसे नहीं कि आया पेशेंट सर्जरी कर दिया हो गया काम. यू हैव टू टेल डिटेल प्लानिंग ऑफ द पेशेंट. ये एक दिन का काम नहीं है, काउंसलिंग भी करनी होगी. कई बार पेशेंट बीसीएस के लिए तैयार नहीं होते हैं, बट आइडियल कैंडिडेट हैं बीसीएस के लिए. बट फॉर दैट यू हैव टू गिव प्रॉपर टाइम काउंसलिंग टू द पेशेंट. दिस इज़ वेरी इंपॉर्टेंट. अल्टीमेटली डिसीजन पेशेंट का है, आपको नहीं थोपना है ना. कई बार पेशेंट एंजाइटी में रहता है कि ऑपरेट करने के बाद भी कैंसर है, कैंसर है, कैंसर है, तो फिर बीसीएस में हम ट्यूमर छूट जाएगा. तो उस एंजाइटी को आपको काउंसिल करना पड़ेगा. अगर पेशेंट काउंसिल हो गया तो ठीक, नहीं तो आपको फिर मैस्टेक्टमी ही करनी पड़ेगी. तो व्हाट आर द डिफरेंट जीनोमिक टेस्ट? दे आर मल्टीपल, लाइक oncotype DX. This oncotype DX has been incorporated in new AJCC scoring, TNM staging. Mama print that's used, that it utilizes the 70 genes. Then FAM50, it utilizes endoprict. All these are the for prediction of recurrence and with certain conditions. So ये अभी experimental phase में, not adopted everywhere, but oncotype DX has been adopted in AJC system. And then metastatic workup, PET scan, CT scan, bone scan, what to do, how to do. I will share this PPT to the group. Okay, don't worry. You can take this. अभी ध्यान दो, ठीक है. क्या डिफरेंस है पेट स्कैन और CCT में फॉर मेटास्टेसिस वर्कअप और कंपेरेबल फॉर सिस्टमिक स्टेजिंग? Basic difference, PET is detect early this occult distant metastasis, and CT better for small pulmonary nodule, but both are comparative. Early breast cancer, what to do? Is it mandatory to do all these things, do these investigation? Not required. If only if patient is symptomatic, if any symptom suggestive of metastasis, then you will go for that. But for LABC, this is required. If PET scan is not available, at least CT and bone scan can be done. Okay. For similarly bone metastasis, what is the limitation of PET? Only availability and cost. But अब धीरे धीरे काफ़ी जगह available हो रहा है. So what are the different modalities for treating LABC? Surgery, main cornerstone, to control local disease. To control local disease, surgery is the main. What about chemotherapy? Chemotherapy का purpose क्या है? To prevent recurrence and long time survival. ठीक है? Then radiotherapy, again loco-regional control. And hormonal therapy in positive patients, just to prevent recurrence and better survival. Okay, and targeted therapy in HER2 new enriched variety, just the same thing, survival. So in LABC in stage 3, what is the motive? Motive is to downstage the tumor. ठीक है, to downstage the tumor so that it will become resectable or operable. But you can see this 3 N1 M0 stage, it can be operated. You can operate, but only for grade 1 and 2 and ER, PR positive and HER2 negative. This is a luminal A variety and grading 1 and 2. But if grade is grade 3, better to go for neoadjuvant chemotherapy first. Okay, new urgent systemic therapy is important. For all these, the algorithm for the treatment is start after workup for metastasis, when it is confirmed, staging is confirmed, this is stage 3 disease, you have to give neoadjuvant chemotherapy, then assess the response. What is the response? If it's a complete response or partial response, go for surgical therapy, different options for that. Uske baad, after that, go for adjuvant therapy, and then one category is non-response therapy, non-responsive to the therapy. In that, what you have to do, you have to switch to the alternate systemic therapy, that is second line chemotherapy or alternative radiotherapy. And तब भी response नहीं है, तब क्या करना है? Then you have to individualize the therapy according to the patient need, either surgery, radiotherapy or chemotherapy. So what are the benefits? Important benefits are, it may facilitate breast conservation. Neoadjuvant NACT will facilitate breast conservation. Inoperable tumors can be changed to the operable stage. Tumor-free margin can be achieved, and it provides time for genetic testing. At least because of certain medical condition, if patient is not fit for surgery, then you can start this neoadjuvant chemotherapy also. It will buy the time. It's not working. So indication, what are the indications of NACT? T4 tumors. This is NCCN guideline. इसमें क्या है? That all stage 3 tumors, there are certain condition in operable disease. Certain condition in operable disease, that is T3N1, where you can or you will give neoadjuvant chemotherapy, that is large operable tumor that is unsuitable for BCS. In that case, you will give chemotherapy to downstage the tumor to decrease the size of the tumor so that BCS can be done. In triple negative breast cancer and HER2 positive disease, the stage is T2 or N1, clinical stage. In that case, you have to first give neoadjuvant chemotherapy, then only plan for surgery. And when surgery needs to be deferred, that's the same scenario. Guidelines are there. कैसे देना है? At least minimum 3 to 5 cycles before response assessment आपको देना है. 6 to 8 total complete करनी है, ठीक है? What are the standard regimen? Tetracycline-based therapy है, doxorubicin, epirubicin, and followed by taxane. It's a sequential treatment. Start with anthracycline and followed by taxane. Anthracycline, important toxicity is cardiotoxicity, 2 more minutes, and taxane neuropathy. Special situations, trastuzumab, pertuzumab in yes, okay. Radiotherapy is usually not required, but only for can be given in the non-responder to the chemotherapy. I think is it. Go through all these. Now, how to assess the response? How to assess the response? Response assessment for response RECIST criteria is that by clinical radiographic and pathological assessment in there. There is a complete response, partial response, and then stable disease and progressive disease. According to these criteria, you have to assess the response. Before initiation, you may apply clips to locate the tumor during surgery. Then after 2 cycles, you have to assess the response. Clinical examination is important. Clip placement is tumor shrinks. In the tumor bed, if possible, place a clip, ongoing monitoring, and then after completion, you have to do imaging to assess the how much response has been achieved. And what are the surgeries? Surgeries is response हो गया तो क्या करना है? डाउन स्टेज हो गया ना ट्यूमर, तो फिर MRM या फिर इतना है पेशेंट इस switch patient has been able, you have been able to achieve the BCS criteria, go for BCS. What are the different types of mastectomy? I think I should skip all these things. And after that, what we have to do after surgery? Management of axilla is important. Axillary node dissection is a standard of care. But in certain cases, if this tumor burden or axillary lymph nodes has been converted to N0, you can go for sentinel lymph node biopsy. And then comes the adjuvant therapy. Adjuvant therapy is indicated in all cases: radiotherapy, adjuvant chemotherapy, completion of chemotherapy after neoadjuvant chemotherapy. Neoadjuvant chemotherapy जितनी भी cycles चली हैं, पहले 2 या 3 या 4, वो आपको बाद में completion adjuvant therapy देनी ही पड़ेगी, ठीक है? और for HER2 positive trastuzumab and pertuzumab, you should continue for 1 year. And then radiation post mastectomy, radiotherapy and post lumpectomy after BCS, you have to give radiotherapy to the whole breast, and in certain condition boost therapy to the tumor bed. Chest wall radiation, there are certain contraindication for that. And then comes the last, it's the endocrine therapy. It's a selective aromatase, selective estrogen receptor modulator and degrader, and aromatase inhibitors, tamoxifen, anastrozole, letrozole, exemestane, and fulvestrant. These are the adjuvant chemotherapy. How to give? If patient is premenopausal as a diagnosis, tamoxifen for 5 years. Then again assess. If patient is still premenopausal, give tamoxifen for another next 5 years. If postmenopausal, you can switch to the aromatase inhibitor or continue tamoxifen. And then postmenopausal aromatase inhibitor. Okay. So I think I should. So take home message is the neoadjuvant chemotherapy is the nowadays is the important thing. Surgery is not first choice. You have first optimize the patient, prepare the patient for surgery so that a better outcome can be achieved. Thanks. Any questions?
Thank you so much, sir. It was indeed a wonderful talk. I request Surendra sir to please come and felicitate the guest.
Our next speaker is Dr. Surendra Kumar. He is professor here in the Department of General Surgery, and the next talk will be on the session Modified Radical Mastectomy, its techniques and the pitfalls. And hand it over to you, sir.
ये किसके लिए है? अच्छा, पॉइंटर ये है. Although the topic which has been allotted to me is quite different, but pitfalls, operative technique, complication, I would like to cover under this a video of modified radical mastectomy. So, so what exactly MRM is, or what structures we remove in modified radical mastectomy? So it's a surgical procedure where we remove the breast, nipple areola complex, fascia over the pectoralis major muscle, skin over the tumors, say around 1 to 2 centimeter, although we don't follow this principle nowadays so as to get a negative margin. But what principle we follow is no ink on margin, ठीक है, no ink on tumor margin, ठीक है. Then we also remove axillary lymph node 1, 2, and depending upon the axillary disease or load of axillary disease, we may even opt for removing level 3 group of lymph nodes. Pectoralis minor, whether it has to be removed or not removed, it depends upon the which type of modified radical mastectomy you wish to carry out. Okay. So there are basically three types of modified radical mastectomy: Petty's, Auchincloss, and Scallons. In Petty's, what we do? We divide the, we remove the pectoralis minor muscle. In Scallons procedure, we don't remove it, we divide it. And finally, in Auchincloss, we prevent the pectoralis minor muscle. Is this clear? So this removal of pectoralis minor muscle division, basically it helps us in carry out or performing the axillary dissection or level 3 dissection. Now coming on to the first step, what should be the position of the patient? As you can see in this particular photograph, the patient lies supine, leta hua hai. And what you can do is, you can put a small sand bag behind the ipsilateral scapula, and what it does, it pushes the posterior wall and floor of the axilla anteriorly. So it basically helps us in carry out or performing axillary clearance. Is this clear? Then the upper limb, the ipsilateral upper limb, it has to be dragged separately. The reason is simple. While performing level 3 dissection or while clearing axilla, not abduction, okay, we perform adduction, okay, adduction. इससे क्या होगा? This will relax the pectoralis major muscle. It will relax the pectoralis major muscle. Okay, so you can easily retract the pectoralis minor and pectoralis major muscle, and it makes your life easy while performing level 3 dissection. Is this clear? आप extend करके देखिए, abduction में ये taut हो रहा है और adduct करिए, relax हो रहा है. ये clear? Then what we should do if we are planning to perform a LD flap reconstruction? What should be, how we should modify the position? So ideally, we can perform it in a lateral position, okay? Or once we are done with the modified radical mastectomy, what we can do? We can change the position of the patient. However, some surgeons, they perform both the LD reconstruction and MRM in a single lateral position. ठीक है, उसी में दोनों निपटा देते हैं. So these are some of the important steps of modified radical mastectomy. One is incision, raising the flap, removal of breast, axillary dissection, hemostasis, and closure. For this, I have a small video. Can you please play the video, please? So coming on to the incision, usually we give a transverse incision, transverse elliptical incision, and there is a specific name for it. We call it Stewart incision. It's nothing difficult to remember this word, Stewart oblique incision. Sorry, Stewart transverse incision. And what are the extent of this incision? So, anyone? No, no, no. Incision. I'm talking about incision. Parasternal to anterior axillary line. ठीक है? Parasternal area to anterior axillary line. Why? Why we should not go beyond the anterior axillary line? See, once we are done with the closure, if we extend the incision, say up to the posterior axillary line or mid of the axilla, finally it will fall up to say posterior axillary line, or somewhere it may go somewhere more posteriorly. So while performing or while irradiating the patient in adjuvant setting, there will be an inadvertent irradiation of axilla. So to avoid this and to avoid radiation related complication to the thoracic structure, we should judicially plan our incision. Is this clear? Okay. Nothing about, chalo, aage badho. The next step is how to raise flap. So the aim of raising the flap is, anyone? Okay, you have to remain in the avascular plane, and secondly, it should not be too thin and it should not be too thick, because if you raise a thin flap, there is always a possibility that the flap may get necrosed in post-operative period. So it's a deadly complication. And if it is thick, what can happen? What will be the harmful effect of pitfall? Leaving a disease on the margin of flap. So how to remain in a perfect plane? So the subcutaneous fat, they are small as compared to a bigger fat globule. So this is how you can remain on the right plane. And another technique is that traction and counter traction method. ठीक है? ये. So in this particular video, what we are doing, we are retracting the breast with the left hand, and with the right hand, we are using cautery to remain in the perfect plane. Is this clear? So this principle, it becomes difficult to follow in patient who have a dense breast, dense obese breast, because it's really impossible to differentiate between the subcutaneous fat and breast fat. क्यों? कि दोनों अक्सर दोनों में क्या परेशानी आएगी? दोनों मोटे होते हैं. So literally it is difficult to differentiate between subcutaneous fat and breast fat, because the size is almost same. So what we can do is, another thing is, in such patient, what we should do is, we should leave the subdermal plexus of vessel on the skin flap. So this is how you can achieve a appropriate thickness flap. Next. So similarly, you can raise the lower flap. अगर कोई एग्जामिनर पूछ रहा है सुपीरियर इंफीरियर किसको पहले उठाना चाहिए, वो सर्जन चॉइस है. मोस्ट ऑफ द सर्जन्स दे प्रेफर टू रेज द सुपीरियर फ्लैप. किस में परेशानी आती है, which is more difficult? So it is the inferior flap, because the subcutaneous this breast fat, it it is densely adhered to the subcutaneous fat. So to get that appropriate plane is quite difficult in raising the inferior flap. Next. See that right now we have started dissecting the breast from the pectoralis major muscle. Now, from which side to start this step? Anyone? 3. It should be medial to lateral because the amount of breast tissue in the medial aspect of the breast is less. So it is easy to get that plane beneath the pectoralis fascia and pectoralis major muscle. Is this clear? Is this clear? So this is how we should raise the breast from the pectoralis, underlying pectoralis major muscle. So on medial aspect, you may get some bleeders, which might be perforating branches of internal memory, perforating branches of intercostal vessels. So this can be easily taken care by using any energy source like cautery or vessel sealer, etc. अब ये dissection कहाँ तक complete करना है? It should be carried out up to the lateral border of pectoralis major muscle. ठीक है? So once this lateral border of pectoralis major muscle is in the field, the dissection, it is carried out superolaterally, and whole of the lateral border of pectoralis major muscle is separated out from the overlying breast. Then it is retracted with the help of either Cerny retractor or Morris retractor. And which muscle we will see once we retract the pectoralis major muscle? It is the pectoralis minor muscle. Pectoralis minor muscle. So at this step, we should try to dissect that anatomical plane between pectoralis major muscle and pectoralis minor. अब कौन से स्ट्रक्चर बचाएंगे और कौन से निकालेंगे? तुमसे नहीं पूछूंगा बेटा, तुम परेशान ना हो. कौन से निकालेंगे? क्या निकालेंगे? Yes, interpectoral node, Rotor's group of node. So Rotor's group of node, they are included in level 2. और क्या छोड़ेंगे? Medial and lateral pectoral nerve if you are planning to conserve the function of pectoralis muscles. Is this clear? अब तक कोई सवाल पूछेगा ऑपरेटिंग चैट में बता लोगे? हाँ, ठीक. So axillary dissection में हम लोग क्या कर रहे हैं? Basically we are clearing both superior and inferior, or I should say the anterior aspect of pectoralis minor muscle and the posterior aspect of pectoralis minor muscle. Is this clear? See how we enter the axilla. So we have to cut the clavipectoral fascia, and once we are done with it, we enter the axilla. And axilla में क्या करेंगे हम? See, usually most of the time dissecting out the level 1, level 2 lymph node is sufficient, but the amount of disease which we have in our part of world is quite high. So personally, whenever I perform a modified radical mastectomy, I always remove level 3 group of lymph node, and I won't take more than 5 minutes. ठीक है, मैं बस खत्म कर दूँगा. So रोक देना, इसको रोक दो. Now coming on to the boundaries of level 1, level 2 and level 3. So medial boundary of level 3 include What is the medial boundary of level 3? It's the Halstadian ligament or costoclavicular ligament. And what is the lateral boundary of level 3? It is the medial border of pectoralis minor muscle. From the medial border to lateral thoracic vessel, we have the boundary of level 2 dissection. Okay? And the lateral boundary of level 1, which we follow in our institute, is thoracodorsal pedicle. Thoracodorsal pedicle. ठीक है? So superior extent क्या होता है? Axillary vein. Why we should not go above the axillary vein? Because the lymphatics which drain the upper limb, they passes through that area. And any attempt to dissect at that level will prone the patient to develop a lymphedema in post-operative period. अगर disease grossly present है, of course you can go for that step or you can remove those lymph node. ठीक है? अब यहाँ पे और क्या चीज हम लोग बचाएंगे एक्जिला में? अगर ग्रॉसली इन्वॉल्व नहीं है, इस पे भी तो वो तो अलग है बेटा. एनीवन? वो तो ठीक. लॉन्ग थोरैसिक नाउ, थोरैकोडोर्सल पेडिकल और कुछ इंटरकॉस्टोब्रेकियल नाउ. ठीक है? इंटरकॉस्टोब्रेकियल नाउ. ठीक है? बिकॉज if you injure these now or you resect out these now, the patient may complain of severe paresthesia in the upper and medial aspect of upper arm. So this is the reason why we should try to preserve or conserve the intercostobrachial nerve, which are usually 3 or 4 in numbers. So here we have the first or second intercostobrachial nerve, and here we have the long thoracic nerve of Bell. दिख रहा है? हाँ, is this clear? See, the sheet around the axillary vein should not be excised or removed, because any such attempt will prone the axillary vein to develop thrombosis in post-operative period. ठीक है? So the tissue or soft tissue along with lymph node which lies in between the long thoracic nerve of Bell and the latissimus dorsi pedicle should be excised completely. Now, what is the lowermost boundary of axillary clearance? Angular vein. It is the angular vein, and this angular vein, it combines with the latissimus dorsi or vein vein present along the LD pedicle to form subscapular vein. ठीक है? So the lower limit is the angular vein, superior limit is axillary vein, and lateral limit LD pedicle and mid. दिख रहा है? हाँ? और level 3 का medial most limit क्या थी? Halstadian ligament or costoclavicular ligament. So once you are finished with this entire procedure, hemostasis check करिए, and all these structures, they should be demonstrated to the assistants. ठीक है? Incision close कर सकते हैं drain डाल करके, one in the axilla and another beneath the pedicle, sorry, not pedicle, flaps, and the drain, it should be, or the opening through which we take out the drain, it should be close to the incision, say about 1 to 2 centimeter. Now, what is the reason? So all the drain side, they should be included in the radiation field, and if you take out these drains away from the incision line, you can expect what can happen. So again, you will have to involve an extra portion of radiation field, which may result in complication related to accidental irradiation of thoracic structures, etc. I think we have people from radiotherapy. They will discuss that in detail. So these are all modifications of incision. You can modify the incision line depending upon the site of the tumor. Any questions? I'm done, beta. फिर से रिपीट कर दें लेवल 3 की लेवल 2 का मीडियल बॉर्डर ऑफ पेक्ट्रालिस माइनर मसल से लॉन्ग लेटरल थोरैसिक मसल्स, वहाँ से लेटरल थोरैसिक मसल से पूरा एलडी पेडिकल तक.
Thank you so much, sir. It was indeed a wonderful talk. I request Nizam sir to please come and felicitate our esteemed speaker. Next, we start with our oncology session, and the first lecture is neck dissection, safe planes and key structures. I would like to welcome Dr. Naseem Akhtar sir. He's a professor in surgical oncology department here at KGMC now. We welcome you, sir.
कहाँ रख रहे हो यार पीछे एसी में देखो ना. अच्छा चलो डालो. Good afternoon everyone. Today I am discussing about neck dissection, safe planes and key structures. I will cover this topic under following headings: incision, skin flap elevation, boundaries, structures to be safeguarded and closure. As we all know, that a well-planned incision can make surgery feel like heaven, and poorly planned one can turn it into hell. Planning depends upon the site of disease, whether the site is oral cancer, whether the site is thyroid or parotid. The incision is different. Level of lymph nodes to be done, whether you have to do level 1 to 3 and or you have to do level 1 to 5, the incision will be different. And it will also depend upon the skin involved, whether it is involved by primary neck or by different scar, the incision will modify accordingly. And definitely we should follow the natural skin lines to reduce scarring and complication. Prior radiotherapy also changes the incision line, as prior radiotherapy there is poor healing. So we should modify our incision, don't take trifurcate incisions. And we should always keep future reconstruction in mind. As various kind of incisions I am showing this image, utilized for oral cancer in modified Schobinger incision, which is here. This is modified Schobinger incision. This is most commonly used in oral cancers, and this is a trifurcate incision. It gives very good exposure, but the healing at trifurcation is poor. And second type of incision is transverse incision. This healing of this incision is good, but exposure is not very good. So the dissection is difficult with the transverse cervical incision. In post-radiation cases, McPhee incision is employed, two transverse incision, that is McPhee is employed. And these images, these two images are showing that primary tumor itself is involving neck. So the when we will do wide local excision of this tumor, the neck will be opened and there will be no need of any further incision for the neck dissection. And in this case, the horizontal incision will come along the margin, and only vertical incision will be required for the neck dissection. For supraomohyoid neck dissection, a transverse incision is used, which is around 2 centimeter below inferior margin of mandible. And for larynx, Gluck's or U incision should be used. It will incorporate the laryngectomy site, this stoma site, and will be from one mastoid to other mastoid. For thyroid, a transverse incision is used, and for parathyroidectomy, a lazy S incision is used, and for the neck dissection, we pull the this limb of the lazy S a bit anterior. And in neck dissection, when we will start, we will take a sharp incision with cold knife and reach up to the platysma, and then we will divide platysma with cold cautery, and we will keep the cautery setting at lowest effective power and avoid prolonged activation at one point, so that there is no lateral damage to skin. And skin flap elevation is at subplatysmal level, and there should be no fat along the flap on the platysma side. There is no yellow fat along the platysma. Now we will know about of contralateral digastric and posteriorly up to anterior border of trapezius, and the deep boundary is bounded by a deep layer of deep cervical fascia. So our lymph node dissection is in between platysma to a deep layer of deep fascia. We don't have to remove the deep layer of deep fascia. So what structures are to be safeguarded, and how to identify them, preserve them, and how to ligate few of the structures. In nerves, spinal accessory nerve and marginal mandibular nerves are dissection of these nerves are technically challenging, and these nerves are at high risk of injury during neck dissection and demand precise technique. While the phrenic nerve branches of brachial plexus, vagus, lingual, and hypoglossal are not usually injured if we limit ourselves in our boundaries, but if we go beyond our boundaries, and we can injure them. So to injuring phrenic branches of brachial plexus, vagus, lingual, and hypoglossal, we need extraordinary attempt to injure them. And vessels, we will discuss how we will save IJV, carotid artery, and thoracic duct. How we will identify and dissect spinal accessory nerve. We will identify after the flap elevation. After the flap elevation, posteriorly we will identify spinal accessory nerve by two techniques. One is we will identify greater auricular nerve, and the spinal accessory nerve will be about 1 centimeter above the greater auricular nerve, emerging out from the posterior border of sternocleidomastoid. Second technique is follow the anterior border of trapezius, and it is about 5 centimeter above from the clavicle on the anterior border of trapezius. We can follow the nerve from here, or we can follow the nerve from here. And third technique is anterograde approach, in which we identify the nerve at level 2 from posteriorly to the posterior to the vein, or inferior to the digastric and follow the nerve from level 2 to level 5. Second is how we will identify and preserve the marginal mandibular nerve. This is identified at level 1. This structure is marginal mandibular nerve, and we will identify the facial vein and ligate this facial vein and lift this facial vein above and do the rest of the section below. When we will lift this facial vein above, we will retract the marginal nerve from the field of dissection. So this technique is known as Hesse-Martin maneuver. This is for preservation of marginal mandibular nerve. The second method to preserve this nerve is by sandwich technique. The nerve, marginal mandibular nerve, lies in between platysma and the fascia or the submandibular gland. So it is sandwiched between the fascia of submandibular gland and the platysma. So if we can divide the submandibular fascia here and lift the submandibular fascia above, it will be out of the field, surgical field. How to preserve phrenic nerve and branches of brachial plexus. Simple way to prevent these injuries is don't breach the deep layer of deep cervical fascia. This is deep cervical fascia, and if you will not breach this fascia, you will never injure the phrenic nerve or brachial plexus branches. And if you will breach this deep layer of the deep fascia, cervical fascia, you will enter and you will either injure the phrenic nerve or brachial plexus branches. So never dissect deep layer of deep cervical fascia. How the lingual and hypoglossal nerve are identified and preserved. During deep lobe submandibular dissection, lingual nerve is visualized, and this is sublingual nerve, and this is deep lobe of submandibular gland, and this is submandibular ganglion. So when we will lift this we will push down the submandibular gland, we will see the sublingual gland and submandibular ganglion. We have to divide this submandibular ganglion at this level, so that lingual nerve will be separated from the submandibular gland. So the lingual will be saved here. To injure hypoglossal nerve, you have to go to deep to the plane of digastric muscle. So never go deep to the layer deep to the surface of digastric muscle to prevent the hypoglossal nerve injury. Now identification of facial artery. As facial artery is coming from external carotid artery, this will come and run superiorly and obliquely and pass deep to digastric. This is digastric and this is stylohyoid muscle. So this will come here and come out from medial to stylohyoid muscle. So we have to look for this facial artery here at medial to stylohyoid muscle. And how will we identify that we will search this facial artery here? That landmark is common facial vein here. This is very close to common facial vein, which we ligate anterior to digastric muscle. So in this way we can identify the facial artery and ligate facial artery just medial to stylohyoid muscle. What to do about carotid and internal jugular? For dissection of carotid sheath, we should always use cold knife and step by using right angle. Never use cautery, and always use right angle to lift the carotid sheath. Cautery should not be used very close to vein. It may thrombose the vein. And in elderly cases, there should be there can be tortuous external carotid artery. So we should remain careful in elderly persons. For thoracic duct, Thoracic duct is usually injured in level 4 dissections, and care should be taken that thoracic, especially in left side of dissection. Best approach is clamp the tissues, all fatty tissues here, and ligate them, and always check kylic by doing Valsalva procedure before the closure. Closure is done in 2 layers. One is platysmal closure, and second is skin closure. So, and I will show you one video of neck dissection. Eight axilla नहीं, 8 neck. This is modified Schobinger incision, and we have given incision, and now we are dividing the platysma using cautery. This is platysma. The flap is elevated, subplatysmal flap is elevated, and this is elevated up to the inferior border of mandible, and there should be no fat left along the platysma. This is vertical incision, and this is division of platysma. Now anterior flap is elevated up to the sternohyoid muscle, up to medially up to sternohyoid muscle, and posterior flap is elevated posteriorly up to anterior border of trapezius, exposing 1 centimeter anterior surface of this trapezius. This is greater auricular nerve. This is marginal mandibular nerve. This is greater auricular nerve, and this is spinal accessory nerve, which is 1 centimeter above the greater auricular at the posterior border of sternocleidomastoid. This is dissection of spinal accessory nerve in level 5. This we dissect the nerves usually by scissor, not use thermal device. Ligation of external this jugular vein. We are elevating fibrofatty tissue from clavicle. The division of posterior belly of omohyoid, and elevation of fibrofatty tissue from level 5. Preservation of transverse cervical vessels. The branch from transverse cervical artery is ligated, and this fibrofatty tissue is dissected. The fascia or the sternocleidomastoid is divided, and sternocleidomastoid is dissection of fascia is done all around the sternocleidomastoid. This is internal jugular vein, and we lift the sternocleidomastoid, and then this is dissection of omohyoid. Omohyoid is taken, posterior belly of omohyoid is divided, and this is division of carotid sheath over the IJV. Posterior belly of digastric is dissected. This common facial common facial vein is ligated. This is the dissection of fibrofatty tissue is done at level 2 and 3. Level 3, 4, sorry. This point is level 4, where we ligate the lymphatic tissue so that there is no kylic in post-op phase. The level 4 dissection. This is phrenic nerve. The cutaneous branch from phrenic nerve is divided, and level 5 dissection is completed. This is spinal accessory nerve. This is level 2. Spinal accessory nerve is visualized in level 2, and the fibrofatty tissue is separated from the vein and the inferior border of digastric muscle. This is dissection of level 2. Now, we come to the dissection anterior to the vein, and level 3 anterior to vein is dissected, and level 2 and 3 anterior to vein is dissected, and this is digastric, posterior belly of digastric, and marginal mandibular nerve is preserved here, and mandible is fascia or mandible is divided, and the retromandibular vein is ligated here. This is pushed, the submandibular gland is pushed down, and this is ligation of facial artery. Now submandibular gland is elevated, and this is lingual nerve, and submandibular gland is separated from lingual nerve. Submandibular gland is separated from lingual nerve at submandibular ganglion, and the tissue is submandibular 1B is removed. This submandibular duct is ligated, clamped and ligated. This is dissection of level 1 between the anterior belly of digastric, both anterior belly of right and left digastric. So this is transverse cervical artery and artery. This is brachial plexus. This is phrenic nerve. This is portion of thoracic duct. This is marginal mandibular. This is sternohyoid. This is anterior belly of digastric. Tendon of digastric, posterior belly of digastric. The lingual nerve is here, and sternocleidomastoid, and the spinal accessory nerve here, and this is superior thyroid artery. Okay. The closure is done first for the platysma and then for skin. Okay, thank you.
Thank you, Dr. Naseem. This was really a visual delight to see the video of neck dissection and a wonderful explanation of the topic. I would request Dr. Gitika Nanda to please come upon the stage and felicitate Dr. Naseem after. And our next talk will be on extremity soft tissue sarcoma by Dr. Puneet Prakash. He is Associate Professor in the Department of Surgical Oncology, KGMU. Kindly welcome Dr. Puneet Prakash sir on the stage for the next talk.
Is it on? Yeah. Okay. Am I audible? Yeah. So thank you, Dr. Amit. At the outset, okay. Acha. So at the outset, I would like to thank the organizers, HOD, Professor Sonkar sir, and Dr. Geetika ma'am for having me here. It's always a privilege and honor to address fellow surgeons. So I'm going to talk about extremity soft tissue sarcomas, biopsy to wide excision, and limb salvage strategy. So before we go ahead, let's split the word. It is soft tissue and sarcoma. So soft tissue is anything which connects and supports the skeletal system, has a mesodermal or a mesenchymal origin with some contributions from the neuroectoderm. And any tumor which is arising from soft tissues is known as a sarcoma. Sarcoma in Greek word means fleshy. And as the name suggests, these are fleshy tumors which arise from mesenchymal tissues. They are younger age is a predilection, and they are characterized by rapid growth and early hematogenous spread. So as you can see, the soft tissue is located all over the body, and the tumors arising from these soft tissues are known according to the origin of the tissues. Like from blood vessels, it may be angiosarcoma; from bone, it may be Ewing sarcoma, cartilage, chondrosarcoma. And we have a whole list. That this is the WHO classification. It's a very exhaustive classification. I will not go into the detail of it. So when coming to the anatomical location of our body is affected by soft tissue sarcomas, but here the most common being the extremity soft tissue sarcomas. Almost half of our soft tissue sarcomas are occur in the extremity, upper and lower, and more common in the lower extremity. Going to the etiology, there are genetic factors like any other disease, exposure to radiation. All radiation increases the risk of cancers, certain chemicals, and viral infection. Here I would like to say that if a soft tissue patient of a soft tissue swelling comes to you, I will not ask you to go into all the genetics of it, but here the point is that if there is a patient of neurofibroma, which we very often see, and if there is a long-standing swelling and which shows a rapid increase in size in the last like 2 or 3 months, then you should have it in your mind that a neurofibroma may have progressed or transformed to a neurofibrosarcoma. So certain genetic conditions like neurofibromatosis, Li-Fraumeni syndrome, Gardner syndrome, which is a variant of familial adenopolyposis coli, Gorlin syndrome. These are all conditions which are associated with neurofibromas, increased risk of soft tissue tumors. History of radiation also increases the chances of having soft tissue sarcomas. Certain viral infections such as HIV and CMV, which are associated with Kaposi sarcomas. This is a list of chemicals which are associated with soft tissue sarcomas. But again, when you see a patient, these are just academic, this is just an academic exercise, you should know all these things. Now when a patient comes with a history of a soft tissue swelling, what should you do? This is one of our own patient, and what are the warning signs? So the first thing which as a postgraduate student you should ask is, what is the duration of such a tumor? On examination, is the size more than 5 centimeter and deep to the fascia? Is there a history of rapid change in size? Any history of recurrent swelling? Any local symptoms like neurological deficit or pain? History of neurofibromas or radiation exposure, or family history of soft tissue sarcomas? So any soft tissue mass which is deep to the fascia should be considered a sarcoma unless proven otherwise. So how will you prove it? The question is imaging or biopsy. What should we do first? Yes, correct. As when you are being taught about breast cancer, you always there is a triple assessment, and you always go ahead with imaging first. Same here, we go ahead with imaging first, local part X-ray and chest X-ray. But the investigation of choice in soft tissue sarcomas is MRI, because it's a soft tissue sarcoma, and as we all know that MRIs are they are the investigation of choice to delineate the soft tissues. The hydrogen spin which is there is different for different soft tissues depending upon the water content. and it delineates not only the muscle groups but also shows excellent pictures as with relation to vascular structures and neurological structures. Then if we have to do a metastatic workup, most of these sarcomas have a predilection for lung metastasis. So HRCT thorax, no contrast required because we are not going to analyze the mediastinum. So only a non-contrast HRCT is good enough to diagnose lung metastasis. Now, as we all are talking about the PET scan, there's an evolving role of PET scan. As of now, the guidelines do not recommend it, but yes, the role is upcoming. It is useful in staging and prognostication, grading and response to chemotherapy. Higher SUV, if you have done a PET scan, a higher SUV correlates with poor outcomes, as has been shown in certain studies. And in certain soft tissue sarcomas, you all know the MARSES acronym, rhabdomyosarcomas, high-grade tumors basically, clear cell sarcoma, angiosarcoma, and epithelioid sarcomas. In such patients, in such tumors, we can get a PET scan to detect the lymph node metastasis. After doing an imaging, then comes the biopsy. Here's the role of usually the residents. Usually the residents do the biopsy here. So a percutaneous core needle biopsy is preferred. We never suggest to do an incisional or an excisional biopsy. Take as much core as you can, preferably 12. But when you are taking core biopsies, avoid potential contamination of uninvolved anatomical compartment. For example, if there's a tumor on the shoulder region, you have to take biopsy. Suppose it's over the deltoid region, you have to take the biopsy from the deltoid region. You should not cross the pectoral area and take a biopsy. You can do it from here also. But if you do that, you'll contaminate the pectoral compartment as well as the deltoid compartment. You have to be in line with the future resection, so that because when we do the definitive surgery, we have to excise the biopsy site. And if we have done an MRI beforehand, another advantage apart from delineation of the soft tissues is that MR can guide us to do biopsy from the representative areas, avoiding necrosis. Then, as you can see in this picture, we are doing biopsy from the most superficial, most accessible part, avoid long axis, along the long axis, so that it can be incorporated in the future incision. This is a core needle biopsy. It's just a schematic diagram. All of you are knowing how to do a core needle biopsy. We have automated guns now. BARD is commercially available. Now, incisional biopsy. When the core biopsy has failed, and it has failed for more than 2 times, then we can go, not a French, so I'll take the English not a French, so I'll take the English translation of it. The French Federation of Cancer Centers Sarcoma Group, the FNCLCC grading is there, and now it has replaced the earlier National Cancer Institute grading. So what are the grades? The grades, there are 3 parameters which are included in the grades. One is the differentiation score, the mitotic count, and tumor necrosis. And your pathologist will grade your biopsy specimen according to these 3 parameters. Grade GX is when the grade cannot be assessed. Grade 1 is when the final score is between 2 to 3. Grade 2 is when the final score is between 4 to 5. Grade 3 is when the final score is between 6, 7, or 8. And there is a predictive value for these grades. For example, the 5-year metastasis survival free rates in this study for grade 1 tumors was 91% as compared to 43% for grade 3 tumors. Now, this is the staging, again very exhaustive, it's given in the books, I'll not go into the detail, but the important point is you can see that the grades are mentioned in the AJCC staging. AJCC staging is very easy for you to remember, I mean just simple arithmetic, less than 5, 5 to 10, 10 to 15, and more than 15, so 1, 2, 3. But the important thing which you may be asked in your exams is what are the changes in the current AJCC edition. First, the soft tissue sarcomas are divided now into different staging systems by anatomical site. Then earlier superficial and deep location was there because one was divided into A and B, 2 was divided into A and B subsequently. So now it has been removed. And most importantly, lymph node metastasis and distant metastasis are both of them are in stage 4. The grade is so important, as you can see here. Even if your size is more than 15 centimeter, that means it's a T4 tumor. But if it is grade 1, it still belongs to stage 1 of AJCC 8th edition. Now coming to the metastasis, you all know the acronym MARSES. So the lymphatic spread is there in these tumors. The most common adult soft tissue sarcoma is the liposarcoma, followed by leiomyosarcoma and undifferentiated pleomorphic sarcoma, earlier which was known as MFH. Now, principles of surgery. It's very easy. You have to just cut it out. But the catch is there when I go further. As early as in 1950, the concept of limb salvage surgery came for soft tissue sarcomas. So, we have to do a limb salvage surgery with negative margins. Planned margin positive resections can be done if it is near the critical structures like major blood vessels or nerves. Radical excision is no longer recommended. I'll come to that. What is a radical excision? And amputation is an absolute no. But we have to do it if sometimes if the gross resection of the tumor is going to render the limb non-functional. Standard surgery is wide excision, 2 centimeters beyond the reactive zone. Now, this is a diagram where you can see when we are talking about the radical excision or the compartment excision, we excise from the muscle from origin to insertion. The wide excision is when we are taking a gross margin outside the reactive zone of more than 2 centimeters. Then marginal excision is when we are excising along the reactive zone, and intralesional is just subcapsular excision. This is one of our own pictures. And if we do a wide local excision, this is the anterolateral compartment of the thigh, and the great vessels, the femoral vessels and the nerves can be visualized. We can very well save the vessels. Now, when we are doing a surgical site, surgical excision, we have to incorporate the previous biopsy site. So, as you can see, when I mentioned earlier that if you are doing an incisional biopsy, it has to be along the long axis of the limb so that you can excise the biopsy site. So, here you can see if it's a transverse incision, it becomes you have to excise more skin to incorporate the biopsy site. Then, if you're doing it, the main golden rule when you are doing a soft tissue sarcoma surgery is you should never see the tumor. If you're seeing the tumor, then definitely you're going wrong somewhere. So, dissection should be through a grossly normal plane uncontaminated by the tumor. And after surgery, you should place surgical clips for adjuvant radiotherapy. And another important thing is the placement of drains. So, when you are placing the drains, it has to be on the lower border of, or maybe an upper border of the incision along the long axis of the limb. As you can see, the B is the correct position of placement of limb, because the exit site will be incorporated in adjuvant radiation if it is given, or maybe if you have to re-excise the scar, you can easily excise the longitudinal scar. Now, there is something called the Kawaguchi rule. It's a very landmark paper which was published in Clinical Orthopedics and Related Research in the year 2004. So, when we are talking about sarcoma surgery, as I mentioned earlier, we have when the tumor is close to certain critical structures like nerves, vessels, then how can we take gross margin? So, Kawaguchi's rule is if we are taking a curative margin, defines the curative margin as a margin more than 5 centimeters. What we practice is an adequate wide margin. So, when we are doing surgery in our department, we take a gross 2 centimeter margin, which is a wide adequate margin. If it is less than 2 centimeter, it is considered inadequate. Now, in this paper only, there are certain barriers to tumor which as a postgraduate student you all should know. Now, each tissue can be classified into a thick or a thin barrier. What's a thick barrier? A thick barrier is a joint capsule or a tendon which is around the soft tissue tumors, and it is equivalent to 3 centimeters of the normal tissue. A thin barrier is like a muscular fascia, periosteum, vessel sheath, or epineurium, and it is equivalent to a 2 centimeter of normal tissue. So, when you have excised the tumor and you are examining the resected specimen, and if it is adherent to the membranous covering on the outer surface of the barrier, but the outer surface is shiny or the luster is there, then that thick barrier will translate into a margin of 2 centimeters, and a thin barrier will translate into a margin of 1 centimeter. So, after you have resected the specimen, you should always do a gross examination, and when you send the specimen for the pathological examination, you should always ask whether there was an intact fascia all around the tumor or not, because if there is even if the gross margin is less than 1 centimeter, but if there is an intact fascia all around the tumor, it means you have taken an adequate margin, because that thin barrier will translate into a margin of 1 centimeter. Now, amputation, obviously it's an absolute no, but nonetheless we do it sometimes. It's done for the large tumors where radical amputation is sometimes necessary, but here we should know that amputation does not increase the overall survival, and in metastatic disease there is no need for amputation unless we have a bleeding tumor.
something like that, a palliative amputation. Adjuvant treatment, chemotherapy as of now does not, unless it's a high grade tumor, most of the time chemotherapy is not used, but radiotherapy plays a very important role in adjuvant treatment for soft tissue sarcomas. So what are the indications? Radiotherapy, like surgery, is a local treatment, right? So we have to reduce, it reduces the local recurrence. It is not going to affect the distant metastatic rate. So to reduce the local, what are the indications? The indications are a tumor size more than 5 centimeters, lesions which are located deep to superficial fascia, high grade tumors, narrow or positive margin, and local recurrence, recurrent tumors after prior surgery. This is just for academic purpose. We are not doing it at our center, something known as isolated limb perfusion. This is a technique where we deliver high dose of chemotherapy after heating it to do a limb salvage surgery, or if maybe the tumor is so large that it is unresectable. This is the setup of it. Now, a small discussion regarding pre and post-op RT. Most of the surgeons do not prefer pre-operative RT because most of the time it leads to wound complications. But if we pre-operatively in your MRI, there is a chance that you are going to have a closed margin near a blood vessel or maybe a nerve, then we can go ahead and do a pre-op RT. And there are certain benefits of doing a pre-op RT because the field size is smaller and you have a tumor in place, right? So the radiologist, the radiation oncologist can see the tumor and plan his radiotherapy. Wound prediction, the complications, obviously when you're doing surgery, if the size is more than 10 centimeter, then there's chance of wound complications, proximity to the skin surface, and if your flaps are not properly vascularized. Chemotherapy for high grade tumors, these are the regimens which are used. And the last slide, the treatment algorithm. So I'll go through it slowly. After you have done the staging, you do the local part imaging and you do the biopsy. If the limb salvage is possible, you go ahead, resect the tumor in the limb salvage surgery. And if there are high grade tumors, recurrent tumors or deep-seated tumors, patient goes for adjuvant radiotherapy. If for some reason you are not able to do a limb salvage surgery, you can go for pre-operative radiotherapy or neoadjuvant chemotherapy, but that has to be discussed in a multidisciplinary tumor board. And after that, if the wide resection is possible, you can go ahead and do a limb salvage surgery. And if it is not, then obviously amputation can be done. Thank you.
Thank you so much, sir. It was indeed a wonderful talk. I request Kushagra sir to please come and felicitate.
I want to ask one question from a student. Can we operate a sarcoma without biopsy?
स्टूडेंट से पूछ रहे हैं.
Yes, sir, we can operate. Sir, I am Dr. Jyoti, JR3 in Department of General Surgery, KGMU, and we can operate sarcoma without biopsy.
Which sarcoma?
Soft tissue sarcoma, which are superficial, and they can be operated without going for biopsy.
Never operate sarcoma without biopsy. Even don't operate after FNA. Biopsy is mandatory. Okay. So extremity sarcomas.
Should be the management of a recurrent sarcoma at the local site. If there is a local site recurrence, how should we proceed further?
सो पैनल से पहले 5 मिनट का लघु शंकर निवारण का ब्रेक है, ठीक? तो प्लीज़ सब लोग जाग जाओ। 5 मिनट का मतलब घड़ी से 5 मिनट, मेरा 12:45 हो रहा है, ठीक? तो जल्दी से फटाफट जाओ और उससे ज़्यादा फटाफट वापस आओ, ठीक है? विल हैव अ पैनल, सो वी वांट योर एक्टिव पार्टिसिपेशन इन पैनल। आंखें सबकी खुली, कान सबके खुले, फटाफट।
You can bring back the coffee glasses with you back inside.
Please recharged for the panel discussion on oral cavity cancer. The moderator is going to be Dr. Parijat Suryavanshi sir, professor here at General Surgery, KGMU Lucknow. And I'd like to invite esteemed panelists, Dr. Vijay Kumar sir, professor and head surgical oncology, KGMU. Professor A. Sonkar sir, professor and head surgery, Department of General Surgery, KGMU. Dr. Mrinalini Verma ma'am, additional professor of radiation oncology at KGMU. Dr. Ankur Verma sir, additional professor, surgical oncology at Kalyan Singh, Lucknow. We welcome you all, sir.
So the structure of panel discussion will be that we will be discussing three cases. Okay? Early oral cancer, locally advanced oral cancer, and third is advanced non-metastatic oral cancer. We'll be focusing more on the early oral cancer because that is what we will get in exam, early oral cancers. Okay, this case number 1. A 39-year-old male presenting with a growth on right lateral border of tongue, is non-tobacco user, non-alcoholic, and there is no clinically palpable lymphadenopathy. So this is what we have, a visible ulcer on the right lateral border of tongue in the mid part. So, Sonkar sir, so we start from you. So what else we need to know on this picture? We have a visible ulcer, no neck negative. From examination, clinical examination point of view.
Hello, audible? I'm audible, yeah. As far as examination is concerned, it looks pretty straightforward. It is small, 1 centimeter to 1 centimeter, nearly 2 centimeter lesion, ulcerative lesion. And we need to focus on the examination part. We should try to palpate the tumor all around. And we should also see the relation with the floor of mouth, posteriorly, circumventral papilla, and try to ascertain the depth of the tumor. And then oral cavity, I mean, this is so straightforward. I mean, besides examining, we would also like to see all the GB sulcus, which should be a good clinical examination, should contain all the GB sulcus, anterior relation with anterior facial pillars, circumventral papilla, whether it is going posteriorly or not. So it should be done along with the neck nodes.
So important thing is that palpation is important. Always put your finger and examine the induration. There's always an underlying induration, and that induration is a part of tumor. So always palpate. Okay, once you palpate, you will find an induration, and that induration is also part of disease. The extent of induration is the exact extent of the tumor. So for imaging, Vijay sir, this is an obvious case where we have a ulcer on the right lateral border. Do we need imaging?
Practically, this does not require imaging. You can see a small ulcer, and most probably it doesn't seem to be any induration in this. For this tumor, MRI or anything is not required. The modality of investigation is MRI, contrast enhanced MRI for CA tongue, because that soft tissue is delineated very well on MRI. But you should get an MRI done in this case. In any case of oral cancer, the reason being the patient may have secondary lesions, may have skip lesions, or may have second primary also. Okay, so this for this tumor you need not need an imaging, but you need an MRI to see for skip lesions or secondary lesions in the oral cavity or in the neck.
You want to add something, Dr. Ankur?
So, as sir said, there is a high chances of secondaries or second primary because most of the patients are smokers. So, if the clinical history supports, then we should always get the MRI.
Okay. I think if on palpation you find a significant induration, then it's very important to get an MRI done, because then you need to know the exact depth of the tumor. So if there's an induration, always get an MRI done. And most of the cases you will find induration. So for exam purpose, say imaging, and that is contrast MRI. MRI is for tongue, MRI is better than CT scan. So once we have imaging done, we go for biopsy. Biopsy always should be done after imaging. Now, many times patients, they come with already a report of FNA or scrape cytology done outside. Maybe some primary physician has done FNA of scrape cytology of the primary lesion which comes out with positive. Now, should we proceed on basis of FNA or scrape cytology being positive, or do we have to go for biopsy in all cases?
I think we should go for biopsy because in scrape cytology, the most important thing is to see the invasiveness of the basement membrane or whether it is an invasive component, so that we can acquire on the incisional biopsy only. So we should always go for incisional biopsy or the punch biopsies we are doing as of these days.
In chronic traumatic ulcer or inflammation, you can have atypical cells. So it is important to get a histology done in order to confirm the malignancy. So this is what we have got. We have MRI done. VS sir, can you want to interpret, comment on this MRI?
So in this you can see there is small ulcer on the left side which is highlighted. Okay, this is with the contrast which has been given. So this is in a very early tumor. I think depth of invasion would be around 3 or 4 mm. And cannot comment on the neck in this. So this is a lesion you see here. Okay, on the without contrast you see this is without contrast, so it's very deep. After contrast it's highlights. Okay, so this is the tumor here. A small tumor, early tumor, T1 lesion.
And we can also see the midline. So you also need to see what is the deepest extent of tumor from the midline, because when you're planning for a resection, you need to take a margin from the deepest part of the tumor. So in this MRI, another advantage is that you can also plan your surgery. How deep you have to go while resection. So we have MRI report. Focal lesion is seen in the right lateral wall of the tongue. In the mid aspect, maximum depth is 6 millimeters. Length of lesion is 10 mm. No clear extrinsic muscle involvement. Mildly prominent bilateral submandibular cervical chain lymph nodes. Here we'll focus on this maximum depth, 6 millimeters. This is what reported in MRI report. So accuracy of depth measured in MRI versus what we get depth of invasion in the final histopath. What is the correlation between two? Is this accurate MRI in predicting the depth of invasion? Because depth of invasion is a very important prognostic factor in oral cancer.
Actually, when we do surgery, there are two factors of shrinkage factors. One is the Cautery effect, due to which the margins shrink, and one is the Formalin effect. So the depth of invasion we get is usually less afterwards as MRI.
Okay, this is why before resection MRI, the depth of invasion we get on MRI is important. Okay. There are around 30% shrinkage of the tissue once you resect it. So why is it important, depth of invasion for clinicians?
According to the 8th AJCC staging manual, the staging, the T lesion depends on the size of tumor and including the depth. Up to 5 mm it is T1, more than 5 from 6 to 10 it is T2, and more than 10 it is T3. Okay, so this is very important for clinician. It is not the thickness of tumor, it is just the depth of invasion. Okay, the depth of tumor.
So there is a difference between thickness and the depth of the tumor.
No, the idea of depth of invasion, I would like to add one more point, that the greater the depth of invasion, greater the chance of lymph node metastasis. So this is also important finding, that if the depth of invasion is so and so, probably it was when you started it was 4 millimeter or so, there was a greater chance of lymph node metastasis. Number one. Number two, when you are doing resection, you will also keep in mind that since the depth of invasion is 10 millimeter, you will also take a greater amount of tissue on particular around that particular area. It is known as third dimension of the tumor. So you would be more careful there.
So depth of invasion is important both of prognosis and planning of resection also. Now this is what we believe, that depth of invasion more than 4 mm. If it is at least 4 mm or more, there is a high risk of lymph node metastasis. But recently most of the textbooks have switched down. Now even as low as 2 mm of depth, people are advocating the neck dissection. This is what we have in the recent Devita. If depth of invasion is more than 2 mm, patient should be considered for ipsilateral neck dissection. So threshold has come down now from 4 mm to 2 mm. 2 mm depth of invasion means if you can palpate the tumor, it is at least 2 mm depth. So practically you have to do neck dissection in all cases. So exam, whatever case you will have, oral cancer, always say neck dissection. If you can palpate the tumor, it is at least 2 mm depth. So we have biopsy, squamous cell carcinoma well differentiated. Now, Dr. Minali, would you like to go for HPV testing in oral cancer cases, like you do in oral pharynx case?
No. In ROPD, I would not go for HPV testing for oral cancers.
This patient is non-tobacco, non-alcoholic.
Still, because in India it is very low percentage, like it varies from 15% to 35%, और 35% is from the southern India का जो data है, तो I would not like to go. Still, it is non-small.
Not even posterior pharyngeal cancer and posterior throat cancer.
It is for oral
for
cancer.
Oral cancer.
For oropharynx, so yes, we should, but not for oral cancer.
Right.
So there is association of HPV, strong association of HPV with oropharyngeal cancer. 80 to 90% of cases oropharynx are positive for HPV, but that is not the case in the oral cancer cases. So routine screening for HPV in oral cancer is not yet educated. We come to treatment options. Now there are two treatment options, surgery and definitive RT. If we go by the theory, textbook part, then in very early oral cancer, both are equally curable, the result. But usually surgery is preferred. So again to the radiation oncologist, why is that case? Surgery is preferred treatment for early oral cancer.
For definitive radiotherapy, I really want to differentiate between the buccal mucosa versus the primary tongue, because tongue is more notorious, more skip metastasis, more regional nodal metastasis, and more failures also. But still, even in the textbook and in the practical purpose also, if it is the case, T1 up to 1 centimeter, depth is 6 mm, little more, because now it's more awareness about the DOI, 4 mm or more, or you have mentioned it is 2 mm even further.
Yes.
So better, still we can go for radiotherapy. Why? Because we can irradiate neck also, okay? And then we can give a more dose, the boost dose to the primary lesion itself, okay? But definitely salvage surgery is an option for us, okay? But if you are opting the surgery, then also for this patient especially, probably we don't need the adjuvant radiotherapy, but we know more failures and we need more surgery and then add radiation. So why is the vice versa? Either you choose surgery first and then post-op RT, or definitive RT and keep salvage surgery for recurrence and then further management. So in both ways for this particular case.
Sir, any comment?
To me, the first question would be, Dr. Milani, how much is the response rate of if we treat with the definitive intent?
Sir, for this case, or even up to 2 centimeter, not beyond 2, and it is N0, obviously. So it is around 80 to 85%. It is not very, although there is no evidence, phase 3 randomized or meta-analysis or level 1 evidence, there is no level 1 evidence.
Yeah.
And sir, why we don't have level 1 evidence? Because in last year, the whole last year or whole last 2 years, we have done only single brachytherapy for a same kind of lesion in the buccal mucosa, not for tongue. So in 2 years, 3 years, only single patient. So how can we gather the evidence? I don't think so. But yes, I agree with sir, no head-to-head comparison. That's true.
Another, I will give it to you then. Another question is, or statement is, that it hinges around the practicality on the surgical aspect. Say, for example, patient receive radiation, and then it is peeling on the arterial side. So reconstruction failures are seen. I mean, there may not be, once again, a level 1 evidence, so cannot say, but practical experience is that after you have irradiated, it is very difficult in our setting to, get the graft working and other things working. And probably, and then we are of the age when we said to radical, it is early, good to be radical early and conservative, probably. Vijay?
for the students, for practical purposes, if you get this case, you have to say surgery. Because practically all early oral cancers are subject to surgery. Because for these patients, surgery is almost more than 95% cure rate. Okay, the sequelae of radiotherapy, the problem with radiotherapy is the sequelae last for lifelong. So they like dry mouth and all those, the loss of taste and all those problems, which is not there in surgery. So early oral cancers, whenever somebody asks you, you have to say surgery. Okay, if the patient is not fit, patient refuses surgery, then you can always refer him for radiotherapy, definitely radiotherapy.
So the main drawback, I think, is radiotherapy side effects: osteoid necrosis, dental problems, trismus. Sir.
If we opt for surgery, there is always chance of we have a treatment left with the radiotherapy, and we can do surgery multiple times, but we can do radiotherapy multiple times in 5 years duration. So if we select for the surgery, we can operate, and if patient is having recurrence, then he can again operate it and given radiotherapy. But if you have already exhausted radiotherapy, you cannot give radiotherapy.
Sir, practically this is very much right, but agar academically we are talking, but I don't want to stretch it further, but just for the academic discussion, अभी जो रेडियोथेरेपी वी आर यूजिंग फॉर एडवांस विद एडवांस टेक्निक्स, तो उसमें जीरोस्टोमिया का सर इतना इशू नहीं है, बिकॉज वी आर डूइंग पैरोटिड स्पेयरिंग एंड ऑल दोज थिंग्स. और जो सर ट्रिस्मस की भी बात है, आई डोंट थिंक दैट इज़ ऑल्सो एप्लीकेबल फॉर दिस पेशेंट बिकॉज इट इज़ टंग और द बकल मिकोसा, where we have to irradiate the whole buccal mucosa. So just for complete discussion.
Okay, that is why I have included both options. In theory, both options are equally acceptable, but practically you have to go for surgery. This is what is usually followed. Okay, if patient refuses, as sir said, if patient refuses surgery or because patient is a very high risk case for GA, then you go for radiotherapy. Now we come to surgery margin. Dr. Ankur, margin. How much margin is sufficient?
So theoretically, we should take 1 centimeter margin, and pathologically it should be 0.5 centimeter. Upon palpation, we remove 1 to 2 centimeter away from the palpated margin, and pathologically it should come 0.5 centimeter. Anywhere it is less than 0.5, then it is said as inadequate margin, a closed margin.
Some surgeons take more than 1 centimeter margin during tongue resection, because when you use cautery, the muscle contracts. So there's difficulty in actually getting exact 1 centimeter margin at least. So they tend to over.
But you then always, before you start the incising it, you can always, or excising it, sorry, you can always mark it first from where you have to. You palpate it. It is still basic basal instincts. You can palpate it, then you can mark from where, which area to which it has to be taken out. And then you go vertically downwards, rather than thinking about shrinking of tumor, other things.
So if you take at least 1 centimeter margin all around, including the deeper part,
Yeah.
and that is why imaging is important.
And that is why the third dimension of tumor, or the depth of invasion, comes into play. You have to think of that as a tumor, and your 1 centimeter margin starts from where you imagine that the depth of invasion is ended, tumor is ended.
So frozen section of margins, is it followed? Frozen section of the margin. So if it is positive, we can do resection same setting.
It can be done, usually not followed, only done where you have a doubt regarding the margins, because tumors are seen in the oral cavity. You can see the tumor, you can see the margins, you can palpate the indolation. So some people recommend it for advanced tumors. For early tumors, it is not required.
So even after taking a 1.5 centimeter margin, if you're getting a margin positive, that signifies a bad tumor biology rather than you under surgery.
Sometimes when we give chemotherapy, we can utilize a frozen section afterwards, because there is a shrinkage of fibrosis. We sometimes cannot see the actual depth or the actual lateral penetration, so we can go for frozen section in that case.
This is important when patient already had chemotherapy elsewhere and it came to you after a few cycles of chemotherapy for surgery. You don't know the exact extent, what the original extent of the tumor.
In that case, you will take if had it been you who started anti-chemotherapy, would you go for new margins, or you would go for the old margins only?
Yes.
During our time, in paper that may have come that you would to take the new margins, or old margins only. But recently I've seen that it started saying you can take the new margin, but depending.
Actually, theoretically you give chemotherapy only for advanced lesions, borderline resectable. So if you had previously if you had margins, you would not have given chemotherapy only. Okay, so you cannot go for the old margins. So what happens when a patient gets chemotherapy outside? You do not know the exact size of the tumor previously. So in those cases, you can do a frozen section also. You can give adjuvant RT also in those cases. Okay. If you are giving chemotherapy, you know the extent of tumor previously. If it is operable, you go upfront and operate. You don't give chemotherapy. If it is not operable, borderline operable, then only you give.
We will go for elective neck dissection.
So for exam purpose, you have to say neck dissection in almost all cases, irrespective of the whether you are able to palpate lymph node or not. In N0, still you have to go for neck dissection because of macroscopic disease possibility. This was
there is microscopic disease, and there is a good amount of clinical evidence in this paper also that survival is also better compared to elective neck dissection versus therapeutic neck dissection.
This was a classical paper from Tata TMH, elective versus therapeutic neck dissection in node negative oral cancer, I think almost done 10 years back. It is very relevant now.
We must say, but sometimes follow-up is an also issue ना in our society. कि patient अभी आया है तो फिर आएगा तभी जब उसका recurrence is so big that you have shown in the previous paper कि now it is not resectable and it is salvageable, मतलब it is out of salvageable. So follow-up is also, so that's why I said कि if patient is agree on close follow-up, then yes, no need of adjuvant radiation. So follow-up is, I mean, must.
So with this histopathology, there is no need for adjuvant radiation. Only one small positive factor is important, LVI is present, but that too, sole LVI positivity is not very important as far as we are planning. So keep this patient on follow-up. Now, adequacy of neck dissection in terms of number of nodes. 60 nodes removed in SND. Is this adequate?
Nearly adequate मान सकते हैं.
Means recent textbook said at least 80 nodes removed, but it is not absolute. So 16 to 80 nodes is okay, I think. This is what recent Devita says. Supraumahid neck dissection should include 18 or more lymph nodes, but somehow 16 to 18 is okay. If you whether the neck dissection is accurate or not.
Actually, this also depends on the pathologist, how many dissects. Okay, yes. The nodes may be more than 16. The pathologist dissected only 16 nodes. So that is also an issue in this.
Should pathology. We dissect and send nodes separately?
No, I don't think it's required, no.
12, 14 is okay, but if it is 0 by 12 or 0 by 14. But if I don't know the surgeon, then probably better to take it as a inadequate clearly and irradiate the neck.
Okay, patient was operated elsewhere. So you will go for radiation. You consider this an inadequate neck dissection. Not this case if there is only 10 nodes removed.
Yes, yes. If I don't know, then yes, definitely.
So it will give benefit of doubt in that situation, I think. Sir, agree, sir, on that? Yes. So adjuvant radiotherapy, we already discussed that there is no need for adjuvant radiotherapy if patient is willing for close follow-up. We'll keep the patient in follow-up. So any role of adjuvant systemic therapy in this case?
There is no role of adjuvant chemotherapy.
So in early oral cancer, systemic therapy have very little role. There is no role of giving chemotherapy or other target therapies. Okay? It is either surgery plus minus radiation. That is the treatment of early oral cancer. Now, before proceed to next case, any questions from audience regarding this case? Any questions, sir? So there is a teeth.
The treatment is complete until you have removed that teeth. The last caries.
Paul, this was the cause of this malignancy, repeated ulceration, because patient was non-tobacco, non-alcoholic.
What he is trying to say that we should remove the get it treated, and sometimes what he was saying that we should go for histopathology, not for scrape cytology and cytology as such. So what will happen if it is reason is removed? Sometimes healing can also be seen, and then obviously you cannot offer patient any other treatment.
Any questions from audience, students? Any question you want to ask about this cancer, this picture? Okay, we proceed to case number 2. A 55-year-old male patient presents with large ulcer proliferating growth in left buccal mucosa involving left lower GBS up to mandible along first premolar to third molar involving skin of cheek. So skin is involved in the surrounding edema and redness of skin. 2 nodes are palpable now, and this patient is known tobacco chewer and alcoholic, and biopsy came out to be squamous cell carcinoma. So this is the picture. Yes, sir. Any, what can we see in this?
This is a locally advanced cancer. Skin is involved, so it is T4. Okay, and there is surrounding edema, and this is which is not good. So after biopsy, I would particularly plan her for neoadjuvant chemotherapy followed by surgery because of surrounding edema, not because of tumor. Surrounding edema. Edema means there is a blockage of the lymphatics, because of which there is edema. That lymphatics cannot be removed. So I would prefer neoadjuvant chemotherapy followed by surgery followed by radiotherapy.
He is trying to say, Professor Vijay Kumar, that when you give chemotherapy, the edema reduces, you get to know what is going to be the exact margin from where you have to take a non-neoplastic 1 or 2 centimeter, 1.5 centimeter margin.
So in workup, like what imaging will require for bone involvement?
CECT should be done for bone involvement, and if possible 3D mandibular reconstruction for the future preservation of bone if required.
CT scan is better for bones. Okay, MRI is good for soft tissues.
Now metastatic workup. Now for metastatic workup, usually you go for CT scan thorax. Would you like to prefer PET CT scan? The most of residents they ask whether to go for PET scan or not.
Not required in oral cancer. It is usually non-metastatic. It is confined up to the neck only. Most of cases.
So in which cases would you like to prefer to go with the PET CT scan?
Any patient with systemic symptoms, bony pain or weight loss, in those patients I would like to go for PET CT or a distant metastatic workup.
Or if there are bulky nodes?
Multiple bulky nodes.
So CT scan shows growth in left buccal mucosa extending into lower GBS abutting mandible with no evidence of bone erosion. Upper GBS is free, RMT is free, tumors involving skin, multiple nodes are present, CT thorax is normal, so it is non-metastatic. So now we come down to this treatment options. Either we go upfront surgery followed by radiation, or we start with the chemotherapy. After response assessment, we go for surgery and then radiation. Sir.
I will go with the second option.
And the reason is same, edema.
Edema. Reason being edema.
So extensive facial edema is a contraindication for surgery. Because when you have a facial edema, actually it opens up the planes and the tumor cells can actually migrate much further than what margin you will take. So
Also good responders to chemotherapy have good prognosis. This is also matters.
So if we have to operate, suppose if we are choosing upfront surgery in some case, what margin will take? Will take margin of the ulcer or the edema portion? Should we include the edema portion if at all?
No, margin of edema is not possible because there is no demarcation of the edema. That's the reason we are giving NSCT. When you go back to the photo, you see there is no demarcation. The edema is stopping here. Okay, see it's a diffuse one. You understand? So there is no margin. There is no margin. If you are operating upfront, you have to take 2 centimeters from the ulcer. That is all you can take.
So edema, it is a blurred basis margin. From where you have to take margins is not clear. So extensive facial edema is a contraindication for upfront surgery.
If there is only induration, then you can go ahead and operate, take the margin from the induration. If there is edema, give NSCT.
Because of chemo response, the edema will resolve and then you can reassess the patient for the surgery. Now for surgery, margins we have discussed, I think mucosa and skin margin both should be at least 1 centimeter, or you will take like a wider margin on skin because there was a previous edema.
Means if you want, you can take 2 centimeter, but 1 centimeter recommended. If because of edema, you can take more than 1.5 or 2 centimeters if possible, where it's possible. Because on face you do not have too much skin or too much tissue where you can go for very wide excision. Okay, so if possible, you can take 1.5 or 2, but 1 is adequate, I think.
Now, bone management. There was no bone erosion on CT scan. So how are you going to manage the bone?
I think I will also take out the bone because of the reason it is in close proximity and difficult to say. On CT scan, you would see that there is no lytic lesion and there is no new peristome formation. It tells us there is involvement of the bone. But even then, if it is not there, segmental resection, heavy mandibulectomy in that particular case would be sufficient. From my point of view, in order to do an R0 resection.
So if cortical erosion is not there, we can go for marginal mandibulectomy, and it is always better to preserve the bone because the function of eating and swallowing is very important for the patient.
I think this patient has a gross paramandibular disease.
Yes. I have to go for segmental resection because of paramandibular disease.
Yeah. And gross paramandibular disease, it is better to go with segmental mandibulectomy. In trying to preserve a border of mandible, you can actually leave a disease behind. So even if there is no bone erosion, if there is gross paramandibular disease, go for segmental. It is preferable to go for segmental mandibulectomy. Okay. Paramandibular means if you can palpate if you see a fullness here, you can palpate disease over the mandible. It is paramandibular disease. So patients operated while local excision with segmental mandibulectomy was done with ipsilateral modified neck dissection. And this is the histopathology. Dr. Minalni, how are you going to depict this?
So skin is involved clearly, so it is qualifying for T4 anyhow, whatever is whatever else. And LVI, PNI, absent, poorly differentiated, one negative factor. DOI to okay, it's more than 2, so still it is T4, not going beyond that obviously. And nodes are positive with ENA, and it's more than 1, so and 3B clearly. So now for me it is T4 and 3B, and most advanced stage except the metastasis. So post-op radiotherapy with concurrent chemotherapy, definitely, no question, no doubt.
So extranodal extension is one of the worst prognostic factor, and when you are giving adjuvant radiation for extranodal spread, you also add chemotherapy to it. So it is chemo radiation, not just plain radiation. T4 and 3B is the highest possible operable stage in the oral cancer. So patient completes adjuvant radiation, is on regular follow-up. Now follow-up imaging. Again, follow-up imaging. When should we do a follow-up imaging and what?
Follow-up imaging for oral cavity usually we don't recommend in our OPD because we believe on the proper clinical examination, oral cavity and for neck. Yes, sometimes people say for second malignancy also, because as time progresses there is a chances to note down the second malignancy. So some people say you have to go for endoscopy, triple endoscopy or imaging for that, but practically we don't.
Okay. There are also chances of second primary in aerodigestive tract, around 4% per year chance of increased malignancy, second malignancy.
One more thing, if you suspect recurrence, then you go for a MRI, not a CT scan. Okay.
And if patient has developed trismus after radiation, then I think it is better to go with imaging because clinical examination then will be inadequate. You are not able to examine properly the oral cavity.
Definitely, if you can't do examination, then definitely.
So if there's no trismus, you can easily examine the oral cavity, your operative site. Then follow-up imaging is not strictly required. But if somehow you are not able to examine, or if there is any suspicious lesion, then you go for imaging first. Now this patient presents after 1.5 years with single 4x4 centimeter fixed node in ipsilateral level 5 neck with a small induration in anterior part of intraoral flap. So now further workup. Patient has a fixed node 4x4 centimeter in level 5. So further workup in this patient.
I'd go for a PET CT followed by an FNAC from the lymph node and a biopsy from the indurated site.
So this patient already had extranodal extension. Now patient again has a fixed node, a recurrence. So it is a very high risk case. Patient could be a metastatic case also. So in this case, I think PET CT scan would be better than CT scan. CT scan can miss some lesions which PET scan will pick up. Is it agreed?
But I mean, it's not straightforward PET CT.
No, it is not mandatory to get a PET CT, but
yeah,
usually what we practice
yes,
is that.
yes, definitely. But the second best option is the local site ka imaging plus thorax ka CT. Because head and neck में metastasis अगर आएगी भी around 15% or so, and that is also in the advance, तो वो 15% में से भी 85 to 90% in lungs and bone, not otherwise. It is, I mean, so.
Yeah, this is right. But it is not mandatory to get a PET CT scan. But there's some scenario where you think that the chances of metastasis are very high. Then probably we do prefer to go with PET CT scan, but it's not mandatory.
No, For
example,
I said PET CT because of staging. This is one of the highest stage where we operated. The stage was stage 4. So that is actually, had it been an early cancer which has recurred, I would not go for PET CT, I would go for local imaging. Okay, so because of the initial stage, I have recommended PET CT. But it is still not mandatory, you can go for a regional imaging also.
It's level 5 neck node. For exam purpose, I think they should say CT thorax first. I think because some examiners may object to that.
Because we have PET CT now in house.
Yeah.
So yes, why not? And CT is,
So in the exam you get a case and similar case, although you won't get any recurrence case, but if asked, you can first go for CT thorax, any suspicious lesion, indeterminate lesion, CT scan, go for PET CT scan. You don't know what the examiner would.
You should go for PET CT thorax and first go only when you are ordering imaging for the neck and oral cavity and face. That is also important क्योंकि आधा अभी लिखेंगे बाद में लिखेंगे. Advanced stage में पहले ही कर लेना है. एक ही imaging में एक ही cycle में हो जाएगा.
If you say PET CT, you have to justify it.
Cost, availability. So investigation reveals no metastasis. So there is local disease, 4 by 4 centimeter fixed node. There is no metastasis visible on PET CT scan. Aim. Now what should be our aim? Will it still be curative or will it put patient on the palliative option? Yes, sir. Patient has no metastasis. There is only local fixed disease.
Look, very difficult to say because the node is fixed. A fixed node means it's inoperable. Okay. And secondly, he has a metastatic disease. So the treatment aim would be curative. The patient may again relapse. Okay. For localized disease where surgery is possible, I would say the aim will be curative, but we cannot rule out palliative treatment.
So this is locally advanced disease.
Actually, this may not be a node. This may be extranodal disease. So the problem is with the extranodal disease. There is no capsule in that.
You cannot resect this fixed node. If the node is fixed, you can't do surgery. You can't achieve a margin in that. So don't go for surgery if there is a fixed node. Okay. Although there is no metastasis, so theoretically our aim will still be curative. Whether we are able to achieve that or not is a different question. Okay. Prognosis in these patients are usually worse. So this is the highest possible stage you have operated, which again recurred with a fixed node. So further treatment option, we cannot operate this case, it is fixed node.
So definitely it is not salvageable. And you said ki still we keep option of curative.
Yes.
But for systemic therapy, chemotherapy, immunotherapy, targeted therapy, I don't think that is curative in any case for solid malignancy without surgery and without adequate dose of radiation. And it relapses after 1.5 years. So we can theoretically opt the re-irradiation. But in this case, as you mentioned, this is the worst tumor biology itself. So what is the purpose of that? That also we should know. And we should understand that. So for me, it is the more towards palliative case, although you haven't mentioned about the patient factor because that is also very important. अदर देन दैट जब आप री आरटी के लिए भेजते हैं तो विदाउट सीइंग द पेशेंट वी कांट से कि वेदर वी कैन डू इट और वी कांट डू इट बिकॉज as in previous case you and sir also mentioned कि radiation always have some long term side effects, so we have to evaluate that कि whether we can do radiation or not. So for me it's more towards palliation than cure.
So these cases, what we aim is that we want a therapy which could actually downstage the node, make it mobile, so that we can again do a resection. That is one remote possibility of cure. If
that is what I said when we was
but this is what we want.
When intention is curative means what I said was if you give systemic therapy or re-radiation, if the node becomes mobile, you can always go in for surgery, and that would be, then it would be a more of a curative setting. If you cannot resect the node, it will go to palliative setting.
So by the response of your chemotherapy, you will decide whether to send the patient for palliative regime, or if it becomes mobile, you can actually have one more shot at curative treatment. So this last case, a 46-year-old male patient presenting with growth in left border of tongue and pain, difficulty in swallowing since 4 months. So he is a known tobacco chewer. On palpation, there is a hard induration in left half of tongue up to midline involving base of tongue. Disease extending to floor of mouth and left tonsillar fossa, and there are few mobile nodes palpable in left 1 and 2. So this is a advanced non-metastatic disease. And this is the imaging MRI. Sir.
Refer to radiotherapy.
So this is obviously a very advanced disease, but it's not a very uncommon scenario. We get these patients because of negligence. They're already having some local treatment elsewhere, and patients often come in this stage. If you see the report, this whenever you see this much big report, you always know that this is a advanced case. You don't even have to read it completely. We come to the opinion quickly regarding treatment. Theoretically, there are 4 options. Either go with chemoradiation, surgery, then upfront radical surgery followed by radiation, chemo, or straightaway put patient on the palliative RT. Theoretically, there are 4 options we have.
So surgery to sir has already ruled out na C option to. But for me it is the first A option is the right for this patient.
Option is correct.
Radiation with concurrent chemotherapy. And probably it is the oropharyngeal primary that is spread anteriorly and posteriorly. एंड बिकॉज बच्चे यहाँ पे हैं तो इसमें सर ने जो फर्स्ट स्लाइड दिखाई थी उसमें एक बहुत ही पर्टिकुलर बोला था सिम्टम दैट इज स्वेलोइंग, पेन इन स्वेलोइंग. तो उधर से समझ में आ रहा है कि इट इज़ नॉट प्राइमरी टंग, इट इज़ BOT probably, and that spreads anteriorly and posteriorly. A very particular sign for oropharynx
Can
malignancy.
anybody tell me why I refer to radiotherapy? Yes, we can give chemotherapy and operate, no? So why did I refer to radiotherapy? So there is a very clear demarcation which you operate, which you don't operate. Oral cancers are operated, oropharyngeal cancers are not operated. Base of tongue, oropharynx, tonsil will always go for radiotherapy. Anything in the oropharynx goes to radiotherapy. Okay, base of tongue goes to radiotherapy. It is not operated. Understand? So this patient was directly referred to radiotherapy without giving any NACT or without trying to perform any surgery.
So if this disease was oral tongue and which secondary spread to the base of tongue,
any base of tongue tumor goes to radiotherapy. Okay? Base tongue, posterior third tongue. Anterior 2/3 we operate, posterior third, and base tongue goes to radiotherapy.
I think there are certain places where people would still like to operate on hypopharyngeal cancer, especially I've seen that certain centers, Pavia Milan also they operate upon. And then posterior third of tongue cancer in specific circumstances where you couldn't take out a given non-neoplastic margin of 1 centimeter. But at the same time, the quality of life is bad in these kind of patients because genoglossus is lost in swallowing and inspiration, a lot of there. So there, it is the benefit and loss analysis would be more important as to what we are giving the patient, whether he agrees to. But then the oral cavity tumors operable, and sometimes you can always do type 3, 2B and 3 resection taking till posterior third of the tongue. But obviously you have to understand that these patients will have repeated aspirations and poor quality of life compared to if you leave them as such.
You can always do a total glossectomy in this patient or a base tongue tumor. The problem is patient aspirates, and some patient have to undergo laryngectomy just to prevent aspiration. So that is very morbid thing which to do. So that is why these patients are referred to radiotherapy. And radiotherapy is quite curative in based on tumors.
Here, if you are talking about oral tongue tumor extending towards little, taking out the third of tumor. So posterior third of tumor, primary tumor, it is good, they are radio responsive tumor. But the situation probably he is talking about is an oral tongue cavity tumor encroaching upon the posterior third of tongue, posterior tongue.
So the
Oropharyngeal malignancies and laryngeal malignancies has the best prognosis. In comparison to the hypopharyngeal one, the worst prognosis, and followed by this oral cavity. Oral cavity में अगर surgery है and did आपने RT किया है, then it's in between somewhere actually. So if it is the case of BOT जो लग रहा है, then it's a different prognosis. But if it is primary tongue and then going downwards, then it is a different prognosis clearly.
So what is the epicenter of disease? Is it an oral cancer spreading into the pharynx, or is it pharyngeal cancer from the very start? Pharyngeal cancer, this oropharyngeal cancer, they are mostly HPV positive, and HPV positive cancer are more likely to respond to radiation chemotherapy. That is why they have a good prognosis, even though there are more chances of neck nodes. Oral cancer spreading into the oropharynx, that is a bad prognosis. That is advanced disease, it is difficult to get a margin. Even if you operate, the morbidity is very high, and chance of recurrence will be very high. So in these cases, I think the best would be refer to radiotherapy for the chemo radiation. But our intent will still be curative, because it is non-metastatic disease.
Intent is curative because even in the T4 stages with N2C stage, there are chances of around 30% somewhere in 30 to 35% in between loco-regional control after giving the full dose of radiation and full dose of concurrent chemotherapy. So I guess 30% is a chance to take for such patients.
30% is a big chance for them, good chance for that, for this type of tumor. Any questions from audience? Any questions from regarding any all three cases? Mostly you get early oral cancer in exams, and that is why it is very important to master the early oral cancer.
After RT, if there is residual tumor or there is a recurrence, the patient may be taken for salvage surgery if salvageable, if operable. Okay. If not operable, then you go for palliative treatment.
In this case, if you're doing salvage surgery, you will also end up doing laryngectomy also.
Yes, definitely. That is what. If operable, you go for surgery. Otherwise, palliative treatment.
Complete response doesn't guarantee that patient has a very good biology disease. Probably he responds well, but he would once again behave badly, probably badly, because oral cavity are aggressive tumors. But nobody knows the real truth.
High-grade tumor often respond very well to the chemo radiation.
Good morning, sir. Sir, you said the maximum possible operable stage for oral cancer is T4 and 3. But you also said that an inoperable, a fixed node makes it inoperable, which would probably signify extranodal extension. So, sir, does that mean that even if one node is fixed, does that make the case inoperable?
Any external extension will be N3B.
I want to mention one thing. इसीलिए जो अभी नया AJCC आया था, उसमें उन्होंने पहले एक्स्ट्रा नोडल एक्सटेंशन नहीं था इससे प्रीवियस क्लासिफिकेशन पे, बट अभी एक्स्ट्रा नोडल एक्सटेंशन को उन्होंने TNM स्टेजिंग में डाल दिया, और एक्स्ट्रा नोडल एक्सटेंशन को सीधा फिर अगर एक नोड से ज़्यादा है या 3 सेंटीमीटर से ज़्यादा है तो वो सीधा N3B में चला गया. सीधा N3B में चला गया तो इट्स जस्ट अ प्रीवियस स्टेज फ्रॉम द M1 डिजीज. ओके, तो दैट मच इट इज़ इम्पॉर्टेंट.
And one more question, sir. You mentioned about marginal mandibulectomy versus segmental mandibulectomy. Is it true that if the tumor is only abutting the mandible, then only we can go for a marginal mandibulectomy? If it is infiltrating, then we have to go for a segmental.
This we can discuss. When to remove the mandible? We have a tumor which is abutting.
Look, infiltrating, you have to remove the mandible. Unless there is mild erosion, there you can go for marginal mandibulectomy. It depends on the amount of paramandibular disease.
You have to understand that you never ligate the pedicle. Don't say it. What you do is that you go on the thyroid gland and then you clip it, ligate it, burn it by biopsy or whatever you do it on the thyroid gland. The chances are that you will save the not only the nerve, ESBL, you will also save the parathyroid gland, artery supply. You can save a lot of many things. So this is part of the technique. So remember why you do it, why you remain close to the superior pole, why you burn the artery right on the thyroid gland. So these are the reasons why you do it, and this is the reason why you should know what is the importance of chlorhexidine. Indications of thyroidectomy, probably you all know: thyrotoxicosis, malignancy, cosmesis, compressive symptoms, redo surgery. These are important terms because in MS examination you would be asked to write. These are important terms. When you remove only a lobe, it is total thyroid lobectomy or lobectomy. When you add isthmus to it, it becomes hemiathyroidectomy. And when you add part of the another contralateral lobe, it becomes Hartley-Dunhill's procedure. And then if you remove total thyroid, it's total thyroidectomy. So it is simple thing. Okay? And hemithyroidectomy to us and probably to you would be one lobe plus isthmus. Why is it you remove the isthmus? Because if undergoes hypertrophy, it will look bad. So we always remove isthmus. And if in a rare circumstances, if the disease is of isthmus, you remove it. Then there is a paper on 10 commandments. You should understand probably there is nothing like 10 commandments, but these are why I do and don't. Just understand that please don't think that if you are if you did in 1 hour, you are the best surgeon in the world. Don't operate by clock. You have to do a good surgery to a patient. A patient with disease is better than a patient without disease, right? If he is dead without disease, bad anyway for a surgeon and his family, and you are going to make him cripple for his whole life. He is going to curse you for his whole life. His whole family, mohalla is going to curse you for whole life. Then the positions are there. The flap, identify the middle thyroid vein, attack one pole at a time. By attacking one pole at a time means that you take care of one pole so that there's not bleeding from all the sides of the thyroid gland. So try to do one pole at a time, superior pole, inferior pole, one at a time. But if you feel there is bleeding, you just put a gauze, pack it, and start doing surgery somewhere else. Then always look for a superior external branch, not ESBL. I don't look for ESBL. There is no recommendation also to look for ESBL, but I always look for recurrent laryngeal nerve. There was a time when people would say don't look for recurrent laryngeal nerve, but please do look for recurrent laryngeal nerve. Also look for parathyroid glands. Very important for survival. In a situation of total thyroidectomy, if all the parathyroid glands are involved, gone, patient becomes a cripple for his whole life, and then very difficult to manage. All right. So this factor of nerve injury we have already mentioned, but you are patient enough, you have been doing surgery for long, you will always remember that you will always try to save the nerve. Position, this is the most common position is extension. There are 2-3 barking doors, rows, and there's one more name I don't know, but what we do is we extend the neck. Then there is a word of caution that if the patient is an old patient or there is preceding history of neck pain, spondylolisthesis, don't extend too much, otherwise patient might develop quadriplegic paralysis, which would be very bad for the surgeon and anesthetist. All right. Then position. Then where the inferior incision is made, incision is made on the at least 2 centimeters above the manubrium sterni or the suprasternal space of buns. 2 to 3 centimeters. Just you can go a few centimeters above and below. Then the anatomies have to be remembered. This is the symphysis mentis. Somewhere here is the hyoid bone, thyroid cartilage, suprasternal space of bun, and this anterior border of sternocleidomastoid muscle. Raise the flap. The flaps are raised subplatysmal. How would you identify platysmal muscle? Platysmal muscle is like peanut butter between two bread. Bread is white color. If it is not atta bread, it is white in color. And when you put in a peanut butter, it is brownish color. It looks like, the moment you see brown platysma, which makes the face taut when you shave your neck, it is a platysma. So you make a plane below the platysma, subplatysmal flaps are made. If you have to cut this in the muscle, you cut it from above because there is ansa cervicalis coming down. So the superior and inferior, where the boundaries of the flap are up to the level of thyroid cartilage, as somebody says up to the level of hyoid bone, and inferiorly up to the level of suprasternal space of buns. Then you enter the, you have made the flap, you see thyroid is enveloped into white. See the one, this one. So we have already talked about inferior thyroid gland, inferior pole has to be done. This is just the picture. You know that superior thyroid glands are more they are derived from third bronchial arch and fourth. They are fourth. So you have to understand which is more stable in position. Tubercle of Zucker candle. Our own pictures. The ESBL spacer breeze. All right. This is the complication. To me, the most important complication is temporary and hypercalcemia, recurrence of injury, and hypercalcemia. After anything beyond 6 months to 1 year, after 1 year, it's permanent. So the most important complications here is injury to these two structures. We should try to avoid it. Wound infection, bleeding, seroma, they're all there. You have to have a very keen eyes. This factor we already talked about. Modalities of energy is all there. My preferential energy source is bipolar forces, and it also forgives you. If you are, say for example, if you are very doing rapidly and were careless also, it forgives you once and twice. But whatever comes in between RT, whatever comes between the harmonic vessel sealer, it is gone forever. Even it doesn't forgive you. Already done that. Yeah. These are all some pictures, right? The canal nerve and carotid. Parathyroid gland once more. Okay. 1 minute video and then I'm done with it. In the meantime, you can ask questions if you wish to. तुम सो रहे हो, उठ जाओ. ये थोड़ा सा जल्दी कर दीजिए राजा. RQ. Help me. इसको आगे ले जाओ. Yes. Right. And there's a very consistent vein. The moment you operate it, it will free the lateral lobe of the thyroid. It will free thyroid. So when you mobilize the thyroid, immediately bring it to the wound, air will fill. It will become, your space will open up. It will give you a lot of space to work upon. चलने दो क्या कर सकते हैं. Video has been shot from above, तो ऐसा लगेगा that you are seeing the inferior pole.
In the meanwhile, if there are any questions,
yeah, we
they
can
can
ask
be
questions,
addressed.
please. कितने मिनट का है वीडियो? Just the laptop has become unresponsive, so you can ask questions if you wish to, or so you just see that it is trying to come into the view, reconnaissance nerve. And if you see it carefully, you will see a toothpaste sign. In our time, there was a toothpaste where on the white strip there would be a red strip of gel. Signal 2 was the name of the toothpaste. It is known as toothpaste sign. So if you put water there, you will be able to see it. Anything with a vasa nervosa or nerve like nerve would have a artery on it, which is vasa nervosa, the nerve of the particular artery. It is known as the toothpaste sign. Just try to save it. Yeah. So don't use any kind of energy. Don't rub it. Don't be very gentle and delicate in handling this nerve. Don't do unnecessary drying, suction, cautery, handling, whatever is there. Huh? Yes. Even when using this kind of energy, there is 2 millimeter of lateralization. So use, if artery nerve is there, you use your thumb, your wet sponge hose, which prevents lateralization type of the nerve. Okay. I'm done. Probably there will be closure of the
Thank you.
camera.
Thank you, sir. And I request all the students to please move for the lunch.
And thank you, Geetika ji, for giving me an opportunity to speak.
Sir, you took 20 minutes.
Yeah, I only took 20 minutes.
Lunch break will be 30 minutes, so please come back in 30 minutes. Sir.
Warm welcome to all. Post lunch, we are starting with the session 4. It's going to be a case presentation on breast cancer. Our presenter is Dr. Shantanu Mishra. He's a junior resident from MGM Aurangabad. I would like to invite esteemed panelists, Dr. Anjali Mishra ma'am, Professor Endocrine Surgery, SGPGI, Dr. Anand Mishra sir, Professor and Head Endocrine Surgery, KGMU, and Dr. Gyan Chand sir, Professor Endocrine Surgery, SGPGI. We welcome you all, sir and ma'am.
Should I start? Good afternoon, everyone. I'll be presenting a case history of a patient, Shobha Bai Kakde. She's a 58-year-old female resident of Buldana, a housemaker, and she belongs to low socioeconomic status class. She came to OPD with chief complaints of a lump in her left breast since 6 months. History of presenting illness. Patient was apparently well 6 months back when she noticed a lump in her left breast, which was insidious in onset, initially smaller in size, which increased to progressively in last 2 months to the current size, and it was not associated with pain. There is no history of fever. There is no history of nipple discharge. There is no history of lump in the other breast. There is no history of weight loss or loss of appetite. There is no history of back pain, breathing difficulty, and abdominal distension. There is also no history of trauma to breast. Past history. There is no history of diabetes, asthma, and tuberculosis. She is a known hypertensive since last 10 years and has been taking regular medications. There is no history of any allergies. Surgical history. There is no history of surgeries in the past. Menstrual history. She attained menarche at age of 12 and she attained menopause at 46 years. She had regular cycles and age at first childbirth 21 years. She's P2L2 A0, both full-term vaginal deliveries, and both children were breastfed until 1.5 years. Personal history. There is no history of smoking or alcohol consumption. She has normal diet and appetite. There is no history of OCPs. There is no history of hormonal replacement therapy. There is no prior radiation exposure. She had normal bladder habits. Family history. She has one brother and one sister, both asymptomatic. There is no similar complaints on the maternal side of the family. There is no history of breast, pancreatic, prostatic, or colorectal cancers in family. Summary. She's a 58-year-old postmenopausal lady presented with chief complaints of lump in her left breast since last 6 months, which progressively increased in size in the last 2 months. Should I go for the examination?
So what is the impression by the history? What do you think it is?
So it is a swelling that has increased in size progressively. So differential diagnosis could be it could be a phyllodes tumor.
Phyllodes tumor. Okay.
Yes.
One. You think first phyllodes tumor.
Yes, sir.
Okay.
And it could be since there's increased progression, so we can think of locally advanced breast cancer.
Breast cancer.
Yes.
Two possibilities. You
Based
all
on
agree
this.
or any other possibility? 5. Yes. Any other possibility? He is saying inflammatory. You are saying fibroadenoma. जो कहना है कहो, कुछ उसमें प्रॉब्लम थोड़ी है. This session is for discussion. हाँ. You think it is fibroadenoma? Okay. So we will Any other possibility? Do we all think any other possibility? Can't it be inflammatory thing? Chronic breast abscess. Okay, one possibility. चलो उसको भी बात करेंगे. Any other thing? Yes, you wanted to say something? Are you aware of any chronic breast conditions?
So it could be chronic granulomatous mastitis.
तुम्हारा है चलो. Chronic granulomatous mastitis. Agreed. So a benign condition, a neoplastic condition, and a cancerous condition. Those all possibilities you have kept. Now we will go first to abscess. Why do you say it is maybe an abscess by this history? First thing, is history complete? You all agree? What are the components of a history in a breast? If a patient gives a history of breast lump, what are the components of a history? Duration, yes, it is there. Lump, it is there. Progression, it is there. Onset is there. Some negative history was there. Why do you take these all negative history?
So to rule out.
Go back. And what is the problem with all these slides? Huh? Any problem? It is all fantastic. All capital good. So slides are always in running font beta. And go to the first slide. Never write the patient name. If you want to write, it has to be just initials. Like SK, female. So patient's identity is very important. Never take patient's name in a presentation. So it has to be a running font, and it is not name, age. Do you write like this? That in your slides? So name has not to be there. Just SK/58/F. That gives all information. So slides are usually in telegraphic language. So you write less and you provide more information. Next slide.
If you're presenting a patient of any breast lump, so that's all right that you presented 50 years old lady. So you can this thing at this point itself you can tell postmenopausal or what was the menopausal status, because it's not, the points are given like we have to take personal history and then past history and then any treatment history. But when you are, that is all right, so that you don't forget those points. But you can this thing make it according to the whatever is relevant to the this patient that can be brought forward. So that is one of the important point. And as Dr. Anand said that you had given all the history, but whenever there is a swelling, don't forget that this is also at the end of the day swelling. So always whatever negative history is there, like whether it started with pain was there, not, and whenever it is in breast, whether any discharge was there, and whether any other skin associated skin changes were there or not. Was it associated with initially with fever or not? Because if you are entertaining history, possibility of chronic breast abscess, unless you take these history, you won't be able to include or exclude, isn't it?
And then a patient of 60 years or 58 years, you don't expect to be menopausal or premenopausal. So okay, yes, right. I don't say it is wrong, but sometimes you need to give it that information. Go next slide. That was your present illness. Now just keep it here. Why do you want to ask these all questions to the patient? Because these questions will give you the answer of a differential diagnosis. Why history of fever? Fever, a number of causes of fever are there. So why in this patient you won't take?
Sir, to rule out tuberculosis of breast.
Tuberculosis of breast. How common it is? First negative history you wanted to rule out tuberculosis.
Abscess.
No. So
Abscess.
any patient of this age presented with lump in the breast, first you have to rule out the breast cancer. So any lump in the elderly, the diagnosis is breast cancer unless it is proved otherwise. So you have to exclude breast cancer first. Okay?
Yes.
Chalo. First, Chalo, nipple discharge.
So we can rule out different pathologies according to the kind of
Nipple discharge,
nipple
okay.
discharges.
Nipple discharge is a part of a detailed history of a patient. No history of lump in other breast, very good question. So at that time you want any no history of weight loss and loss of appetite. Why?
So to
Just
rule
a
out,
constitutional symptoms.
no, sir. Unintentional weight loss. It could be due to CA breast. So
Constitutional symptoms of a malignancy you want
yes,
to
sir,
say. No history of back pain, breathing difficulty, abdominal distension. Why these three constitutions, these three symptoms?
So rule secondaries.
Metastasis in abdomen, okay. No traumatic breast lump. Now, tell me the risk factors for breast cancer.
So
once you know, then only you can ask all history.
So female.
Female.
Being a female, then
elderly age.
Elderly age.
Okay.
Then nulliparity.
Nulliparity.
Then first or second degree relatives having.
That comes into family history.
Then so early menarche.
Early menarche.
Late menopause.
That will come in the reproductive history.
Late menopause.
Late menopause, that will come into that history.
Then.
Huh? Breastfeeding, okay. Breastfeeding history will come that you can just categorize that history in that category, or you can take here history. Okay, breastfeeding is at first childbirth.
Exposure to
I
radiation.
wanted to elicit from you any symptomatology of the patient. Patient has any symptoms, and then he has asked history of nipple discharge, but no history related to any cyclical pain, non-cyclical pain, heaviness. That will give you, what are the risk factors? Dense breast, okay, multiple biopsies, fibroid nova. Those all are also the risk factors. So any procedure, anything, she was totally asymptomatic for 58 years, or she had some symptoms due when she was her breasts were active. Those all symptoms you have to take.
Yes.
Okay.
Yes.
So those only nipple discharge you have taken. Nipple discharge, then cyclical pain, non-cyclical pain, heaviness, those all benign breast history you should take. Any lump coming, disappearing, those all, because that will also give you an idea of the breastfeeding. Why duration of breastfeeding is important? It protects. How, in what ways? Somebody can explain. Can you explain how it protects breast cancer? Give protection to the breast cancer. ओके क्या खड़े होके बता सकते हो? सब लोग देख लें. Lactational amenorrhea, very good. So patient is amenorrheic. There are no cycles. No cycles means no estrogen. No estrogen means the breast cycle is absent. Breast cycle consists of like menstrual cycle. Breast cycle is there. 15 days estrogen, 15 days progesterone. And because of those 15 days, initial 15 days, there is ductal differentiation and then glandular differentiation. So there is a breast cycle also. So absence of breast cycles means there are no changes in the breast at that time. No changes, cyclical changes mean less chances of developing those all cellular things and going into the malignancy thing, hyperplasia and the malignancy. ठीक है? तो इसलिए चलो आगे बढ़ो. So let's discuss a female of 58 years. What are the differential diagnosis of lump in breast? First is probably neoplastic. On second, somebody says, तुमने कहा था chronic granulomatous mastitis. These are the two possibilities. तुमने एक बोल दिया था cystosarcoma. ये किस एज में होता है?
Young, 35 to 40 years.
किस एज में होता है इधर वाले? So it is younger age, not postmenopausal, after 50. So second, third, fourth decade, cystosarcoma. फाइब्रोडनोमा उधर किसी ने बोला था, किस एज में होता है? Younger age. So you don't expect a fibrous adenoma at 6 years. So basically, if I make this diagnosis, I change the age of this patient. I make it 30 years. Now tell me the possibilities.
Fibroadenoma,
Fibroadenoma,
then phylloids,
phylloides, क्योंकि size बढ़ रहा है.
traumatic,
Chronic mastitis. Galactocele, some more history because of lactation you will have, breastfeeding history you will get. That may be
traumatic fat necrosis.
Traumatic fat necrosis, and obviously malignancy. You have to keep a possibility at last. So by the age, I wanted to draw this point because age is very important in a female when you are discussing a breast lump. So by age, something goes up. So if you keep 30 years, so benign causes come first and then malignancy at last. And if age becomes 60 years, one condition benign, otherwise neoplasm. You think of a neoplasm. Okay?
And then you said the history is only of 6 months. Fibroadenomas are very slow growing tumors. Even this thing, the same history is there in young lady, and if that it is very rapidly growing tumor, like Dr. Anand said, maybe you will think fibroadenoma first, but when it is very rapidly growing, then we always keep suspicion of phylloides. Then there comes the suspicion. So it is also important how long is the history, what is the rapidity of growth. Neoplastic lesions are rapidly growing lesions, but had it been a case of 70 or 75, in those cases it would also be a very slow growing tumor. So age is also important. Then what is the duration of lump, and what was this thing, how rapid the growth was. Okay.
Now, two possibilities we have kept: granulomatous mastitis and neoplasm. History of granulomatous mastitis. What type of history do you get? Yes, a lump and it is increasing, slow growing. That may be one history. Other things, sometimes you get in CGM.
Prolonged breastfeeding.
Breastfeeding, it may be associated, it may not be associated. IgM, it will not be associated. Any other history? What type of history? कैसे present करता है granulomatous mastitis? Always a lump?
In OPD. So how does a typical patient present to you? बोलो बच्चे खड़े होके जोर से.
Nipple discharge, yes, maybe. Recurrent abscess, sinuses, erythema, lump waxing and waning. There may be ulcer, non-healing ulcer associated, or just a lump. And then some constitutional symptoms to the patient. Patient may have a fever, patient may have pain local site. So all types of symptoms, whatever symptoms, if you think in a breast disease, nipple discharge, pain, heaviness, lump, ulcer, destruction, all type of symptoms can be there, a part of chronic granulomatous mastitis or idiopathic granulomatous mastitis. In your patient, do you have any symptoms? So only lump. Only lump is a rare possibility, just one symptom in a granulomatous mastitis. So obviously, now your DD change. First, it becomes a neoplastic, probably a neoplastic swelling. And second possibility, so problem in exam is when we ask after history, what is your diagnosis? You straightforward say cancer breast. Take. So don't say what you will say. You will at least say two possibilities. And why not you will say cancer breast? Yes. So cancer is a epithelial diagnosis, pathology. Okay? So always say malignant lesion, neoplastic lesion, mass. Never say carcinoma breast. Trick. You say, then I say further, what are the possibilities? you can say it may possibilities of carcinoma breast because it is most common in breast. We most commonly see epithelial derived malignancies. Okay, so malignant lump, you agree, you all agree we should go for, chalo aage chalo. Family history is important. Why family history? He has taken family history. Yes.
So, so familial or hereditary, we can.
What percentage?
So 5%, 5%.
मुझसे पूछ रहे हो बता रहे हो?
बता.
अच्छा 5%. So 5% of breast cancers are familial, genetic. Familial can be more. They are genetic. Known genetic जो predispositions हैं. और
difference between genetic and familial?
Ma'am,
It could be hereditary and some could be familial.
Ma'am, hereditary are associated with syndromes like Lee-From-Annie syndrome, Cowden syndrome.
Mutation derived,
Mutations.
है ना? And familial could
familial
be
is
that a family shares. There could be some genetic predisposition also, but then they share same environment, same kind of diet, lifestyle, and that predisposes. So there could be clustering of cancers in a particular family. As of now, we don't know exact reason of that, but in future it's quite possible as genetics is evolving, we might be more wiser. So, but we need to know the difference between two. And particularly when you are looking at family history, what is your main concern? Like you said, it is only present in 5% cases. So what specifically you ask the patient?
If there is any history of similar complaints in maternal side of the family.
Okay, so suppose this lady,
just ma'am, it will be always maternal side?
No sir, it could be paternal also if since BRCA2 mutations are associated.
Why you are saying it is maternal always?
So
it has to be in family. You have to take both sides history.
And you said
yeah,
family.
We are
so
more concerned for maternal side.
She is a 58-year-old lady, okay? Suppose she says ki okay, there is a family history, my mother had breast cancer. So then what would be your next question? At
what?
When do you suspect it could be genetic? When it occurs at earlier age in family member, bilateral premenopausal, particularly less than 45 years of age, bilateral tumors. Suppose a mother had cancer at 70 years of age, that could be familial, but that is not pointing towards genetic cause. And if this thing, this any maternal lineage has TNBC, triple negative breast cancer, and not only this thing, these are mainly you are talking about BRCA related. Then you ask for any other malignancy, because in P53 Lee-From-Annie syndrome, so any mother, father, brother, did they have any other malignancy? Yes or no? Okay.
So that brings to me to another question. If a patient has a positive family history, what are more history you will ask? Ma'am has told, just you can somebody summarize, you can summarize.
At what age does onset was?
Number of cancer, what degree relative? First degree relative, second degree relative, in which generation, same generation, above one generation, two generations, age of the patient, then unilateral cancer, bilateral cancer, associated with ovary, any other cancer, and then ma'am has told type of subtype of cancer, if you can get that information. Beyond that, if patient is no more, age at which she expired. Why this? Why subtype? Why we want to know subtype? Why do we want to know age of the patient when she expired?
First of all, do we know how many subtype of cancer do we know of? Do you know? Molecular subtype. एक भी जना खड़े होके बोल दो.
Very good.
Good.
Very
good.
good. Very good. Triple negative. So at your stage, we are very happy if you know these 4 types. So obviously this question I asked, T and BC are more genetic cancers. First answer. Second answer, we wanted to know the age, at what age that in the history patient expired. Because if that is, then from that age, before 10 years less than that, the next, the family has to start screening at that age. Means a patient has expired at 46, so all family members, if you think of a genetic, they have to start screening at least 10 years prior. So 35 years becomes the age. If somebody has expired in the family at 40 years, then 30 years onward, the screening has to be started in the family. Okay? And then number of those malignancies, generation, association with ovarian malignancy, that will give you a clue whether it is a genetic cancer or familial cancer or not. Take. So 2 plus 1 formula, just remember. Mota mota. 2 plus 1. What is 2 plus 1? 2 breast cancer, 1 ovarian cancer. It's important. Okay. No, let's move on. 11 minutes already.
So basic is that on the basis of chief complaint, you make some diagnosis in your mind and then rule out on the basis of history of
Exam.
progenital. So take the negative history to rule out those things. Like you have told that granulomatous mastitis, but once it is asked that why there is a loss of weight and loss of appetite, then you have told only the breast cancer. You have forget the tuberculosis and other granulomatous mastitis. So keep those things in your mind that on the basis of chief complaint, you have made these histories, and while you are taking the history of progenital illness, you are ruling out one by one and narrow down to the 1 or 2 differential diagnosis finally. Okay.
Hurriedly, you complete this general examination. Anything important in general examination?
So no sir, BMI is 24 and she's well built.
So in general examination, you will say that patient has a lump on such and such site, and patient has lymph nodes or not. I will go into the describe it into detail into the local examination.
Yes, sir.
Understand?
Yep.
Okay.
On inspection, patient was examined in sitting position with arms by side, raised above and on pressing over waist and leaning forward position. Right breast and axilla appear normal. In the left breast, fullness is seen in lower outer quadrant that became more prominent on bending forward. Left nipple areolar complex is at lower level as compared to right. There is no nipple retraction, dimpling noted. Left nipple areolar complex appears normal. There is no swelling in axilla or supraclavicular region, and there are no skin changes in both the breasts. On raising both arms above head, left breast moves upward than the right, with left nipple areolar complex displaced upward and outward, and while leaning forward, both breasts fall equally. This is the picture showing lump in the lower outer quadrant of left breast. There's a biopsy done on the lump before, so that is that's not an ulcer. It's of a sign. On palpation, all inspectory findings were confirmed. There is no local rise of temperature. Right breast and axilla is normal. Left breast, there is no tenderness and local rise of temperature. A singular lump of size 4 into 3 centimeters palpable in the left lower outer quadrant involving the nipple areolar complex. It is hard in consistency, non-tender, and it has ill-defined margins, irregular surface. There is no involvement of chest wall, skin, and underlying muscle. There is no nipple retraction and nipple discharge. Swelling of 2 into 2 centimeter is palpable in the left axilla, which is non-tender, mobile, and central group of lymph nodes.
Systemic examination, CVS S1 S2 heard, respiratory bilateral equal entry present, abdomen soft, non-tender, no organomegaly, CNS, no focal neurological deficit present, spine there's no obvious deformities, there's no paraspinal tenderness. On digital rectal examination, findings were normal, and per vaginal examination normal.
Go back. We will come to the diagnosis. So examination become very important in the PG exam at your level. Go back. Okay. So what is the first line written? Patient was examining sitting position. So photo you have shown, patient is sitting in position. And the next line, what is written?
Arms by side.
And go on the picture. Arms are on the side. Go back to your examination. Arms raised above, arms pressing over waist, leaning forward. And then you have written right breast and axilla appears normal. Show me the picture, clinical picture. Am I able to see opposite breast and axilla? So that becomes all, it's a habit of all of you. You see that lump and you write, you assume that everything is normal and you write everything normal in your copy. Now, if you're taking your patient, taking consent, it has both, breast has to be exposed, then only you can compare the both breast, nipple areola. You said moving arms above, next slide. Now how can you examine this? Do this in inspection when patient is wearing the सारे कपड़े पहने हुए सब कुछ ऐसा है. How can you do this?
On after exposure only.
तो कहाँ किया तुमने? किया है? So anyway, that point I wanted to raise. Do the examination proper. Exposure is very important. In a familiar, in a safe environment, take consent, keep a female nurse or your colleague or anybody beside the patient, do examination, a proper examination. Now tell me, he has done so many manuals. Sitting, go back, you examined the patient in sitting, arms raised above, arms pressing over waist, leaning forward. Why these all manuals? Yes, थोड़ा तेज बोलो यार, सब लोग सुन ले. So कैसे पता लगेगा? Fixity, you are saying fixity you want to know. How do you know by these manuals? Fixity of the lamp. So before that, what are the different manuals for inspection and then palpation? Inspection is okay. You do inspection in a sitting position, arms by the side on pressing. And then yes, you ask your patient to raise. And then inspection in any other position or always in sitting position?
Semi-recumbent.
Semi-recumbent position. You have not done that. So semi-recumbent. So why sitting and semi-recumbent? Why not only semi-recumbent? Semi-recumbent mein inframammary you can see. So what's the issue of sitting then? Nipple, ठीक है, very good. So navel of nipple. So I don't know the previous era, but my interpretation of this is breast surgery has become very advanced. You want to see the size of the breast, envelope skin, you want to compare both sides, nipple position, ठीक है? Ptosis, you know the ptosis? So ptosis, it all depends and you can plan your surgery. So because of all these things you can see only in sitting position. You can't see this in recumbent position. The advantage of a recumbent position is you can see complete breast. In sitting position you are not able to see the IMF and lower half of the breast completely. But in recumbent position you see the complete thing. But ptosis and size of the breast interpretation, this will be wrong if you examine only in sitting recumbent position. Okay. Now why these all raised above? Raised above? Why raised above? You want to raise? So when you go back, you ask your patient and see what happens in a normal patient or in a diseased breast. On a normal side, on a disease side. Somebody was saying fixity. So fixity of the lump. So if lump is fixed, it will not move up. The opposite breast will move up when you raise your hand. ठीक है? ऐसे करोगे? So breast will move up. And then if nipple is fixed, nipple retraction becomes more prominent. ठीक? You raise up because nipple is fixed, so it will not move up. So basically nipple retraction. And then arms pressing over waist. This is basically for palpation. By palpation, you want to see the fixity in the direction of the muscles in the chest wall. So pressing over waist is a maneuver for palpation. And most of time you do this palpation examination both in sitting as well as in lying down position. So for inspection, both positions, and for palpation, both positions. Understood? And why sitting only? Sitting will, disadvantage of the sitting, you can't see the lower portion, IMF. IMF is a very important landmark of the breast when you're doing surgery. And sitting position, you can't see the nipple position, you can't see the ptosis, you can't see, assess clearly the size of the breast. These all distances, there are many measurements in the breast when you do conservative surgery. Understood?
I'll just saying whatever Dr. Anand has said. First, so when you would be writing during your practical exam, isn't it?
Yes.
So you won't be providing any photograph there. So whatever you have written, how could you have summarized it better? Just draw a diagram, drawing both breast and axilla. The lump was situated in whatever quadrant, and whatever findings if axilla was palpable. One is that, and then whatever Dr. Anand has said, it has maybe a standard textbook have not incorporated those in detail, because currently the standard of care is breast conserving surgery. So we need to know more about anatomy. What is the volume? What is the ptosis? Whether the inflammatory fold are visible or not. Accordingly, a surgeon would plan what kind of breast conserving surgery has to be done. So maybe at your this thing level that may not be relevant, but try to incorporate that in your practice. And always a picture is worth 1,000 words. Even for exam, even if you have less time, try to draw diagram, figures, tables, and this thing, it speaks a volume about your knowledge, isn't it? And go back to that picture. So what is there in this thing at the waist? Actually, my attention was drawn to that. Something is there. What was there? So somebody is very good. So in examination, you are looking at picture as a whole or patient as a whole. So if fungal infection is there, as a surgeon also you should be concerned. If you are planning a front surgery, maybe then you have to take care of that infection first. So whatever this thing is visible, even if you are not able to make out what exactly is there, you are not able to make out this is fungal infection, but you can say there are rashes over these things. So be truthful in your examination. That is more important. Okay. Okay.
Just go to the palpation. So breast, you imagine the breast as a clock. Always imagine breast as a clock. This is wrong way, outer quadrant. It has to be which clock position? 6 o'clock, 7 o'clock. Tick. Then distance from the nipple areola margin. 3 centimeter from the nipple areola margin. 2 centimeter lump at 6 o'clock, 3 centimeter from the nipple areola margin. Now you know, you can just imagine and you have a picture. A patient has a 4 centimeter lump at 1 o'clock, 2 centimeter, 7 centimeter from the nipple areola complex. That's the purpose of your examination. It can't be so 4 into 3 centimeters single lump in upper outer quadrant. Upper outer quadrant, a small breast, a large breast, you don't, unless you see the picture, you don't have any idea. It's a large breast. Okay? So let's come to the diagnosis. We will take 2-3 minutes. So now your diagnosis is, you have written carcinoma breast. Would you like to change your diagnosis?
Neoplasm.
A breast
Or
lump,
lump
probably
growth.
malignant.
Malignant.
Which side? Side
Left.
has to be there.
Yes.
Left side.
Left side.
There were axilla, lymph nodes.
Palpable.
So palpable axilla lymph nodes. Single, you just described. Now work up.
So triple assessment.
Triple assessment you have done. Don't speak.
Then so we can plan for since we'll have to check for, we'll do the mammography. And
Mammography, so an imaging and mammography.
Yes.
Okay.
And then we'll plan a core biopsy.
Core biopsy. Okay.
And on the basis of that, we can
Two
stage
investigation. Anything else you want to add? Investigation complete कर लेते. You are agree with those two investigation or anything else? Addition or subtraction or change? पर hurriedly बताओ. Metastatic workup अभी कहाँ थे? पहले इसमें primary. अभी तो पहले diagnostic आओ ना.
What about lymph node? You said कि it is N1 on your clinical examination, but your clinical staging includes your radiological workup also. So do you want to do, like just now we were discussing that breast conserving surgery is now the standard of care. What about axilla? So how do you image axilla?
USG. So a mammogram, an ultrasound of the axilla, a core biopsy. Core biopsy, palpatory method or ultrasound guided?
USG.
Preferably ultrasound guided अगर छोटा है, ठीक? 4 centimeter you can do palpatory वो हम लोग सब करते रहते हैं unless you want to target any areas. So core biopsy. Question: why not FNAC? Why core biopsy?
FNAC,
Tissue आता है. You want ISC?
Invasive versus non-invasive.
तो उससे फायदा क्या हो गया?
What is your intent? Diagnosis is written. I would differ there with Dr. Anand ki that you have to say neoplasm. I will say breast cancer because that is the most probable diagnosis. I am not treating this thing. So your diagnosis is written based on mammogram. FNAC would also make a diagnosis. Why do you want core needle biopsy? So why would you plan new adjuvant? This is early breast cancer, T2N1. Yeah, go ahead.
Luminal weather.
तो क्या होगा उससे? Prognosis बाद में पता चलती है क्या फर्क पड़ता?
Subtype ठीक है. Subtype will tell you
Subtype से क्या करोगे?
Subtype will guide. तुम्हारे पीछे बोला. It will guide.
We can plan
planning of treatment. And confirmatory investigation. So can you say 100% sure that it is a malignancy? So it's not a confirmatory investigation. So confirm the diagnosis. Then you go for confirm the sub. That will tell you prognosis and that will help you in planning of the treatment. Planning means surgery or neoadjuvant. What will be the beneficial for the patient? So those all things you can get after the core biopsy. What about axial lymph node? Do you need any investigation to confirm? You can go for a needle aspiration, ultrasound guided needle aspiration to confirm in just a lymph node or it is a metastatic lymph node. So stop.
Oh, I think we can stop.
I think planning of treatment will be some time more. So we have discussed history and examination. Probably any questions to you, we can give, or otherwise we will just close this session. Organizers ने कहा close कर दो इसको.
So the thing, what needs to be probably, that's what initially what Dr. Anand was saying, and this thing I can understand ki at many centers that breast conserving surgery is not being offered, so maybe students are being taught in that way. But currently, wherever even if you read journal or papers, so the standard of care is now lesser is more. Breast conserving surgery, axillary de-escalation. to the extent that we are not doing anything for axilla, for staging also. So unless we know status of axilla, we know whether it is positive or negative, then based on subtype, why subtype is needed? In certain tumors, even if the tumor is early breast cancer, you don't go for surgery, systemic therapy would be offered. So I'm not going into detail. Then the secondary thing is, if you do not know whether this axilla was positive or negative, you won't be able to tell about further therapy or this thing, whether this patient really needs adjuvant therapy or not. Suppose a patient is having luminal type A and axilla is negative. The patient might not need any kind of chemotherapy. But if lymph node is positive, maybe that we don't have time to discuss all this thing, but you need to keep your mind open. And you have to invest more time on examination, and please avoid all cap. Suppose you have written LT, so that is acronym. So I won't be able to make out key this is whether left or LEFT, isn't it? Okay. Good, thank you.
So you have to improve all those slide making. This is all for you. Any questions?
Thank you so much. I would like to invite all the panelists and Gitika ma'am to facilitate the presenter.
Ma'am, the introducer, would you like to introduce yourself once in front of our residents, please?
I'm a localite, but I'm doing my PG from. I'm JR2 in surgery, general surgery in MJ Aurangabad, and I come from Lucknow only, and I was planning for home visit, and this conference came up, so I planned it accordingly.
Our JR3s are going to kill you. Be aware from them. No, faculty. This is for him. So this is from you as a memory of your presentation from KGMU. Thank you, Anjali ma'am. And thank you, Anand Mishra sir. The outsiders, probably you people don't know them much. They are the pioneers and the who is who of breast and endocrine surgery. So they are the people who have started, initiated, and they're leading the Department of Breast and Endocrine Surgery, and it's indeed an honor to learn from these two. So thank you, ma'am. Thank you, sir.
So next we have a panel discussion on thyroid cancer and thyroid diseases, sorry. So our moderator is Dr. Kushagar Gaurav sir, Associate Professor, Surgery, KGMC. We also have in the panelist Dr. Dr. Gyan Chand sir. Sorry, Dr. Sabaratnam sir, Professor, Endocrine Surgery, SGPGI. We have Dr. Abhishek Krishna sir, Assistant Professor, Endocrine Surgery, SGPGI. And we have Dr. Sara ma'am, Assistant Professor, Endocrine Surgery, RML. Thank you.
Since Dr. Gyan is not there, please join us. Ma'am, driver थोड़ा wait कर लेगा, ज़्यादा लंबा नहीं रहेगा. आइए ma'am, please. Ma'am, please.
So welcome on board all the specialists. हाँ जी, पहले एक 3 क्वेश्चंस पब्लिक के लिए, ऑडियंस के लिए, तो प्लीज बी अवेक. ओके, दैट्स गुड. हाँ, मैं फायर करूँगा. देखो पैनल, these are very simple question. I have made them. इसमें knowledge test नहीं करनी है मुझे, ठीक है? I have not testing. They are experts, मतलब and we want you guys to gain something from our experts. तो मैंने questions, I tried my best to make the question जैसे मैं resident था उस time पे, जो मैं सोचता था, जो मेरे दिमाग में आता था, तो क्या doubts रहते एक resident के लिए, ठीक है? मुझे ये नहीं पूछना है कि बेथेस्डा में कौन से लेवल पे एफएनएसी क्या कितने % कैंसर आएगा, नो वो सब थ्योरी हम सब पढ़ चुके हैं, सुबह से पढ़ी रहे हैं, आज बोर हो जाएंगे वो पढ़ेंगे तो, बट सम प्रैक्टिकल टिप्स एंड ट्रिक्स जो हमें एक्सपर्ट से लेनी है, ठीक है? तो आई वुड लाइक कि कुछ भी चीज़ अगर पूछनी है इन बिटवीन द डिस्कशन ऑल्सो, प्लीज रेज योर हैंड, इंट्रोड्यूस योर सेल्फ एंड देन आस्क कि सर प्लीज़ आपने, मैम आपने ऐसा क्यों पूछा, या मैडम आपने क्यों बताया, सर आपने ऐसा क्यों बताया, या ऐसा नहीं तो ऐसा है तो क्यों है, वगैरह वगैरह, ठीक है? तो बी इंटरेक्टिव, टू वे डिस्कशन, तो दैट वुड बी द बेस्ट, फ्रूटफुल वही होगा. ओके, सो कुछ सेक्शंस में है, तो सबसे पहले जस्ट स्पॉट डायग्नोसिस, स्पॉटर क्या है? थायराइड स्वेलिंग तो है, कैसी थायराइड स्वेलिंग, व्हाट वुड बी प्रॉब्लम? डिफ्यूज स्वेलिंग, वेरी गुड. डिफ्यूज स्वेलिंग आज सुबह से किस में पढ़ाई है, किस में होती है डिफ्यूज स्वेलिंग? ग्रेव्स. हाँ, हाइपरथायराइडिज्म कुड बी एनीथिंग. हाइपरथायराइडिज्म तो इट्स अ बायोकेमिकल डायग्नोसिस. हाइपरथायराइडिज्म इज अ बायोकेमिकल डायग्नोसिस. तो अगर डिफ्यूज थायराइड स्वेलिंग विद हाइपरथायराइडिज्म है तो इट वुड बी मोस्ट प्रोबेबली बी ग्रेव्स. गुड. चलो अब अच्छा फायर करना था, सॉरी. ठीक है, अपूर्व. मल्टीनोडुलर गोइटर, गुड. एनीबॉडी who has difference in opinion? कुछ और है? Neck with multiple nodules seen, multinodular goiter, good. Please sit down. हाँ जी, ये क्या है? Solitary nodule, good. ठीक है. So we know difference between what is diffuse swelling is, what is multinodularity, and what is solitary nodules. ठीक है. So this would be to our first panelist, Anjali ma'am. What are the red flags in a history that should raise suspicion for a thyroid malignancy for a PG? Every question and answer is for PGs only.
No, the PGs are future faculty, so
yes, definitely
for
a future faculty.
Okay.
Yes.
So what are the red flags? So for any malignancy, who is more likely to have malignancy, male or female? If a nodule is present in a male, that is more likely to be malignant. But in general, thyroid cancer is more common in females. But when you are dealing with nodule and male is presented to your clinic, so you would be looking more intently. Then at the extreme of ages, either the patient is more than 60, 65 years, or patient in pediatric also, pediatric nodules, more than 1/3 to 1/5 nodules would be harboring malignancy. So if you encounter nodule in a pediatric age group, that is more likely. Then if there is history of any childhood irradiation, or then if that swelling is very rapidly enlarging recently. Remember that thyroid cancer in generally are very slow growing. So even the history of 2 to 3 years would not exclude presence of malignancy unlike other malignancy. But if in that background, if there is a very rapid increase in size, that is always suspicious of malignancy. If you find other nodule or lymph node that would come in the examination, then one of the most important history is presence of change of voice. If patients presents with change of voice of recent onset, that is most sensitive and specific history of presence of thyroid cancer in the present nodule. Then there could be other compressive features as well. And very rarely in our this thing, if maybe down the line 10 to 20 years, a patient of thyroid cancer would present only with as a nodule, as we are detecting nodule earlier, and our general awareness and screening is improving. But patient do also come with, like a patient comes with fracture, patient is having a swelling in neck, and coming from endemic iodine deficient area, patient is likely to have follicular thyroid carcinoma, particularly if the swelling in the bone is kind of pulsatile, because that is a soina phenomenon of metastatic follicular carcinoma. So there are some features, but I will remind you that these features are present in a very minority of the patients. Most of the patient would present with a very simple thyroid nodule. So that's why the history may not exclude malignancy with certainty. But whenever these findings, whatever I have told, then there is very high chance of malignancy.
Ma'am, one more question. In most of the malignancies, solid organ malignancies in body, we, as a resident, quote loss of weight and loss of appetite. Do we see that in thyroid cancer or not?
That is very good question. So we rarely see, as I told you, ki whatever this thing, 7 or 8 points I have mentioned, those are also not present in majority of cases. And rarely any patients of thyroid malignancy present with loss of weight or loss of appetite. Anecdotally, if thyroid cancer is associated with thyrotoxicosis, then those are manifestation of toxicosis, not the malignancy. Then that would be present. But in that case, patient would be having increased appetite but weight loss.
Weight loss. ओके तो ध्यान रखना है लॉस ऑफ वेट लॉस एपेटाइट जो हम लोग ब्लैंकेट की तरह सब मैलिग्नेंसी में डाल देते हैं तो वो थायराइड कैंसर के संग एसोसिएटेड नहीं है सो सबा सर so what examination findings are red flags for thyroid cancer?
See, if you have a hard, irregular thyroid swelling, fixed swelling, then associated with cervical lymphadenopathy, that is a very, very important point, cervical lymphadenopathy. Then rapid increase in a nodule, and then if you have a skin involvement, these are the four most common things. And then absence of carotid pulsation on that sign. You all know berries, 3 berries are there. James Berry is a physician or a surgeon? I'm only supposed to answer, I think. Okay.
No, you can question, sir.
Question them also.
Yes, sir.
Okay. So, 3 berries are there, isn't it? One is berry picking, one is berry sign, and berry's ligament. So, these are common questions. The footnotes of Bailey has. So, whatever I said, hard fixed nodule or a thyroid mass with cervical lymphadenopathy, and then absence of carotid pulse on that side, and very rarely other features are there like this one, like if it is retrosternal, then you will have flushing, signs of retrosternal extensions are there. So did I answer your question?
Yes sir, thank you. अब रेजिडेंट से ये फाइंडिंग्स मिल रही हैं. लेट्स सपोज शॉर्ट हिस्ट्री, जैसे मैडम ने बताया, कोई नोड्यूल है, शॉर्ट हिस्ट्री है, रैपिड प्रोग्रेशन की हिस्ट्री, वॉइस चेंज है, अल्ट्रासाउंड क्लिनिकली हार्ड है, एंड देयर आर लिम्फ नोड्स. तो अब नेक्स्ट स्टेप क्या है? अब इस नेक्स्ट स्टेप में क्या करना है? ओके, और कुछ TSH. ओके, और इमेजिंग में क्या करना है? How many of you guys say CCT should be first imaging investigation? Okay. अच्छा फिक्स नहीं है तो CCT नहीं करना चाहिए? Okay, so we have difference opinion. So our third panelist, Dr. Abhishek. So what should be done first in such a case? If we clinically very hard को suspicion of on history as well as on examination that ये malignancy है, तो क्या हमें अल्ट्रासाउंड CT दोनों करने हैं? कब क्या करना है? और दोनों में क्या रेड फ्लैग्स होने चाहिए?
So the initial investigation for any thyroid swelling is an ultrasound of the neck, because it characterizes the nodule. Like we have BI-RADS characterization for breast lumps, similarly we have TI-RADS characterization for thyroid nodules. So it has 5 components and each one has a score. So I'm not going to tell everything in detail what are the scores, but what are the signs of high risk in ultrasound.
Yeah.
So if a nodule is hypoechoic or very hypoechoic, there are 2 things: hyperechoic, isoechoic, and hypoechoic. Hyperechoic means it has more echogenicity as compared to the surrounding. The nodule has more echogenicity as compared to the surrounding thyroid parenchyma. Isoechoic means same echogenicity, and hypoechoic means it is and specificity. So all these features are there, and of course, yes, taller than wider. So 1 to 5. So thyroids 1 and 2 are mainly benign. 3, 4, 5 mild, moderate, and highly suspicious. So if there is a thyroids 3, 4, or 5 nodule more than 1 centimeter or any size, we need to get a FNAC done for that.
Yeah. And what about CT? When to do a
Yeah,
CT?
CT. So CT has certain indications for in case of thyroid cancer or thyroid nodules. If it's a big thyroid nodule and we are suspecting that it may have a retrosternal extension, so it helps us in planning for the surgery, number one. In cases of thyroid malignancy, if we are suspecting thyroid malignancy, then to look for the nodes and the extent, any extra thyroid extension or surrounding organ tissue involvement, then we need to do that. And yeah,
Definitely. CT is our roadmap to surgery. What? So
barely for surgical planning.
definitely for surgical planning.
But
So,
definitely not the initial investigation.
अल्ट्रासाउंड तो हमें सबसे पहले करना है क्लिनिकली, क्योंकि हमें सस्पिशन हुआ थायराइड कैंसर का, तो हमें सबसे पहला अल्ट्रासाउंड इज लाइक अवर एक्सटेंशन ऑफ अवर क्लिनिकल एग्जामिनेशन. ठीक है, नाउ अब तो ओपीडीज में भी होता है, तो इट इज योर एक्सटेंशन ऑफ योर क्लिनिकल एग्जामिनेशन. एवरी सर्जन शुड डू टू नो टू हाउ टू डू अ अल्ट्रासाउंड, एटलीस्ट सुपरफिशियल ऑर्गन्स का, जैसे कि ब्रेस्ट, थायराइड का, इनका करना आना चाहिए. So it's good to learn when see your faculties doing that ultrasound. So it's good to learn कि कैसे करना है, कब करना है. तो कैरेक्टराइज करना है नोड्यूल को, जैसे डॉक्टर अभिषेक ने बताया, जितना टायराइड्स बढ़ता जाएगा उतना सस्पिशन ऑफ कैंसर बढ़ता जाएगा. एंड सीटी इज अ वेरी गुड क्रॉस सेक्शनल मोडालिटी टू सी एक्स्ट्राथायराइडल एक्सटेंशन, वॉल्यूम ऑफ लिम्फ नोडल बर्डन है कि नहीं है. अगर आरएलएन इन्वॉल्व है, कोई एक्स्ट्राथायराइडल एक्सटेंशन ट्रेकिया इन्वॉल्व है, तो हमारे को क्रॉस सेक्शनल इमेजिंग चाहिए, क्योंकि बिकॉज हमें वो सब रिसेक्ट ऑफ करना है, तो रिसेक्टेबिलिटी देखनी है. ठीक है, कैरोटिड्स कितना इन्वॉल्व है और जो भी क्लिनिकल साइंस से कंफर्म करना. ठीक. सो कमिंग टू अवर नेक्स्ट एक्सपर्ट, as Dr. Abhishek said, FNAC. So how should a resident interpret Bethesda categories in practical surgical decision making?
So as you all already must be knowing, Bethesda is nothing but categorizing the FNAC reports, right? So every category starting from 1 to 6, and I want to reinforce 1 to 6, it's not 0 to 5 or 0 to 6 because काफ़ी बार confusion होता है. So it's 1 to 6 and every category has a risk of malignancy. That is theoretical point. So I think I can ask them question in fact. So I think मेरे बोलने से पहले I would ask you, and I'm sure you would already be knowing, can you tell me Bethesda category 1, which is non-diagnostic, what would you do if a patient comes to you? Repeat. You won't keep the patient on follow-up. You will do a repeat FNAC. Why? Because the risk of malignancy in this particular category is 1 to 4%. So we cannot miss a malignancy, right? So we need to repeat the FNAC. So that is good, done. Second category is, Bethesda 2 is benign. So benign mein, what would you do? If the patient has symptoms of compression or has the nodule is very big and is causing cosmetic problem, in that situation you can take the patient up for surgery. Or if the nodule is small, you can keep the patient on observation. 6 monthly to yearly, you can do ultrasound and you can see for the trend of increase in the size. Third option, which is an updated option, जो अभी फिलहाल guideline में नहीं आया है, but what we can do is we can do ablation of the thyroid nodule, microwave ablation or radio frequency ablation. The nodule is small in size. Then coming to category 3 and 4, which is ATP of undetermined significance and follicular neoplasm. Now here the risk of malignancy increases, 10 to 15% and 15 to 30% respectively. So in this situation, we have two options. The first is we need to take up the patient for a lobectomy. After lobectomy, the final biopsy will tell you what kind of a lesion it is, whether it is malignant or whether it is benign. If it is malignant, but size is less than 4 centimeters, there is no, there is a favorable histology, right? It's just a differentiated thyroid cancer. There is no family history of malignancy, no other extrathyroidal extension. In situation mein you can let the patient be. You just do a lobectomy and you just keep the patient on follow-up. But if the nodule size is more than 4 centimeters, if there is unfavorable histology, If there is extrathyroidal extension, in that situation, you'll have to take up the patient for a second surgery, which is completion thyroidectomy, right? और second option होता है जो आजकल आपने सुना होगा molecular testing. So that is just an adjunct. Molecular testing usually हम अपने patients में नहीं कर पाते because financial constraints होती हैं. But if a patient is undergoing molecular testing from the FNAC aspirate and there is presence of unfavorable mutations like TERT, OP53 or RET PTC or BRAF, in that situation, you will take up the patient for surgery. You can counsel them and you can tell कि ये high risk features हैं, we can go ahead and remove the total thyroid rather than doing a lobectomy. But that is, the patient has to be informed, has to be counseled, right? Coming to category 5 and 6. That is, 5 is suspicious of malignancy and 6 is malignancy. So no doubt you will have to take the patient for surgery, right?
So अब हमें FNAC में let's suppose कैटेगरी 5 या कैटेगरी 6 आ गया, ठीक है? तो अब कौन सी सर्जरी करनी है? हेमीथायरेक्टमी, लोबेक्टमी, सब टोटल थायरेक्टमी, नियर टोटल थायरेक्टमी, टोटल थायरेक्टमी? अच्छा, how many of guys say total थायरेक्टमी? Category 5 or category 6? Total thyroidectomy, how many of you guys say कि treatment, surgical treatment is total thyroidectomy? Single lobe involvement, 4 centimeter swelling. How many of you guys say subtotal thyroidectomy? कोई कुछ बोल ही नहीं रहा यार. Near total. So coming back to our experts, ma'am, so please guide us. अगर let's suppose category 5 or category 6 है, so what is the optimal treatment for, like they are confused between near total, when to do a near total thyroidectomy? What is the ideal treatment for a thyroid cancer and when to do a near total, specifically near total thyroidectomy?
So this is a very simple question. At the same time, it's the most difficult question. Why? So why do we not want to preserve thyroid? And who said total thyroidectomy? No one's near total?
नहीं बोला था, 2-3 लोगों ने बोला था, फुसफुसा के बोला था.
Who said?
नहीं देखो एग्जामिनर पूछता है तो कई बार तारीफ करने के लिए भी पूछता है, ऐसी बात नहीं है.
नहीं, हेमीथायरेक्टमी कौन करवा रहा है? Why? बताओ ना.
देखो कुछ भी बताओ, जब तक गलती यहाँ नहीं करोगे ना फिर एग्जाम में गलती करोगे.
This is not the question of गलती. What I am trying कि you understand कि whatever I am doing, why I am doing so. But it should be, patient तो बनाएगा informed एक decision, but you need to give patients fact. So why do you want to do hemi? Why not total? Just get rid of cancer in one go. What is the problem? What kind of cancer is thyroid cancer? Suppose a patient is having breast cancer and one patient is having thyroid cancer, and or I would ask you to choose between one that you would have a cancer, which one would you choose? Thyroid or breast? Anyone? खड़े हो? बताइए.
Please
but
बताओ ना,
अच्छा,
जो
okay,
बोल रहे हैं.
I will rephrase the question. I'm very difficult examiner. Till you answer, I will not stop. So, what is the fear of having cancer? Why do we fear cancer? ये तो बहुत simple question है ना? बताओ जो. बताओ बच्चे बताओ.
कैंसर में क्या होता है, क्या डर लगता है कैंसर का नाम सुन के लोग डर क्यों जाते हैं?
So, have you seen any patients of thyroid cancer during your residency? कितने देखे? Okay, so I will ask you, what is 5-year survival rate of thyroid cancer? Any idea? Any of आप लोग कौन से ईयर के हो? फर्स्ट ईयर, सेकंड ईयर, थर्ड ईयर? थर्ड ईयर के कितने बच्चे हैं? हाथ उठाओ. Okay, So now you people must have heard about low risk and high risk category of thyroid cancer. What is that? So, and what risk we are talking of? So basically, whenever this thing cancer is there, the first, what is our this thing treatment goal, that we want to cure the patient, but it is not possible in majority of with majority of cancer. If not cure, then what do we want to do? We want to improve disease-free survival rate, or we want to bring down the recurrence-free survival rate. So thyroid cancer, but thyroid cancer is not one cancer. It's kind of heterogeneous cancer. And whenever we are talking and mind it, whenever you are reading book, whosoever is a Western author, that person would be writing in reference to papillary thyroid cancer. Papillary thyroid carcinomas are very indolent thyroid cancer. The risk of dying with papillary thyroid cancer in low risk category is very low. 20-year mortality is only 2%. Okay, so if this thing, a 20-year mortality is only 2%, and if a patient is having only one side cancer, why to remove whole thyroid gland? Once I take out the whole thyroid gland, the patient has to be lifelong on thyroxine supplement. Then there is risk of permanent hypoparathyroidism also, and recurrent palsy maybe, if it is not unilateral, bilateral would be there, but that is anecdotal. So therefore, this thing currently majority of the guidelines say, and the another thing is, why guidelines? Why not RCT? Nowadays, whatever we do evidence-based surgery. So what is evidence? What is level 1 evidence? And from where it comes? Have you heard of, again third year, what is this thing level 1 evidence? Level 1, level 2, have you heard about level 1, 2 evidence? And then we have grade of recommendation. What is this? Level 1 evidence. Have you heard of randomized control trials, meta-analysis? So what is that? अरे बताओ बच्चे, तुम तो फिर गीति का बहुत नाराज होने वाली है. Is she not one of the examiner or Dr. Kushak? So our evidence, so whenever we want to prove or disprove, we conduct trials. And then one arm has one kind of treatment, another arm had another kind of treatment. For thyroid cancer, it should be total versus hemithyroidectomy. Then we follow up the patient, and then what would be the endpoint? Mortality. But it is easier to conduct such trial in gallbladder cancer, esophageal cancer, because unfortunately or unfortunately, patient is likely to succumb in coming 6 months. But it's difficult in thyroid because majority of patients are going to live beyond us, at least beyond my age. 20 years mortality if it is only 2%. So there is no level 1 evidence so far as treatment options in papillary thyroid cancer is concerned. So majority of the guideline would say ki if it is less than 4 centimeter tumor, totally intrathyroidal, it is not aggressive type, no extrathyroidal extension, no lymph node, maybe we can get away with hemithyroidectomy. Hemithyroidectomy would be preferred option. I'm not saying it is the option, it is preferred option. The reason being is patient would be this thing spared of lifelong thyroxine supplement and other complication. But the hindsight of it would be that in remaining lobe, there could be a recurrence because these tumors are known to be multicentric. But whenever it comes, you can deal it with later. So this is just to give you background, because whenever you this thing, just don't cram up anything. Why it is being said, there has to be some basis of it. So, but for your examination purpose, small intrathyroidal papillary thyroid carcinoma, for that matter, only minimal invasive capsular follicular thyroid carcinoma also should be dealt with only with hemithyroidectomy. And if there are aggressive features, then total thyroidectomy. If lymph nodes are involved, then so far as lateral compartment are concerned, whichever side lymph node is involved, that side dissection is done. Central compartment is, I think we would be discussing about that later on. That is a different ball game together. Usually we don't go for prophylactic central compartment dissection. Therapeutic is yes. But if the tumor is more than 4 centimeter having extrathyroidal extension, so in that case, along with total thyroidectomy, you would be doing prophylactic central compartment dissection as well. But all these are recommendations and guidelines, mind it. And our Indian guidelines are to be slightly different, because I am compiling that document, so it's my duty to put forward that disclaimer.
Kushagra, shall I?
Yeah, please.
See, ma'am said she's my teacher also. Like a difficult exam. I'm a very easy examiner. So if you ask me if this question comes to you in the exam, you have to answer in a very like madam said, very small, less than 2 centimeter hemithyroidectomy, and if at all, some institutions and some places total thyroidectomy is also there. So whatever institute you are coming from, as an institute policy, if they are doing total thyroidectomy, that is acceptable. सब ब्लेम हम ही अपना ऊपर नहीं लेना है, कुछ ब्लेम इंस्टीट्यूट के ऊपर, डिपार्टमेंट के ऊपर भी डालना है. क्यों टोटल थायराइडेक्टमी करते हैं? हमारा डिपार्टमेंट में होता है सर, वो पॉलिसी है, हम करते हैं. सो एक्चुअली वो भी इम्पोर्टेंट है. सो मोस्ट ऑफ द टाइम्स प्रीवियस एंड नियर टोटल, when you do not have the expertise, KGMC में तो expertise है, so total thyroidectomy करें. near total और sub total expertise कहाँ पे नहीं है, complication कम करने के लिए वो करते हैं. That's not wrong. So it depends on various modalities are there: hemithyroidectomy, subtotal, near total, and total thyroidectomy. Most of the times, most examiners are happy with the answer of total thyroidectomy, except in very few cases where you will do a hemithyroidectomy.
Okay, up to 2 centimeter hemi, no one is going to contest. 2 to 4 centimeter hemi is what I said, preferable option. Preferable means it is not the option. So that means other option is there. So at the end of the day, then how do you decide? Even like just prior to this, we were discussing breast cancer. So in breast cancer, like I said, standard of care is everywhere, less is more. But at the end of the day, it is shared decision. First, though, whether a patient is candidate for that thing, and now you have to discuss everything with the patient, giving them fact. So how are you going to give them fact? First, you have to read them. So then you discuss these are pros and cons. So what would be, and this is the literature, and what would you like to have? Okay. And as Dr. Sabha said, this is practical exam. So in practical exam, be practical, don't be theoretical. So all examiners, whosoever examiners can be good or bad. No, students are good or bad. Usually examiners are good. Okay, so they like it. But at the end of the day, you are going to be a practicing surgeon. So you should be think in that direction and from that point of view. Because somebody else's life is in your hand. So always be this thing, be kind of responsible for this, read, study, and you have such a wonderful teachers. And always discuss, don't hesitate to ask question. My only submission with current generation is, I don't know, why don't you people ask question?
Just want to narrate you a scenario from the recent examination that concluded, ma'am. So this examiner, this was a case of thyroid, I don't know, solitary or multinodular, what was it, don't remember. So the examiner asked the student, what is the ultrasound finding, what should be the ultrasound finding if you're suspecting a malignancy in this patient? So the student said, sir, thyroids. And then he said, okay, what is thyroids? Then no answer. And then he said, what is the FNA finding? He said, sir, birads. Sorry, Bethesda. And then what is Bethesda? I was not really knowing about it much. So I think they should be taught only what is the basics so that they can at least say that to the examiner.
That's why Dr. Sarah said it's categorization. Ultimately, what it is telling you, probability of malignancy. It could be any system, but we should be knowing like, okay, if it is irregular, maybe thyroid is also not a uniform system. There is Korean thyroid, then this is thyroid, so there would be slight difference. But you should be knowing what is the basis. A malignant nodule is likely to be irregular, it is likely to contain microcalcification, if lymph nodes are there, there is no doubt it is malignant. Okay, if extrathyroidal invasion is there, no doubt. It is likely 99.9% it is likely to be malignant, only some would be radial thyroiditis, isn't it?
ओके तो समझ में आया टोटल थायरॉइडेक्टमी बोलना सेफ है ओल्ड एग्जामिनर हो तो बट यू कैन ऑलरेडी से कि अगर एग्जामिनर की भ्रुकुटी तन गई है सर हेमीथायरेक्टमी सेलेक्टेड केसेस, तो जैसे मैडम ने बताया छोटा इंट्राकैप्सुलर नोड्यूल है, सेफ है, कोई एक्सटर्नल एक्सटेंशन नहीं वगैरह वगैरह, मेनी टिप्स एंड ट्रिक्स, अगर वो नहीं है तो हम हेमीथायरेक्टमी करना सेफ है, अदरवाइज सेफेस्ट आंसर इज टोटल थायरेक्टमी. ओके, quick question to Dr. Abhishek, please be crisp. What are the practical tips to preserve parathyroids? How to identify them first of all, and how to preserve them?
Yes.
As a PG resident, what should be aware of? How to identify?
Before answering this question, I want to ask, how many parathyroids do we have? 4. अरे 2 + 4 ही होता है यार. अब वो बोलोगे 5 - 1
कुछ प्रीफिक्स और
मतलब 4 ही होता है, सब में 4 होता है. किसी में 2 नहीं हो सकता है, या किसी में 10 नहीं हो सकता है. पैराथायराइड कहाँ मिलता है? व्हाट्स द लोकेशन? मतलब थायराइड के बगल में, बेसिकली थायराइड के पीछे, बगल में, आगे, आजू बाजू, मतलब कहीं मिल सकता है. तो 2 ऊपर 2 नीचे. और थाइमस में होगा तो थाइमस यू नो थाइमस में हो सकता है पैराथायराइड. सो देयर कैन बी मोर देन 4 पैराथायराइड्स. दैट इज व्हाट आई वांट टू से. जरूरी नहीं है 4 ही हो, ठीक है. So parathyroid identification, the best identification for a parathyroid is a surgeon. Is an experienced surgeon. Not color, not fat. If you're an experienced surgeon, you can identify that. An experience आएगा सर्जरी करने से. सर्जरी कब करोगे? जब एंडोक्राइन सर्जरी में आओगे. I know, sorry. चलो anyways. So पैराथायराइड्स आर किस कलर का होता है? क्या बोलते हैं? डस्की ब्राउन, ब्राउनिश विद अ फैट पैड अराउंड इट. जनरली फैट में वो एम्बेडेड रहता है विद अ वैस्कुलर सप्लाई. सो टू आइडेंटिफाई, एज आई टोल्ड यू, वी नीड टू बी केयरफुल अबाउट द लोकेशन कि सुपीरियर का लोकेशन कहाँ है, इन्फीरियर का. सो मोस्ट ऑफ द सुपीरियर पैराथायराइड का लोकेशन कहाँ है? अराउंड 2 centimeter diameter at the junction of RLN and RLN is recurrent laryngeal nerve and the inferior thyroid artery. Superior parathyroid इसी एरिया में जनरली मिलता है. बट दिस इज द नॉर्मल लोकेशन. अगर ग्लैंड बढ़ गया, मल्टीनोडुलर गोइटर बहुत बड़ा है, तो एवरीथिंग चेंजेस, द एनाटॉमी चेंजेस. सो इसीलिए दैट्स व्हाई आई टोल्ड कि एक्सपीरियंस सर्जन इज द मोस्ट इंपॉर्टेंट फैक्टर फॉर आइडेंटिफाइंग अ पैराथायराइड. सिमिलरली इन्फीरियर जो है वो इन्फीरियर पैराथायराइड जस्ट नियर द इन्फीरियर पोल ऑफ द thyroid, generally most 60-65%. So the most obviously you have to identify them first. Preserve करने के लिए identify करना ज़रूरी है, and identify करने के बाद उसका vascular supply preserve करना ज़रूरी है. तो there is something called as capsular dissection. Thyroid के ऊपर कैप्सूल होता है, तो we have to hug that capsule.
And this is the catheter. ये कीमोपोर्ट है, and हाँ ये कैथेटर है. So अल्ट्रासाउंड गाइडेड हमने IJV आइडेंटिफाई कर ली. ये जो पल्सेट करी है क्या है? नेक में कैरोटिड. यस, गुड, कैरोटिड है. आगे होती है हमारी इंटरनल जुगुलर वेन. हमने लोकल आइडेंटिफाई कर लिया. इंटरनल जुगुलर वेन कंप्रेसिबल होती है, ठीक. तो जब भी हम प्रेस करेंगे अल्ट्रासाउंड से तो कंप्रेस कर सकते हैं. तो अल्ट्रासाउंड गाइडेड हमने पंचर लिया लोकल लगा के एंड नेगेटिव बना के, ठीक है. ये हम पंचर कर रहे हैं अल्ट्रासाउंड की मदद से. यू कैन सी ये नीडल आ रही है, यहाँ कैरोटिड है. सो वी वांट टू पंचर हेयर. यस, रेड एरो आ रहा है. सो नेगेटिव प्रेशर्स के संग वंस यू पंचर यू कैन सी डार्क कलर्ड ब्लड उसके अंदर आएगा. जैसे ही आएगा हमने सिरिंज हटा के गाइड वायर डाल दिया. गाइड वायर हमारे संग हमारे उस आर्मेंटेरियम में हमें मिलेगा, किट में मिलेगा. गाइड वायर डाल दिया. देन ऑन सी आर्म यू कैन सी कि गाइड वायर हमारा पूरा नीचे तक चला गया है. फिर हल्का सा डायलेट करेंगे स्किन इंसिजन एंड दिस इज डायलेटर, टनलर एंड नॉट टनलर, दिस इज डायलेटर. इसकी एक शीथ होती है. तो डायलेटर से हम सबक्यूटेनियस टिश्यू तक डायलेट करते हैं ट्रैक्ट. गाइड वेयर पर रेलोड किया एंड जेंटली पुश किया तो आईजेवी तक वो हम डायलेट करते हैं. एंड देन उसको टनलर पे लोड, शीथ पे लोड किया एंड शीथ को पूरा अंदर तक पुश कर देते हैं. ये जो ग्रे कलर की शीट है वो अंदर पुश कर रहे हैं. साइमल्टेनियसली वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द टनलर. वी आर विड्रॉइंग द गाइड वायर एंड द ट द शेथ, या ये हमने बाहर वाइट वाला पार्ट विड्रॉ कर लिया। इसके बाद अब ये पोर्ट है, पोर्ट का कैथेटर जो कि हम डाल रहे हैं, ये सारा आईजेवी के अंदर है। ओके, ये यहाँ से यहाँ जा रहा है कैथेटर, ठीक है। और हम अब कैथेटर डाल के अब इस शीट को भी विड्रॉ कर लेंगे। कैथेटर को पकड़ के रखना है कि सिस्टम में ना चला जाए एंड बाहर भी ना स्लिप हो। सो एटलीस्ट 15-20 सेंटीमीटर डाल के हम लोग विड्रॉ कर लेते हैं एंड इसको कट करके भी निकाल सकते हैं, जस्ट जेंटली पुल करके भी निकाल सकते हैं, वो पुल हो जाएगा। एंड इस तरह से हमने शीट को निकाल लिया एंड कैथेटर हमारा वीनस एक्सेस सिस्टम में है। उसके बाद हम लोकलाइज करेंगे लेटरल पार्ट, सेकेंड रिब का लेटरल मोस्ट पार्ट जहां पर हम कीमोपोर्ट को फिक्स करते हैं। ये हमने सियाम लगा हुआ है, सियाम में देख लिया, वहां पे भी ऑब्वियसली लोकल लगा दिया और लोकल वहां से लेके पूरा ट्रैक जहां तक हमने पंचर किया था वहां पूरे ट्रैक में लोकल लगाते हैं। वी शुड हैव, वी मेक अ पॉकेट जिसमें हम कीमपोर्ट लगाएंगे। इट शुड बी लार्ज इनफ कि हमारा कीमपोर्ट फिक्स हो जाए, इट शुड नॉट बी वेरी स्मॉल इनफ कि हमारा कीमपोर्ट घुस ना पाए, इतनी बड़ी भी ना हो कि उसमें फ्रीली मूव करे। तो इट शुड स्नगली फिट इन द कीमोपोर्ट, इन द पॉकेट। ये पॉकेट हमने बना ली, फिंगर्स डाल के उसे ब्रॉडन कर लिया। ये कीमपोर्ट हम इसमें लगा के देख रहे हैं कि जेंटली वो आराम से बैठ गया, फ्रीली मूव नहीं करना चाहिए, इट शुड स्नगली फिट। एंड दिस इज व्हाट अ टनलर है। स्टील का डिवाइस होता है, स्टील का रॉड होता है जो यहां से लेकर हम लोग जहां हमारा इंसिजन था उसके पास में निकालेंगे हम इसको। ये हमारा कैथेटर था, ये हमने पंचर लिया है, तो यहां से लेके निकालेंगे। और इसके बाद हम ये देखो, ये मैं पॉज कर रहा हूं, ये जो एरो है ये लेड टिप होता है। कैथेटर में सबसे आगे लेड टिप होता है, ठीक है, क्योंकि कैथेटर फ्रीली है, जब मतलब हार्ट की बीटिंग के संग वो हिलता है, तो हमको ये एसवीसी और राइट एट्रियम के जंक्शन पे रखना है। जितना राइट एट्रियम के अंदर होगा तो ऐसे नोड को इरिटेट करेगा एंड एरिथमियास कर सकता है एंड उस पर थ्रोम्बस बन सकता है। तो हमें उस लेवल पे रखना है एसवीसी और राइट एट्रियम के जंक्शन पे। तो इट शुड नॉट बी इन एसवीसी बिकॉज वहां थ्रोम्बोसिस कर देगा। तो आइडियली इट शुड बी, इट कम्स बिटवीन 10 to 12 सेंटीमीटर। राइट साइड पे लेते हैं तो डायरेक्ट एसवीसी में आ जाते हैं, तो रफली 9 to 10 सेंटीमीटर। इधर रहते हैं तो बिटवीन 10 to समटाइम 11 समटाइम 12 डिपेंडिंग ऑन द ओबेसिटी ऑफ द पेशेंट, लेंथ ऑफ द पेशेंट, उस पर डिफर करता है। तो हमें फ्लोरेसेंस, कंटिन्यूस फ्लोरेसेंस में देखना है कि ये जहां बीट कर रहा है इट शुड बी एट द जंक्शन ऑफ, इस पे मार्किंग बनी होती है कैथेटर, विल सी कैथेटर मार्किंग बनी है। तो जो मैं 10 सेंटीमीटर की बात कर रहा हूँ, कैथेटर की मार्किंग उतनी होनी चाहिए और इसमें फंसा के हम कैथेटर को, बाकी एक्सेस कैथेटर को निकाल लेते हैं। वी जस्ट पुट अ गाइड वायर सो दैट कैथेटर को हम अपने होल्ड में अभी रख सकें और एक्स्ट्रा कैथेटर को काट देंगे। ये देखो टिप 1-1 सेंटीमीटर पर मार्किंग बनी हुई है एंड एक्स्ट्रा कैथेटर जो है वो हम कट करके हटा देंगे। ये एक ग्लास का नॉब होता है, इसमें एक ब्लैक पोर्शन है, ब्लैक टुवर्ड्स बॉडी, एंड ये पुट करके हम कैथेटर को इस कीमपोर्ट पर चढ़ाएंगे और उसके बाद उस ग्लास नॉब को इसके ऊपर चढ़ा देंगे जिससे कि एक्स्ट्रावेसेशन, ये हम ग्लास नॉब को उसके ऊपर चढ़ा रहे हैं जिससे कि एक्स्ट्रावेसेशन हमारा नहीं होगा। ये ग्लास नॉब को हम पुश कर रहे हैं उसके ऊपर जिससे कि पूरा कैथेटर अलोंग द कीमपोर्ट चढ़ जाए। एंड देन कंफर्मेशन कैसे करते हैं हम, एस्पिरेट करके ब्लड आ गया एंड फ्रीली जब जा रहा है पुश कर रहे हैं सलाइन, हेपारनाइज सलाइन पुश करना है, हेपारनाइज सलाइन में ही एस्पिरेट करना है, हेपारनाइज सलाइन में ही पुश करना है। एंड जब वंस इट इज कंफर्म्ड कि कंफर्टेबली जा रहा है तो आराम से हम लोग प्लेस करके इसको फिक्स कर देते हैं। सो दिस इज हाउ बेसिकली 2 पॉइंट फिक्सिंग भी होता है, 3 पॉइंट फिक्सिंग भी होता है। विल सी कि क्या चीज होती है एंड फिक्स करके सबक्यूटिकली हम क्लोजर कर देते हैं। सो दैट इज हाउ इट इज डन। किसी प्रोसीजर के लिए आई नो दिस इज अ वेरी इजी थिंग कि दिखाना बहुत आसान होता है, प्रैक्टिकली करना मुश्किल होता है। सो लेट्स मूव टू स्किल लैब जहां हमारे पास मैनिक्विन है और हम कीमपोर्ट का क्या क्या पार्ट्स होते हैं वो देखेंगे, ठीक है। तो आई थिंक क्योंकि बच्चे ज़्यादा हैं तो अगर हम 2 ग्रुप्स में बढ़ जाएंगे तो आसान रहेगा। तो एक ग्रुप में मतलब वी हैव मैनिक्विन जिस पे केवल सरफेस मार्किंग दिखानी है, जस्ट प्रोसीजर बताना है, मतलब कि कहाँ से डालना होता है, सब करना होता है। एंड दूसरा 15 का एक ग्रुप, ओके 15 ईच, ओके वी कैन मतलब इधर वाले एक ग्रुप 1 एंड ग्रुप 2, तो वी हैव 2 मैनिक्विन्स देयर। तो एक मतलब मैनिक्विन एक ही है, उस पर ग्रुप 1 आ जाएगा, उनको हम बता देंगे। एंड ग्रुप 2 मीनवाइल ग्रुप 2 को हम लोग विल मेक हमारी दूसरे जहाँ पर साइमल्टेनियसली कीबोर्ड पड़ा हुआ है तो कैसा फील होता है, जब हम उसे पंचर करते हैं तो कैसा फील होता है, तो वो यू कैन डू दैट, देन वी कैन स्विच अगेन, ठीक है। ग्रुप 1 ग्रुप 2 की जगह ले लेगा, ग्रुप 2 ग्रुप 1 की जगह ले लेगा, ठीक है। तो लेट्स मूव टू स्किल लैब। स्किल लैब यहाँ से आके जो खाना पड़ा था, खाने से पहले ही लेफ्ट साइड में, सॉरी राइट साइड में था स्किल लैब। थैंक यू।